Right side.
Niranjan, we are already live on YouTube.
Okay.
We are already live on YouTube.
Yes, there are 50 people already on this Zoom also.
Okay, fine.
1 minute to go.
Manmohan, I'll just call you and tell you how to do it. Huh? Just a minute.
No problem. Sure, thank you. बोलो निरंजन. हाँ.
Good morning, Jain sir.
I think shall we begin? It's 8:10.
Good morning.
Yeah. Shall we start? Yeah. Good morning, everyone. Welcome to this Woundcon from Mumbai Surgical Society, a full day's workshop. I would like to welcome all our delegates, distinguished guests, and faculties. To begin with, let me welcome our chief guest, Dr. Abhay Dalvi. Dr. Abhay Dalvi is presently a president of Association of Surgeons of India. He is a past president of the Indian Association of Gastrointestinal Endosurgeons. He is a co-opted EC member, Association of Minimal Access Surgeons of India, and professor and head of unit, KM Hospital, and presently attached as a consultant Global Hospital. I welcome you, sir, for this today's meeting. Let me welcome Dr. Rajendra Ganeriwal, our guest of honor. He is a president of Maharashtra State Chapter of Associations of Surgeons of India. He is practicing in Amravati since last 29 years as a general surgeon and endoscopist. He is a FIAGES Director of Dhanvantari Cooperative Hospital and special invitee to Board of Directors of Dhanvantari Hospital. Welcome, Dr. Rajendra Ganeriwal. Let me welcome Dr. Niranjan Agarwal, our own Mumbai Surgical Society President. He is a president of the Association of the Colon and Rectal Surgeons of India as well. He is an executive board member of International Society, University of Colon and Rectum, trustee of the Colorectal Foundation Trust Mumbai, and trustee and past president of Association of Medical Consultants Mumbai, chairman of the AMC NOH. Welcome, Dr. Niranjan Agarwal. Let me welcome our secretary, Dr. Rajesh Yadav. He is a senior consultant in HPB and GI surgeon in Bombay Hospital. He is also honorary professor of surgery at JJ Hospital, Grand Medical College. He is an EC member of IHPBA. He has a lot of academics to his credentials. Welcome, Dr. Rajesh Yadav.
Thank you.
Welcome, Dr. Shishir Shetty. He is the treasurer of Association of Mumbai Surgical Society. He is a head of oncology, Apollo Cancer Hospital. He is a head surgical oncology in Dr. DY Medical College, and is a lead in thoracic and GI HPB surgery. He is also a robotic and minimal invasive cancer surgeon with a special interest in tracheal tumors and recon. He is the president of CanCure Foundation. Welcome, Dr. Shetty. May I hand over now the proceedings to our secretary, Dr. Rajesh Yadav. Dr. Yadav, please. Thank you.
Thank you, Manmohan. And as the secretary of Mumbai Surgical Society, it gives me immense pleasure to welcome you all to our Woundcon 2021. At the onset, I would like to thank you all the dignitaries, my colleagues, speakers and chairpersons, and of course our own Dr. Niranjan Agarwal for all his efforts. I would like to call upon our president, Dr. Niranjan Agarwal, to take over the proceeding. Dr. Niranjan Agarwal.
Good morning, friends. Before I proceed, I would like to also welcome Dr. Sanjay Jain, who is the Honorary Secretary of the Associations of Surgeons of India, and is a practicing surgeon at Bhopal. He has been kind enough to log in with us early morning. So thank you, sir. With this, a very warm welcome on this rainy morning in the Mumbai. And as you all know, friends, Mumbai is known to be a city that never sleeps. However, the pandemic has hit us the worst among all the other cities in India, but we still will not sleep, and neither will we allow you to sleep from the academic points of view. For this is the first in a series of 6 theme-based programs with Mumbai Surgical Society planned for a whole day. So exclusively when we talk about wounds, the territory becomes about the surgeons. You know, nobody else can claim anything over it. So the first program was to define as a surgeon, talk about wounds, and today we have a full day webinar, full day program on wounds. We have got faculties from all across the nation who have obliged at a short notice and ready to deliberate their experiences with us today. And I'm sure the deliberations which happen today, the discussion which happens today will leave all of those who have logged in today and registered much richer than what they were till yesterday night. With these few words, thank you, Dr. Bhedalavi, Dr. Ganeriwal, Dr. Sanjay Jain, and my all committee members who are here. The 2 conveners, Dr. Manmohan Kamath and Dr. Milendra Ruke, who have done an exceptionally well job in organizing this event, and my honorary secretary, who always stand rock solid like a brother with me for all the endeavors which we do. Thank you, everyone, and welcome once again. Over to you, Rajesh.
Thank you, Niranjan. Thank you. May I call upon Dr. Ganeriwal to say a few words? Dr. Ganeriwal, please.
Yes. Good morning, all. Respected Dr. Bhedalavi, sir, President, ASI. Dr. Niranjan Agarwal, sir, President, Mumbai Surgical Society. Dr. Sanjay Jain, sir, Secretary, ASI. Dr. Rajesh Yadav, Secretary, Mumbai Surgical Society. Dr. Milendra Ruke and Dr. Manmohan Kamath, convener of today's conference. Dr. Samir Rege, Secretary, MASI. Dr. Anjali, Treasurer, MASI. EC members of ASI from Maharashtra State. EC members of MASI, office bearers of Mumbai Surgical Society. Senior and distinguished faculties, chairpersons for today's conference, and dear delegates. Greetings to you all. I bring greetings on behalf of Maharashtra State Chapter of ASI. It gives me great pleasure to be part of this event, Woundcon, which has been organized by Mumbai Surgical Society. Thank you so much, Mumbai Surgical Society and Dr. Niranjan Agarwal, sir, President, Mumbai Surgical Society. This is a very good initiative which has been taken by Mumbai Surgical Society in organizing a half-day conference on management of diabetic foot. The conference is not only covering the surgical aspect, but also medical issues and rehabilitation issues which are related to the management of diabetic foot. We have excellent faculties to address our concerns regarding diabetic foot, and with excellent chairpersons, I'm sure the deliberation and the interactions are going to be excellent. Diabetic foot, as you all know, is a very common problem which is often faced by all the surgeons in his career. It is so common that we now have a Diabetic Foot Society of India to address the advancement in the management of the patients of diabetic foot. At times, my management of diabetic foot is very lengthy and it requires a lot of patience for its management. The sequelae of healed diabetic foot is even more worrisome and even more frustrating for the patients. An excellent combination of medical management, surgical management, and rehabilitation of the patient with diabetic foot is what we are going to learn from this conference, Woundcon 2021. I must congratulate Mumbai Surgical Society, led by Dr. Niranjan Agrawal, Dr. Rajesh Yadav, for putting up an excellent event in which every detail has been taken care of. I wish the conference all the very best. Thank you so much once again.
Thank you, Dr. Ganeriwal, for those kind words. Next, I would like to call upon Dr. Sanjay, who has just joined us, to say a few words.
Dr. Sanjay Jain.
I think we have lost him.
Okay. Maybe he's logged out for some connection problem. You can proceed in that case.
Okay. Can I call upon Dr. Abhay Dalvi, sir, our president of ASI, to start the inauguration program? Dr. Abhay Dalvi, sir.
Thank you, Secretary. President of the Maharashtra State Chapter, President of Mumbai Surgical Society, office bearers of both Maharashtra State Chapter as well as Mumbai Surgical Society, a very good morning to you. The educational activities since this pandemic have actually invaded India on various platforms, including Zoom. And it should continue, not that it should stop as soon as the pandemic is over. But important thing is that there has to be a good teamwork. There should be no overlap. Overlap becomes a huge problem where people miss out on important things or have to jump around from here to there. And that, I think, requires a complete streamlining. Maharashtra State, I'm extremely proud of to be a part of, has done considerable activities both at city level as well as the state chapter, and my congratulations to them. Mumbai Surgical Society has already listed a year-long program under the leadership of Niranjan Agrawal, and it's a wonderful program to be with and be a Mumbaian to be along with the Mumbai Surgical Society. I vaguely remember Massicon in Pune in 2012 on a Sunday morning at 8 a.m. where I was given a lecture to deliver. You know, on Saturdays is a cultural festivity evenings, and to get up early in the morning on a Sunday and come and deliver a lecture is a huge problem. There are two problems that exist. Number one is to deliver the lecture, and number two is there is nobody in the crowd. And I remember on that particular day, I met Dr. Shrikande, our father figure in Mumbai, at 7:45, trying to come and attend the lecture that I was supposed to deliver. I said, sir, there is nobody in the audience. He told me, Abhay, you are the speaker and the show must go on and you have to be on time. So today I was on time well before the president of Mumbai Surgical Society or the president of Maharashtra State Chapter had logged in. I had already logged in. So with these things, I think we should start the program. Now, wound or Woundcon is a huge problem when it comes to diabetic foot. Wounds can be physical and wounds can be mental. Physical wounds usually in a normal patient would heal quite well, but mental wounds take a long time to heal. Diabetic wounds are like mental wounds. They require a lot of external, internal corrections before these wounds can heal. Today's program, as devised and as I see it, is a huge program which covers almost all the aspects except possibly the mental support to be given to the patient, which could have accentuated the program even better. In any case, I inaugurate and throw this complete program open under the leadership of Niranjan Agarwal and the other office bearers, as well as Dr. Ruke, who has, I think, thrown his life into management of diabetic foot. Thank you so much, and let us start. Thank you.
Thank you, sir. Thank you for those kind words. Dr. Dalvi, have you logged out? Sir, we have to go ahead with inauguration program of lighting of the lamp. So I'll ask the Vama person to go ahead and start the lighting of the lamp. Yeah.
I'm okay.
या कुन्तेन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्।
Thank you, Swapnil. May I ask our treasurer, Dr. Shishir Shetty, to give the vote of thanks. Dr. Shishir Shetty.
Thank you, Rajesh, and Dr. Niranjan for the opportunity. I'd like to thank the president of ASI, Professor Abhay Dalvi, the president Masi, Dr. Rajendra Ganewal, Dr. Sanjay Jain from the ASI, the conveners, Dr. Manmohan Kamath and Milind Ruke for conducting this program, all the faculties, all the esteemed faculties, including the chairperson who have spared their precious time and are going to spend and spread knowledge today. It is indeed a very well organized conference, and most important, I think I cannot miss the sponsors like Coloplast, 365, Torrent, JB Chemicals, Subvision Enterprise, Dr. Manoj Gupta from Hyperbaric Oxygen Therapy, who have always supported the Surgical Society and the Colorectal Society and all the meetings that has been conducted. Thank you, Swapnil, from Vama for organizing it so beautifully, because I'm sure it is not an easy task to manage all the doctors in the last minute. And thank you once again. I will hand over the mic to, I hope I have not missed. If I've missed, I'm extremely sorry. But I think we should start the program. I'll hand the mic over to the next speaker.
Thank you, Shishir. And with this, I would announce the inauguration program has been taken care of and it's over. I'll ask Dr. Kamath to take over the proceeding of the first session. Thank you, everybody. Thank you, Dalvi sir. Thank you, Dr. Niranjan Agarwal. Thank you, Dr. Rajendra. Thank you, Naresh, Shishir, Manmohan, and all the dignitaries on the dais. Thank you so much. Dr. Manmohan. Manmohan, you have to unmute yourself. Manmohan, unmute yourself.
Yeah, good morning, everyone. So we have still 2 minutes to go because 8:30 is the first invited lectures what we'll be having. Till that time, I think I will take opportunity to start this session a little early, introducing our chairperson for the same. So we are absolutely bang on time. I think it is one first achievement. So I think great in beginning is half done, as it is said. So we start the program on time with the session 1 of the invited lectures. The chairperson for this invited lectures is Dr. Rajendra Ganeriwal, which we have already introduced, who is a president of MASI, and Dr. Naresh Rao, who is a consultant surgeon of the One Day Surgery Center at Babulnath, Mumbai. He is a founder and president of the Indian Association of the Day Surgery. He is a president. He is a past president of the Mumbai Surgical Society. He is the editor of Day Surgery Journal of India. He is the editor of the newsletters One Day Surgery Times, MSS Times, and Samvad. He is the author of the handbook for daycare surgery, author of the protocols of a daycare center, and is a member General Assembly International Association of Ambulatory Surgery. So I welcome Dr. Ganeriwal and Dr. Naresh Rao, and I request them to introduce our.
Manmohan, there is
Yes.
some change. Dr. Ganeriwal has to log in for the Sangli program. So Dr. Vijay Shivpuje, who is a consultant surgeon from Solapur, a senior surgeon and practicing at Yashodhara Super Specialty Hospital, has kindly consented to be the chairperson for this session. Welcome, Dr. Vijay Shivpuje. Over to both the chairperson.
Welcome, Dr. Welcome, Dr. Vijay Shivpuje, consultant surgeon from Yashodhara Super Specialty Hospital. So our chairpersons are going to be Dr. Naresh Rao and Dr. Vijay Shivpuje. So may I hand over now to the chairpersons to conduct the proceedings, call upon our distinguished faculty to take lectures. Thank you so much.
Thank you, Dr. Kamath. Once again, I welcome everyone on behalf of Mumbai Surgical Society to Woundcon 2021. Just before we start, this session has two speakers, and to the speakers, I would like to tell you that it is 25 minutes of your lecture and 5 minutes for question and answers. For all the delegates, please put in your question answers on the question answers box that is there below. Time permitting, I will ask them at the end of each lecture. Now, the first speaker is Dr. Milind Ruke, and he specializes in diabetic foot limb salvage and reconstruction surgeries. He has several distinguished qualifications, as you can read on his CV, and he's a teacher and dedicated his whole time and his devotion to the treatment of limb salvaging in diabetic foot. He's going to enlighten us on the management in today's program. So I hand over to Dr. Milind Ruke.
Good morning, all of you. Good morning, all of you. I would like to thank Mumbai Surgical Society to have organized such a beautiful Woundcon today on a Sunday. And I also thank Dr. Abhay Dalvi sir for his words of wisdom and kind words for me. So without wasting any time, I would like to tell you that diabetic foot as an entity especially is neglected and not only difficult to treat but has uncertain prognosis in untrained and inexperienced hands. I have realized in my little experience that all these years the physician and surgeons were not interested in treating this disease beyond amputations. Also, there is a lack of rehabilitation. As compared to other surgeries, it lacks luster and charm. The disease is morbid. Nobody has the time to be patient and deal with the uncertainties, the mental wounds that Dr. Dalvi sir said associated with it.
Sorry to interrupt. Can you increase your volume, please?
I'm not audible?
You are audible,
Hello?
but if you can increase your volume, it will be better.
Yeah. But the moment you are trained, am I audible now? Hello?
Yeah, better.
Much better, much better.
But the moment you are trained and develop interest in this, your body language and explanation skills of the subject instills positivity and confidence in the already depressed and scared patient. It ultimately impacts the outcome and prognosis. I am glad at least now trained surgeons are doing their best to give biomechanically functional foot for these patients and rehabilitates them whenever it is needed. So today my topic is changing pattern of hospitalized diabetic foot ulcer. Few facts, by a rule of 15% of people develop an ulcer in diabetes, 15% of ulcers will develop osteomyelitis, and 15% ulcers result in amputations. But now we see because of more longevity in the diabetic patients, this percentage have increased. 85% of amputations result from the non-healing ulcer. Half of amputated patients have contralateral amputations within 3 years because of poor prosthesis rehabilitation. Half die within 5 years, unfortunately, because of excess of load on the already decompensated heart. Every 22nd, a limb is lost due to diabetes. 1 million limb amputations occur yearly worldwide. In India, in spite of poor data keeping, we have seen 2 lakh legs are amputated every year with infected neuropathic foot. But the best fact is up to 85% of amputations can be avoided. However, there is a still gap between what's known about diabetic foot and what's really done to them. If you see the mortality rate and you take this neuropathic ulcer, amputation, colon cancer, and ischemic ulcer and peripheral arterial disease in a paper published by Dr. Armstrong, they are next to only pancreatic cancer and lung cancer as far as the fire mortality rate is concerned. So it's a very significant problem. A small idea about what happens in the pathogenesis. So we have polyneuropathy with autonomic neuropathy causing increased arteriovenous shunts, causing the foot to be hot and turgid with epidermal cutaneous ischemia, making it prone to injuries and ulceration and infection and extrinsic trauma. Secondly, we have uh, motor neuropathy and sensory neuropathy, making the patient very insensible and have deformed foot, making it biomechanical alteration in the foot, causing ulcer inside out. Then we have peripheral vascular disease causing decreased blood flow and gangrene infection. So these are the main causes. In addition to this, decreased immunity and biomechanical changes prone the patient to different types of diabetic foot that we see nowadays. So out of this presentation, I have thought that there are 5 patterns of presentations were very significant as far as amputation prevention concerns, and I'm going to discuss that today. The changing pattern that we see, the first is biofilm presentation, diabetic foot osteomyelitis, ischemic foot, silent compartment, which we normally try to treat as cellulitis. Most of the patients, the presentation and the documentation is less because most of the patient undergo amputation later on because we miss this silent compartment, and Charcot foot. So coming to biofilm, it is a very significant part of infection, diabetic foot infection. 4 in 5 chronic wounds contain biofilm, often not identified. So what is a biofilm? A biofilm is a mode of survival for organisms since the time of evolution, and these are group of bacteria which come together and stay. So they are polymicrobial to start with. They adhere to each other and adhere to the surface, secrete a extracellular polymerase causing a 3-dimensional structure, and this organisms, there is a core group of bacteria and surrounding planktonic bacteria, communicate with each other through water channels, exchanging metabolic and nutritional exchanges, also exchange phenotypic information, genetic information, and this causes them to be very resistant to antibiotics and various other modes of treatment. So they behave like an organized community and they communicate with each other through water channels. This process is called as quorum sensing. So this is how they become resistant. So what are the benefits of the organism forming a biofilm? They have cooperative nutrition strategies. They alter the phenotype and genotype, giving resistance to the organism, and many other processes. Also causes recurrence of biofilm even after debridement. So resistance to organism and evasion of host immune system is some of the advantages that the bacteria has when it forms a biofilm. Once this is exposed to the body's immune mechanism, it causes a overregulated immune response as an innate immunity takes over, continuous influx of neutrophils, prolonged inflammation, and local level inflammatory things accumulate, and the wound starts getting arrested between the inflammation and proliferation. It doesn't move forward. There is an increased level of metalloproteins, and this cycle continues, and the patient and the wound becomes chronic. The stages of biofilm is one is adherence, then multiplication.
I would interrupt you again. Sorry, people are complaining they are not able to hear you.
Okay. So
if you can increase the volume of your laptop, probably.
Yeah, am I audible now?
Yeah, you are now.
Okay. So the life cycle of the biofilm is it starts with adherence, and within seconds and minutes it gets adhered to the surface. This process is reversible. Then it multiplies into a structure. Later on it matures, and after maturing it becomes a three-dimensional structure which can later on, if not treated, disperse bacteria in the general circulation, causing systemic infection. The diagnosis of biofilm is it is a classical gleamy appearance, whitish in structure, and once you try to debride it recurs. It is heavily exudated, covered with fibrinous and necrotic tissue, and recurrence is common after debridement. It occurs resistance to antibiotic. Persistent wound infection is seen despite the correct dose and duration of appropriate antibacterial therapy. It is difficult to treat. Only cure may be removal and avoiding of its reformation. It is polymicrobial, which is evidenced by tissue culture. Now the strategy to do is, in the old part we used to do a lot of debridement, serial debridement, but that has shown that it doesn't serve the purpose. So you should have an anti-biofilm strategy by using something which will allow, after the debridement, doesn't allow the recurrence to occur. So we have 20% silver which we try to irrigate the wound after the debridement, and it is a very good strategy. Then we have irrigation WAC with polyhexamide, which is another thing, but these are expensive. Now we have cadoxamar iodine, which is a very important thing which has been available in India, has got a triple method of acting on the biofilm. Like they have a non-ionic surfactant, then they have cadoxamar iodine which acts for 72 hours, and we have the iodine which takes about care of the antimicrobial effect on the biofilm. So this is how we used to treat in the past with serial debridement and WAC, and now we have an application after debridement. You apply cadoxamar iodine and you get within 8 days reduced slough, and the wound is granulating and healing. The second most important pattern is osteomyelitis, which usually involves digits of the foot, but we have seen calcaneal osteomyelitis also. If these are associated with peripheral vascular disease, peripheral neuropathy, and chronic renal insufficiency, which normally is in the diabetes, it contributes to the volatile clinical course, impairs wound healing, decreases tissue antibiotic penetration, and abnormal biomechanical pressure is seen in the foot. If you see the outcomes of infected diabetic foot with osteomyelitis, increased length of stay in the hospital, time of healing is more, and the amputation is more in osteomyelitis. The diagnostic criteria clinically, any two of the following can be taken as osteomyelitis. One is probe to bone positive test in your OPD, visible cortical bone if you see on clinical examination. On X-rays, you should see cortical destruction, MRI showing bone edema or cloaca, and ESR raised. The other criteria is a non-healing wound for 6 weeks in spite of giving adequate offloading and perfusion, ulcer of more than 2 weeks duration with clinical evidence of infection, and the most important is positive bone culture or histopathology. This is one of the case, a rickshaw driver who was operated by a general surgeon, and he had when he came to us, we found that he had a fourth phalanx, an entire fourth metatarsal having osteomyelitis. Blood sugar was high, operated by a general surgeon 3 months ago, non-healing wound. Came to us, we did a excision of the metatarsal, the involved osteomyelitis part, created a fillet flap and sutured the wound, and he was doing his work within 45 days. This is a typical sausage toe that we see, and the treatment for this is simple excision of removal of the pus. If the involved phalanx is there, a part of the phalanx can be removed. We do a flexor tenotomy, and this has been, there are a lot of papers which have been published by Dr. Loiza and Dr. Benjamin Lipinski in judicial use of antibiotic and local resection of the bone which is involved, and you offload it and you start healing. The third thing is vasculopathy. So apart from the stroke and heart attacks, macro and microangiopathy and the eye complications, you have foot vascular problems which are increasing now. In the Western countries, we used to find more vascular issues and we used to have neuropathy. But with longevity and young diabetics, we have got more than 30% of vascular involvement in diabetic foot patient, and which is causing the issue. It can be clinically seen that you can examine the foot pulses. You can do ankle brachial index, which is a mandatory investigation. I have been teaching in my medical colleges and telling students to do this because that is the most simple thing that you can do to find out what is the vascularity of the foot. Toe pressure, capillary filling you can see, and if you have facilities of measuring TCPO2, it should be below 40, above 40 to declare it as an ischemic foot. If you know that it is ischemic foot, you do duplex Doppler study and angiography to find out whether it requires any intervention. The therapy of vascular problems depends upon what are the symptoms. So if it is intermittent claudication without an ulcer, then your exercise therapy, Allen Burgess exercises, drugs like pentoxifylline, silistazole, blood thinners are used, and revascularization is only done if there is severe disability, if there is an ulcer which is not healing, because the goal is to provide relief of symptoms. Critical limb ischemia, if the ABI index is less than 7 and angiography finding is there of obstruction, then wound care, antibiotics, but mandatorily you have to do revascularization. Endovascular is the most upcoming thing in diabetic foot management, where we do uh, balloon angioplasty and stenting, because here the goal is to promote limb survival. So this is one of the case. The wound was not healing in spite of debridement. We found a small block here, and we did balloon angioplasty and stenting, and we found it healing very well within the next 2 to 3 weeks. Sometimes you have to do a bypass, and you have to, as a general surgeon, see that the bypass is working properly before you take up the patient for next uh, treatment of diabetic foot. The next pattern that we see is cellulitis. Most of the medical colleges start treating cellulitis, and then they find the patient's foot is turning gangrene distally and they do an amputation. But we miss something called as a silent compartment syndrome, which documentation is less, but it is there. And what it requires is fasciotomy. So this is the patient. There are 5 P's: paresthesia, you have no pulses, and you have pain, which is the most significant symptoms, pain which is more than what you have to comprehend, and pulsations are not felt properly. And these are the 5 P's which tell you that this is not cellulitis, but it is going into a compartment syndrome. So you do a tri-compartment release, you can use vac and then graft the wound, and you can salvage the foot. This is one of the other patient that we would salvage. Then Last but not the least is Charcot foot, which is always mistaken for cellulitis and osteomyelitis, which is because of repeated walking on a neuropathic foot. There is a prolapse of either the forefoot, midfoot, or hindfoot. Accordingly, you will have prolapse of the foot and deformed foot. The average duration of diabetes is 10 to 12 years, commonly asymmetrical, no sex predilection. It happens in type 1 and type 2. Generally, the diabetes is not controlled. There is peripheral neuropathy, and you will find the patient must be walking repeatedly, giving stress on the already deformed foot or foot with low mineralization. Reported incidence varies. When high volume centers, you have sometimes 16% of the patients having Charcot foot, and sometimes now we are getting bilateral Charcot foots also. But in general, the incidence is 0.8 to 0.5%. The indications for surgical treatment, we are having a good lecture on Charcot foot following this. So I'm not going to go into the medical treatment. The indications for surgical treatment is failure of conservative treatment, recurrent ulcerations, unstable foot, bilateral disease, obesity, higher activity level person who is young, you should do surgeries. Surgery, we do surgeries from exostectomy of bony prominences to osteotomy, triple arthrodesis to Elizarov procedures. One thing is patients treated with surgery have longer healing times and requires a lot of mental and physical care. So this is one patient with navicular exostosis. So we planned the surgery and excised the prominent bone, and then we fix the joints, intertarsal joint with screws, and this is how immediate post-op you see that the curvature has come back and also the deformity has gone. So this is actual fixation is talonavicular subtalar joint fixation, uh, calcaneo-talar fixation, then you have talonavicular fixation, and then you have calcaneo-cuboid fixation. This is a triple arthrodesis that normally is required when the patient has got a hindfoot Charcot. Some of the publications that we have, so if you have good reading in this for the students, the pattern of treating diabetic foot has now changed by the IWGDF guideline, International Working Group in Diabetic Foot, that we are trying to detect high risk foot and then risk categorize them. So if you have no sensory loss, no peripheral arterial disease, no deformity, we just educate the patient and tell them footwear. If you have
home वहाँ पे you are not seen anywhere. That's why.
hello sir, am I audible?
Yes, yes.
Milind, you are audible.
Continue,
please.
Okay. So in the risk categorization, if you don't have any sensory neuropathy or peripheral arterial disease or no deformity, we just educate the patient and advise him footwear. But if you have sensory neuropathy and deformity, we ask them not only prescriptive footwear, but do prophylactic surgery of correction of deformity, which can be accommodated in the shoes. If you have arterial disease and loss of sensations, then we ask them to do vascular consultation. And in the risk category 4, if the patient already has an ulcer and amputation history, then he has to do vascular consultation with surgery if required for the ulcer and footwear. So this is how we do risk categorization. To find out high risk patients, you should do a proper inspection like dermatological inspection of skin status, color, whether there is absence of sweating, infection in between the toes, ulceration, calluses which should be treated whenever you find them, musculoskeletal deformities which can be corrected like claw toe, prominent metatarsal heads, Charcot foot, giving them footwear or giving them total contact cast, neurological measurement with vibration perception studies, monofilament, or a simple tuning fork of 128 Hertz can be used, vascular assessment as we had discussed. So guys, I have also seen even the Mediclaim company just saying that the diabetic foot surgeon is कुछ नहीं करता, he just does debridement. But no, the newer guidelines and the classification of diabetic surgery by Dr. Robert Frickberg and Armstrong has recently told us in 2007 that we have four kinds of surgeries in diabetic foot. One is an elective surgery, which is performed on patient with protective sensation intact to eliminate pain or improve function, like in tarsal tunnel syndrome, where you have got very severe pain in the distal part of the foot and the nerve is compressed in the tarsal canal. Vascularization surgeries and diabetic venous ulcers in diabetic foot. These are some elective surgeries. Prophylactic surgeries like tendo Achilles release, gastroc release, Charcot foot surgeries, deformity corrections are prophylactic surgeries. And in curative surgeries, you have got tendon transfers and excision of metatarsal heads in patient with ulcer. And emergency surgeries we all do, like amputation, foot exploration, and debridement. So these are the four types of surgery. Some of the studies in curative surgeries, which was presented in 2003 by Mueller, about cases of ulcers where tendo Achilles lengthening was done alone and it was done with contact cast. And we found that if you do a TA release with a total contact cast, we have 80 recurrence rate reducing from 81% to 38%. So this is how we do a silver Colts test to decide whether we have to do a tendo Achilles release or a gastroc release. I know Dr. Madhu Periyaswamy is going to deliver a lecture in the later part of the afternoon. He will, I think, definitely explain this. The other published was by Piegassi, which is a curative surgery, where a ulcer which was not healing because of chronic osteomyelitis or bone prolapse, you do surgical excision and give a total contact cast, and you find the ulcer healing rate increasing from 79% to about 95%. So this is how you excise and give a total contact cast, and we have given a window, a little modification, and we found the patient healing. Then you have two papers published by Dr. Armstrong in elective surgery, where clawfoot was treated by digital resectional arthroplasty in 31 cases. And in another uh, paper, he said percutaneous Achilles tendon lengthening, which was done in a patient with neuropathy with plantar acceleration. And both the things he showed that the recurrence of ulcer was less by this elective surgery in the foot. This is how it is done. This is how the deformity correction and the clawfoot correction with external tendons lengthening is done. Even the use of footwear was seen to reduce the mean callus grade in the foot, and this was a paper published in 1995. So footwear is a very important part of treatment of diabetic foot and offloading. So more than a century ago, the coal mine workers used to use a cannery and they used to take down the mine to find out whether carbon monoxide poisoning is occurring, and the cannery used to fall unconscious. Of course it would revive when you bring it up, but they used to know if this is a risk to go down below this level. So can we use certain uh, test or clinical test and test available to identify this risk in diabetic foot and label them as high risk foot and take care? It will go a long way in um, preventing amputation. So the take home message is diabetic osteomyelitis and biofilm type of infection, major cause of amputation. High index of clinical suspicion should be there, which is required to detect high risk foot. Osteomyelitis, conservative surgery and judicious use of antibiotics with tissue culture and bone culture. Biofilm, multiple strategies should be used. Clinical acumen by the person who is treating, a physician or a surgeon, to detect high risk foot should be aware of changing patterns of presentations, be suspicious if wound not healing, and in high risk patient use clinical examination, ankle brachial index, neurological test as a canary as used in coal mine to prevent possibility of loss of limb. Because then the eyes are useless if your mind is blind. So be aware of this very important signs which the patient will not exhibit. We have to be vigilant. And thank you.
Thank you, Dr. Ruke. A wonderful lecture. You just completed it in time, and there are apparently no questions. If there are any questions, please, you can ask Dr. Ruke directly. He's there online. Now, I invite my co-chairman, Dr. Shiv Pujay, to introduce the next speaker. Thank you.
Yeah, good morning. I would like to introduce our next speaker, Dr. Ashu Rastogi, who is an endocrinologist and professor at Department of Endocrinology, JIPMER, Chandigarh, India. He has many publications on complications of diabetic foot. He is very well been recognized in the Diabetic Foot Society. He is a good researcher. I request Dr. Rastogi to start his presentation, please. Dr. Rastogi.
May I
Hello.
request the speaker to keep his volume maximum, because there are a lot of concerns regarding the voice of the speakers.
Okay.
So please keep your volumes to the maximum.
I'll do that, sir.
Thank you so much.
Yeah, welcome, Dr. Rastogi.
Yeah, thank you. Thank you, Dr. Vijay. And I hope that my slides are visible.
Yeah.
Yeah. So thank you on the behalf of everybody that they have invited me, because I have been mainly endocrinologist and with acute interest in Charcot and especially diabetic foot. So maybe I might be a black sheep here in this August forum, but I will be mainly concentrating on the medical aspects of Charcot's, and because I don't operate. So before starting, I just wanted to show this simple picture, and everybody of you can definitely find out that something is abnormal with the foot. So he was a 53-year-old gentleman who had diabetic for 9 years, but he was roaming with this swelling of foot for past 12 weeks. So the possible diagnosis that could have been considered and what was considered by many, maybe the doctors who were treating for us, were cellulitis, maybe osteomyelitis. Gouty arthritis is very, very unlikely, because what we can see in this picture is mainly the swelling, which is predominantly at the midfoot with the loss of arches and almost a rocker bottom kind of deformity. So a Charcot's foot or a traumatic fracture. So that was definitely a Charcot foot, but unfortunately this patient was being managed with antibiotics considering just a cellulitis or even osteomyelitis, and nobody did even an X-ray. So this is Charcot's, and unfortunately this was the picture once we got an X-ray. So this is not an uncommon finding in the clinical scenario. You might also be seeing these kind of pictures day in and day out. But unfortunate for the patient also that what you could do in this kind of scenario. So that is an open question for the orthopedicians and especially the foot surgeons. When the patient is completely destroyed, maybe the hind foot, the midfoot, is arthrodesis an option? And so this is really challenging. So we just publish it as vanishing bone disease because we can not see any kind of midfoot bones or the navicular bones here. So this is an unfortunate part of Charcot, so we should never forget. And ideally, a patient should be recognized very early. So this is another case, and you can very well see that there is something abnormal with the left foot. And what you can see is a swelling and erythema, and on touch, the temperature was much higher. So we should not consider osteomyelitis or any other diagnosis. Always keep a high index of suspicion for Charcot's foot. So if you do an X-ray to confirm your finding, you can definitely see, and this is a bone scan which showed a typical increased uptake on technetium 99M bone scans, which was confirmatory of Charcot's foot. So you can have a varied presentations and outcomes in patient with Charcot's, but what is important is what I want to highlight from my presentation is recognize early. Once you recognize early, then only you can prevent such devastating complications as my earlier patient had. This is just a case which I wanted to highlight, show, because that we saw a few months back during COVID times also. Again, you can see a left foot was swollen, but interestingly, what you can see his wrist was also swollen as compared to the right wrist. His left wrist was swollen and the hand was also swollen, and it was erythematous also with increasing temperature. So as we believe that diabetes is associated with predominantly glove and stocking kind of neuropathy, so this patient what probably having a concurrent wrist and midfoot Charcot's neuropathy. So never just focus on the foot. See patient as a whole. They can have multifocal Charcot. So this is also a presentation. So in this patient, we further evaluated and we did an MRI and all kind of bone scans, and we suggest, and this was suggestive of again a wrist Charcot. So wrist Charcot is also a finding, and this is only the 10th case in the world that has been published till date. And never miss wrist Charcot along with the foot Charcot. So I'll be just telling you in just next 15-20 slides a story of the misdiagnosis of Charcot's foot. So this is another case, which is a case of chronic Charcot. So the 43-year-old lady presented to us with the swelling and progressive deformity over past 1 year. She had some swelling 1 year back, which was treated as cellulitis with a course of antibiotics. And when she came to us, you can look, she already had an amputation of the great toe that was around 3-4 years back. And she had a swelling over the midfoot region of the left foot. And you can very well see the arches of the right foot was relatively preserved as compared to the left foot, where the medial longitudinal arch was lost. So probably this patient was having an acute Charcot 1 year back that was missed. She continued to walk, and finally she landed in chronic Charcot with a kind of a pes planus, and it will surely go into the rocker bottom and ulcer and finally amputation. So we need to prevent it. This is a common scenario and common clinical examination in patient with Charcot. They usually have a vibration perception which is more than 25 because of loss of the protective sensation. Monofilament sensations are lost, which is suggestive of distal symmetric peripheral neuropathy. Usually they have a very good peripheral pulses which are palpable with normal pulse volume. Ankle brachial index is normal, as was in this patient. Retinopathy coexists in these patients very commonly, and most importantly, nephropathy was also there. She had proteinuria. So we just asked her kindly if you can provide us an X-ray. So she provided us with an X-ray. So this was when she presented after 1 year of initial presentation to our institute. This was 1 year back. So X-ray was supposedly normal. So the treating physician didn't thought of anything like Charcot. And 5 months, because she continued to walk, she had this kind of picture. And finally, she landed here. So we have to prevent these kind of pictures in our patient of Charcot. So remember, every diabetic foot swelling is not infection. It does not require antibiotics, and it is not cellulitis. There can be a lot of differential diagnoses which are much more common than Charcot. I accept that. But that doesn't rule out that patient does not have Charcot. It can be a rheumatoid arthritis, it can be gout, it can be deep vein thrombosis, it can be osteomyelitis, even septic arthritis. But acute Charcot should always be considered when a patient has a unilateral foot swelling, which is acute in onset and associated with increase in temperature. So how do you actually diagnose acute Charcot? So diagnosis is essentially clinical. We have to keep our mind and eyes open, as Dr. Ruke was also mentioning. You have to have a high degree of clinical suspicion. Take a background history of neuropathy, because these patients have dense neuropathy. They have a localized swelling predominantly over the midfoot, which is the most common site of Charcot, and they have normal bounding pulses with normal AVI. Some people say that you can do an ESR, CRP, but usually they are not useful. You have to do a simple weight-bearing plain X-ray. That is very good in diagnosing acute Charcot. I know that in early Charcot that might be missed. An X-ray may be normal. You have to do an MRI. But just try to differentiate cellulitis from Charcot, because cellulitis usually is a very acute kind of event as compared to subacute event in Charcot, because patient will say that I have a swelling over 2 weeks or 3 weeks. It's very uncommon for cellulitis to persist for such a long time. And fever is usually absent in patient with Charcot. Localization, cellulitis is usually diffuse as compared to Charcot, which is mainly localized midfoot swelling. Inflammatory markers are usually high, especially ESR and CRP in patient with cellulitis as compared to Charcot. Leukocytosis might be there, and MRI is very useful because it can tell you whether this patient is having predominantly soft tissue involvement, or in addition to soft tissue, a bony or a joint involvement, which is detected by a marrow edema on an MRI. So my just a message to all of you who are listening is a unilateral foot edema and warmth in a diabetic patient is a strong predictor of Charcot's foot. Now, just something about physiology and pathophysiology. We know that this is because of mainly sensory neuropathy. On top of that, patient continues to walk. He had minor trauma. In addition to that, patient had increased vascular flow, that is because of autonomic neuropathy and sympathetic denervation. Over that, he had hyperglycemia. So there is glycosylation of collagen, which leads to abnormality in the ligaments and the tendons, along with the joint cartilage. And this whole conundrum leads to Charcot's neuro-osteoarthropathy. So how to differentiate Charcot's with the diabetic foot osteomyelitis? Because we have seen, and you might also see many patients who have an ulcer. On top of that, they continue to walk, they can also develop a Charcot's foot. And just you can just click a photograph of this simple table that differentiate a Charcot's from osteomyelitis. But remember, the Charcot's changes are usually non-specific, which might be seen in osteomyelitis also. So we have to sit with the radiologist and to determine. But remember, in acute Charcot's, flattening of the metatarsal head is usually the first sign, and a very early sign would be focal, very focal periarticular demineralization. And strong indicators of neuropathy or neuroarthropathy on radiograph is absence of any soft tissue involvement, predominantly periarticular changes, involvement of the interphalangeal joint, and ankle is less common because it is mainly at the point of the bridge rather than on the pillars in the midfoot region, and it is polyarticular. So once you have done an X-ray and you find it to be normal, it doesn't rule out Charcot's if you are having strong suspicion. So you have to do an MRI. But if do all patients require MRI scan? I'll say no. Only if the plain X-ray is normal and you are suspecting Charcot's, do an MRI. If there is an overlying ulcer and you want to have a good detail of soft tissue, do an MRI. It very goodly differentiates diabetic foot osteomyelitis with Charcot's, and this MRI is also required in remission of Charcot's, because now there have been some papers, especially from the Swiss journals, and they have been working that you can follow your patient with MRI and then you can determine with a decreasing bone marrow edema is a very good sign that now the Charcot's process is in quiescence, and now the patient can be shifted onto a modified shoe or an air walker from total contact cast. Nuclear scans, yes, we do nuclear scan as I had shown in my first slide, but it is very less often required. But sometimes it might be required, especially if skin is ulcerated. You are finding that it is a very complicated case where osteomyelitis is also there, Charcot's is also there. Then you might do some kind of scans, like we do labeled WBC scan, which is autologous WBC PET scans for differentiating Charcot's from foot osteomyelitis. And also we do sometimes scans, technetium scan, or even the PET scans, FDG PET scans for quiescence of active Charcot's. So we published this paper, and this was also quoted in the recent IWGDF guidelines published in 2020. And they also say that this can be a modality to differentiate diabetic foot osteomyelitis in a patient who is already having a chronic Charcot's. So these kind of pictures you get from these patients who have diabetic foot osteomyelitis and Charcot's. So this scan was found to be very useful. Now coming back to the second case that I showed you of acute Charcot's. So you can very well see that this patient was having increased technetium uptake, which was suggestive of acute Charcot's. So we followed these patients with temperature records. And what you can see, the temperature record of this patient. So this patient had a very high left foot temperature that was around 5 degrees centigrade higher as compared to the right foot. And this is the duration in weeks. So over around 7 weeks with total contact cast, the temperature difference between the 2 foot normalized. That is, it becomes less than 2 degrees. And this is the delta T, or the difference in the temperature of the 2 foot. And it is said that once the temperature between 2 foot is less than 2, you can say that the patient is in quiescence. And now you can shift the patient to modified shoe. And you can see the erythema and the swelling is significantly reduced as compared to the right foot. We also do MRI, and this was also suggestive that there was initially very high marrow edema, but is significantly reduced in these patients after the follow-up of these patients. So remember, when you see a patient of acute Charcot's, you should also know how to follow these patients. So what we do is we give a total contact cast to these patients, and we ask the patient to come back to us every week, because there is significant decrease in edema, and there is significant piston effect because this cast loosens. So we have to change the cast almost weekly. We ask the patient to cut the cast, and we assess the foot temperature again, and again apply the cast if the temperature is more than 2, and reinforce on offloading. So these are the devices, the infrared thermometers that we use to check the temperature of the foot. And this is very important, and you can just cannot follow your patient by touching the foot of the patient with your hand, because hand is less sensitive to detect the temperature difference. And this is again paper by David Armstrong, and who showed that usually it might take even 9 to 10 months for the acute Charcos to go into remission, and before you can shift your patient to a crow boot or a modified footwear. So you have to bear patience, and your patients also have to bear patience while dealing with acute Charcos, so that they don't have destruction of the foot bones. So how long to continue? Till the remission of active Charcos, and remission is defined by temperature difference less than 2 degrees centigrade for 4 weeks. So in UK study, that is the largest CDUC study, which was published in Diabetologia, in England, they showed that the median time to cast is around 9 to 12 months. You can also follow these patients by MRI and the SUV. And in our experience, we have a registry of more than 350 patients of Charcos, and we found out that the median time was around 7 months in our series. Now, coming on to the treatment, as I was mentioning, total contact cast is the gold standard, and this has been well studied, and this is also in the consensus statement of American Diabetes Association, but it was around 10 years back, where they showed that the gold standard would be the total contact cast, and after some time, after in remission, you can put your patient in the crow boot. And probably we and Dr. Bal and Dr. Vijay from India has been chosen for framing the next ADA consensus report on Charcos, and we'll have soon. Coming on to the last part of my presentation, because being an endocrinologist, we are very fond of drugs. So we went back to understand the pathophysiology of Charcos, to understand that which kind of drugs would be useful for Charcos foot. So just a recap of the pathophysiology. In diabetes patient, there is increased blood glucose, and there is lack of the receptors for advanced glycosylation end products because of increased ages. Now, what this increased age does, it causes increased rankle. Rankle is again, I would say, a peptide which is responsible for the activation of osteoclast in the bone. And everybody knows that osteoclast is responsible for the bone resorption and the bone destruction. So what happens in diabetes patient, because of neuropathy, there is decreased calcitonin gene-related peptide, which increases rankle, and finally, it all leads to increase in osteoclast activation. Moreover, these patients do not know that they are having Charcos, because they have a sensory neuropathy, so they don't know and continue to walk. So they have repeated trauma, which leads to increase in the inflammatory cytokines, which again causes bone destruction. So overall, all these things are acting on the foot to derail that patient and landing the patient into destruction of the foot bones. Now, how you can prevent it and treat it? So bisphosphonates are the drugs that have been used, like you might be knowing about alendronate and zoledronate, which predominantly act to inhibit the rankle and decrease the osteoclastic activation. So this is one of the mechanisms by which these drugs might be useful in Charcos. Otherwise, people have also tried, Dr. Bem and colleagues have tried calcitonin, because it also inhibits the osteoclastic activation. And steroids, you know that they are anti-inflammatory. They can inhibit these inflammatory cytokines, and they can also inhibit the osteoclast and prevent the bone destruction. And finally, teriparatide, which is a recombinant parathyroid hormone, you know that this significantly improves the bone density, bone strength, that can also be useful in patients with Charcos. So medical therapy has been tried. All these therapies have been tried. And fortunately, I would be very proud in saying that we were the first to study the steroids in the world, and we were the first to study teriparatide in the world in patients with Charcos. So this is how the bisphosphonates act to inhibit the osteoclastic bone resorption, because bisphosphonates enter the osteoclast and they prevent this ruffling of the border by which these osteoclasts eat the bone. And therefore, the bisphosphonates might be very active. So this is about denosumab, which is again a monoclonal antibody which acts against rankle. And this was a paper from the Netherlands by Westbrook and colleagues, which showed that you can have a significant decrease in the number of days where the patient will require cast if you use denosumab. And this was our paper where we studied the role of steroids, and this was published in Diabetes Care, you can see, where the methylprednisolone was used in patients with Charcos, and we compared this with zoledronic acid as compared to just total contact cast alone. So we had 3 arms, TCC plus placebo, TCC plus zoledronic acid, and TCC plus methylprednisolone. And when we wanted to study how long these patients would require a cast, or how long they will required to achieve remission. And we found out that steroids were not useful for acute Charcot's remission. The patient who were put on steroids along with total contact cast has highest time to remission, as you can see from this purple bar. Patients who were given zoledronate or who were just given the total contact cast, they had almost similar time to remission. So this study also proved that medical therapy might not be useful for acute Charcot, and only total contact cast is the modality. Now, some patient, as I was mentioning, may reach you in chronic Charcot where the bone might be destroyed. So this was the paper again where we just wanted to know what happens to the patient's foot bones when you are studying these patients of diabetes. So this was a paper from Sinecor, and they showed that those patients who had arthropathy, they had significantly low foot bone mineral density. You can see these were the patients with Charcot. These were the patients of diabetes, but without Charcot. They had a slightly better bone mineral density, and black bar is a normal control feet. You can see their bone mineral density was significantly better. So this proves that the control group BMD was 13% higher as compared to a patient who's having neuropathy, and it is around patients who have Charcot, they have 16% lower bone mineral density, and this is the main reason that why these patients have fractures and crumbling of the bones. So therefore, we thought that why we cannot use teriparatide, which has been proven and all orthopedicians and even endocrinologists, diabetologists, physicians are using in patient with osteoporosis. So we use this teriparatide in patient with Charcot, and we demonstrated there is significant increase in the foot bone. Mind it, it is the foot bone mineral density. We measured it by using a peripheral DEXA in the foot bones with teriparatide, this red bar, as compared to patient with who were on placebo. So if you just follow a patient with Charcot, if you do not treat, they would have a further decrease in the bone mineral density. But with teriparatide, there is increase in the bone mineral density, which might be useful. And this is my last slide, and this is regarding the importance of the life of a patient of Charcot. Because remember, this Charcot is not only about the foot, it is about the life of a patient. So this is again the largest study in the world, and this is from our center. This is the mortality amongst Asian Indian patients with Charcot's neuroarthropathy, a prospective cohort study in which we took 260 Charcot's patients and we matched them twice the number with diabetes patients who had neuropathy but did not have Charcot. We followed this patient over a period of 5 years, and they were matched for age and the duration of diabetes. Remember that these patients also have ulcers. Almost 1/3 of these patients had prevalent ulcers. Even Charcot also require amputation that can be because of an ulcer. So 15% also have consequent amputations. But what was surprising to us is that the mortality in these patients, you can see this blue bar represents normal, this controls of diabetes patient, and green bar represents Charcot's patient. The patient with Charcot had around twice increased risk of death in spite of similar duration of diabetes, in spite of similar age. That means the Charcot's process is doing something wrong with our patients. Mean survival in Charcot's patient was less, and you can see the odds ratio for death was around 2.7 times higher in patient with Charcot as compared to a routine diabetic patient. So never ever miss a patient of diabetes a diagnosis of Charcot whenever you see. So this is my humble request. And I would say that Charcot is associated with higher mortality, and despite being younger, they have higher mortality. So finally, the last slide, because it is mainly dealing with surgeons. Indication for surgery is a failure of conservative treatment who are patients with recurrent ulcerations, unstable foot, predominantly the hind foot Charcot, those who are having obesity, very high active level, and you want these patients to come back and be ambulatory on the plantigrade foot, you need surgical modalities. And I would conclude by saying that Charcot should not be missed. It can be easily diagnosed if you have the knowledge of Charcot. TCC is still the gold standard. Bisphosphonates have been shown to increase the bone mineral density, but effect on clinical resolution is not known. Denosumab is an attractive option. We are using as endocrinologists in patients with Charcot, and chronic patients with Charcot have decreased bone mineral density, and you can definitely use teriparatide in your patients with chronic Charcot. So thank you, and thank you for patient listening.
Thank you, Dr. Rastogi. It was wonderful, wonderful talk. And I can see that you have simplified it for the surgeons to understand. Yes, thank you so much for that. Now, there are no questions from the delegates.
I have a question.
Yeah, so I also would like to ask you a question. See, the use of steroids, as you had mentioned in one of your slides, for the treatment of the bone density and mineral. So we as surgeons have always been told that it's like an oxymoron. Steroid and the melting of bones or the increase in sugar levels. So there are two things that always rankle your mind when you're treating a patient of diabetic foot. What do you suggest what is your experience there? I mean, I'm sure you have something to share with us on steroids.
Exactly. So this all hypothesis came from rheumatoid arthritis, because Charcot's is again an inflammatory arthropathy. We know that there's a lot of inflammation going on in the joints. And everybody knows that rheumatoid arthritis is treated with steroid. We know that the bones are affected in patients with rheumatoid arthritis, but still we treat with treat with steroids. The steroid over a longer time definitely affects the bone, definitely affects the glucose control. But remember, in Charcot's, we are concerned with inflammation, and the potent anti-inflammatory drug is steroids. So therefore, we did this study. Though this study was negative, and I would not recommend steroids for acute Charcot's in any of the patients. But yes, science only progresses by doing experiments, and we have now further proved it that steroids are not useful.
So
yes, Dr. Rastogi, I have one question.
Please.
Can I ask?
Yeah, please go ahead.
Yeah. So I would like to ask Dr. Rastogi that a patient of Charcot with a diabetic foot ulcer, can we treat medically?
Yeah. So it depends. Now we are dealing with a patient of Charcot's, and I believe that this patient is having some kind of deformities, and he's having a chronic Charcot's. Therefore, he's having deformity, and on top of that deformity, he's having ulcer. Now, this ulcer can be a non-infective chronic ulcer. Probably the patient might not be offloading appropriately. So the first choice would be appropriate offloading, and that can do good wonders in these patients, even if the patient is having pes planus or even a rocker bottom deformity. But I absolutely agree with you that if a surgical option is there where an arthrodesis can be done and his deformity can be corrected, the chances of healing of ulcer would be great.
Naresh, can I ask a question?
Yeah, please go ahead.
Dr. Ruke, please.
Yeah. Dr. Rastogi, regarding this Charcot, how can you predict in a diabetic patient who will get Charcot or not? Because as in residency, we were taught that people with long-term neuropathy and all these people are bound to get.
Rajesh, you are not audible. Rajesh,
sorry.
Be loud.
I said, because how do you predict that which patient would probably land up with Charcot?
Yeah, so that is a very interesting question, and there have been papers from Dr. William Jeffcott from University of Nottingham, and the prediction of disease like Charcot's is very, very unpredictable. And why I am saying it? Yes, it occurs in patients with neuropathy, but severity of neuropathy has no relation with Charcot's. The duration of diabetes has no relation with Charcot's. The BMI or the obesity of an individual has no relation with Charcot's. So just you have to be more cautious in patients who are having neuropathy, but no vasculopathy. They are likely to develop Charcot's. The only thing is an early detection of Charcot's, but prediction is not possible.
So do you mean that the patient of neuropathy who is having a peripheral vascular disease will not have a Charcot's?
So now peripheral vascular disease is defined by two things. One, a patient who is having an ABI less than 0.8 versus an ABI patient who is greater than 1.3. So even 1.3 is also said to be a peripheral vascular disease because they don't have a typical triphasic flows. So we have seen patients, and it is very commonly seen that Charcot's occur in a complicated case of diabetes where CKD might also be existing and they would have calcified vessels. So their ABI might be more than 1.3. So by classical definition, they are having a peripheral vascular disease, but still they develop Charcot. But yes, those patients who are having critical limb ischemia, if it is not acute, less than 0.4 ABI, they are very less likely to develop Charcot. And one thing I forgot in my presentation is that most of the patients of Charcot we lost, and that because nobody did a autonomic neuropathy testing. And fortunately, in our labs, we have testing for autonomic neuropathy, especially cardiac autonomic neuropathy. And that was the most important reason for deaths in our patients. So if you have facility for cardiac autonomic neuropathy testing in a patient with Charcot, please do it. Otherwise, patient will sleep at night and will be found dead in the morning. This is a very common clinical scenario.
Ashu, one question from me.
Sir.
Nice talk. If the patient of Charcot, especially in renal food, has high creatinine levels, medically, is there any contraindication to treat by the drugs you had enlisted?
Yeah, so amongst all these drugs, denosumab is safe even in patients with end-stage renal disease or even in dialysis. So we used these denosumab in patients with chronic kidney disease.
So there is a question from Dr. Rege. Once in TCC, should the patient be totally immobile? And should TCC always cover toes or okay if not?
Yeah, for midfoot Charcot's, ideally it should be covered whole, because in West they cover whole, but I know that there is limitations in our country because of extreme hotness and humidity. So in few of the patients, we don't cover the toes. And regarding the TCC and immobilization, standard recommendation is even on a TCC, the patient needs to be completely immobilized. And we know that if you just ask your patient, you can take few steps. Few means maybe 100 and 1,000 steps to the patient. So never take this risk. Immobilization means immobilization.
Great, thank you. Vijay, you have to ask any questions. Do you have any more questions or shall we pass
No,
on?
actually just if Dr. Ruke is around, would like to ask quickly one question, whether all patients of DUF need hospitalization or can these be managed on OPD basis?
So none of our patients with acute Charcot's are hospitalized. It's not a in-hospital condition. All of these patients are managed in OP basis. We diagnose them and we gave them a cast and asked them to visit us after 7 days. Yes, if a patient is having complicated Charcot's with an ulcer, with osteomyelitis, we need hospitalization, or if reliant for a surgical reconstruction.
Milind, I have a question for you, Dr. Milind. So, patients who have undergone amputation, especially below knee amputation, are there any statistics about them for 5-year survival rate? Because I probably had learned in something which was very ghastly bad. They were saying that the 5-year survival rate of a patient who has undergone amputation is as bad as cancer. Do you have any statistics on that?
The statistics are there which shows that especially in India, I was talking about India, where the rehabilitative process that we follow are not as good as we do it in the western side. One, because of the economic condition of the patient, the change of processes that is required every 1 or 2 years is not done properly. The patient has an economic problem. He tries to get mobilized in spite of amputation. He's got a already heart which is because of diabetes and various other comorbidities not having a good ejection fraction. So with the amputation done, there is an increased load on the heart. So that is why the mortality rate after amputation, and if you don't have a proper rehabilitative policy towards the patient and you don't follow up the patient, then the patient succumbs to this problems that arise after the amputations. If you have a good rehabilitative process, a good prosthesis is given to the patient, his nutrition and other things are taken care of, then he will definitely do well with the prosthesis.
Thank you. Thank you. I think we have crossed over to the next session, the time. So I think we'll take the question answers on the chat group. I request all of you to do that. These discussions will go on, and I thank both the speakers for the excellent first session. And along with my co-chair, Dr. Vijay Shivpuje, we thank Mumbai Surgical Society for giving us this opportunity. And now back to Dr. Kamath, the MOC. Thank you. Have a good day.
Thank you.
Thank you. Thank you so much. Excellent lectures. Thank you, Dr. Naresh Rao and Dr. Vijay Shivpuje for chairing these sessions. And we thank also our speakers, Dr. Milind Ruke and Dr. Ashu Rastogi. Shall we now go to the second session? of the symposium on the medical issues in management of diabetic foot. May I call upon our chairman for this chairpersons for this particular talk, Dr. Ameya Joshi. He is a director of the diabetic and endocrine clinics in Mumbai. He is a consultant in charge endocrinologist at Bhaktivedanta Hospital and Research Institute and Corona Hospital. He is a recipient of IDF and European Society of Endocrinology Young Scholars Grant. So I think all these things will contribute towards this talk, and they will definitely give us some guidance. The next chairperson is Dr. Suresh Rao. Dr. Suresh Rao is a consultant surgeon at Sanjeevani Hospital, a very senior surgeon. He is a past president of Association of Medical Consultants and a trustee as well. He is heading the HNA cell of AMC. So I will hand over now to our chairpersons to introduce and call upon the speakers for this session 2. Thank you.
Good morning, everybody. Now, this session is going to be a medical subject, diabetes, which requires a multi-pronged attack on the treatment with the help of medical consultants to control the diabetes, diabetologists, and critical care consultants to take care of the diabetic, antibiotics required, surgeon and podologist to take care of the surgical part. Now let's talk to the two speakers in this session. Dr. Sujata Mehta. She is going to talk on antibiotics in diabetic foot, in diabetic infection. Why and when, which antibiotic. Dr. Sujata Mehta, she is an MD Medicine, DNB in General Medicine, IDCCM, IFCCM, and FNB in Critical Care Medicine, Critical Care Medicine, Fellow Critical Care Medicine, MHH, Hanover, Germany. She is a consultant physician and critical care specialist, Mumbai, Bombay Hospital, Mumbai. Dr. Sujata Mehta, please.
Good morning, everybody. Am I audible?
Yes.
Yes, you are.
Yeah.
At the onset, I would like to thank the organizers and especially Dr. Rajesh Yadav, Dr. Niranjan Agarwal for giving me this opportunity to say something in this wonderful symposium. I would also like to thank the chairpersons for introduction. So let's begin with my topic, which is antibiotics in diabetic foot infection, which and why. I think which is one of the most important cornerstones in management of diabetic infections. So let's begin with the introduction. 51% of Indians suffer from diabetes, and by 2030 AD, we'll have almost the largest number of diabetic patients in the world. Diabetic foot infections, they are associated with major morbidity, mortality, high costs, and poor quality of life. It is the most frequent cause for hospital admissions.
You're sharing your slides, or there's no slides thing?
I had shared the slides. 1 second.
No.
So you are not being shared. Just share it.
1 second. 1 second. Seen?
Yeah, started.
Yeah. So 51% of the Indians, they suffer from diabetes, and by 2030 AD, will have the largest number of diabetic patients in the world. Diabetic foot infections are associated with major morbidity, mortality, high cost, and poor quality of life. It is the most frequent cause for hospital admission in diabetic patients. It is a leading cause of non-traumatic lower limb extremity amputation. Almost 1 in 4, 15 to 25% of diabetics would suffer from a diabetic foot ulcer at least once in their lifetime, and more than 50% of these are infected. 40% would recur in a year's time, and as discussed in the previous lecture, the 5-year death risk in even diabetic foot ulcers is 2.5 times higher than in those without diabetic foot ulcers. So moving to the pathophysiology, this is a beautiful slide which explains why we get a diabetic foot. So it starts with a normal food with sustained hyperglycemia, and this is a root cause of all problems. The patient gets microangiopathy causing poor blood flow, edema, which is a substrate for the bacteria. There is always abnormal immune response, and there are other triggering factors such as abnormal architecture of the foot. There is presence of neuropathy, motor, sensitive, and autonomic, and all this finally leads to cracks in the skin, ulcers, and then there is super added infection leading to diabetic foot infections. So the diagnosis, just a quick check through the diagnosis. The clinical typical features of inflammation may be absent in diabetic patients because of their altered vascular, neurological, and immune responses. But we still can classify these wounds on the basis of the IDSA or the PEDI score, that is mild, moderate, and severe. And this is important from our treatment point of view. So mild infections are smaller infections, local infections 0.5 to 2 centimeters. Moderate infections are PEDI score 3, which are more than 2 centimeters and which can involve the deeper structures forming abscess, osteomyelitis, septic arthritis, or fasciitis. And there are severe infection, PEDIS class 4, which have got local infection with signs of systemic inflammatory response syndrome. So these patients are almost septic. Modalities of investigations could be histology, appropriate biopsy when indicated. X-rays, the sensitivities is variable, especially in early cases, but they can detect bone destructions or presence of air in foreign bodies. MRI by far is the best technique, and where available, we could do radionuclide scanning. Now let's move on to the culture. Now culture, these are a very important step in the management of diabetic foot infection. They may not be necessary in mild cases. But for moderate and severe culture infections, we always do cultures. Do your cultures prior to starting antibiotics. You should avoid taking supervised bacteria. Samples should be aseptically collected from deeper tissues after cleaning and debridement. So they should be given a thorough wash with saline, and then you can take the proper sample. Culture may be negative if the patient has already. Your accuracy of the culture reports, which is going to decide your management, it depends always on a good collaboration between the clinician and the microbiologist. So I think the clinician should always speak with the microbiologist what the clinical setting is. So it is not only the collection of the sample, but also the transportation of that sample, processing, and a comprehensive report by the microbiologist, which is of utmost importance. So let's look into the microbiota of these cultures. So if you have a superficial infection, superficial cultures usually will give you aerobic bacteria, whereas it's the deeper cultures which will give you a gram-negative growth and often anaerobes, especially if you have a fetid odor. The most common gram-positive bacteria is still staph, followed by beta-hemolytic streptococci. And the most common gram-negative bacteria found in diabetic patients is Pseudomonas. It is followed by others such as E. coli, Proteus, Enterobatraceae, and so forth. We also see a lot of geographical variations in this diabetic microbiota. In Western countries where the climate is cooler, we most commonly get gram-positive cocci, whereas in the tropics and the subtropics, what we often get is gram-negative bacteria. This could be related to the temperature changes, the hygiene practices, footwear practices, the history of prior antibiotic use, or exposure to water. What about the resistant bugs? So these are also common and the trend is rising. So the prevalence of methicillin-resistant staph aureus is almost more than 50% amongst staphylococci. Then MDR gram-negative bacilli, especially like ESBLs or the carbapenemase-producing bacteria, are seen in almost 20% of isolates, especially the patients which we receive at the tertiary care hospitals. We often get sometimes certain bacteria such as Corynebacterium, coagulase-negative staph, as reported by the microbiologist. These should be taken with a pinch of salt because they could be the common salts, and discussing with your microbiologist could be of help. So this is one paper which was recently done from Bombay, where they studied the epidemiology of diabetic foot infections. And what they found is 55% of their infections were polymicrobial. And these numbers actually match with the numbers from our hospital too. Almost 60% of them were gram-negative bacteria. 20% of these gram-negative were still Pseudomonas, followed by the others as mentioned. %of these bacteria were Staphylococcus. In this study, the incidence of MRSA was around 23%, but there are other studies, then 1% were because of fungi. A few lines about biofilms, because biofilms are often encountered in diabetic foot and they're often difficult to treat. So these are basically bacterial communities in polysaccharide matrix with altered phenotype. And we often see this in our ICU patients with the lines, catheters, and tubings. As soon as we put some foreign body, the biofilm starts forming. But in diabetic foot, these are commonly seen with resistant bugs such as staph and MDR. They delay the wound healing due to poor penetration of the antibiotics. So they need to be tackled. They can be removed with debridement, and we have drugs which can penetrate these biofilms. Some of the drugs like rifampicin, dactomycin, phosphomycin, they have excellent penetration in the biofilms and can be useful in such situations. So now coming to the main topic of antibiotics, which, when, and why. So how do we select it? We are depending upon the medical history. We see what is the patient's medical history, how or the age of the patient, what are the organs involved, are there any renal failure, hepatic failure, and then we select the proper drug. What is the local epidemiology of your hospital? Which is the most common bug? What is the resistance pattern of that hospital? What is the clinical context of this disease? Whether it's a new patient, it's a chronic patient, it's been treated before, amputated before, you need to understand that. How severe is your infection? As we discussed before, mild, moderate, and severe. What do the cultures show you? And how is the clinical response of the patient? Is he getting better or is he worsening? So the route, the dose, and the duration, it is decided by the severity of the infection. The more the severe infection, we use larger doses and we use a parenteral route. Presence or absence of osteomyelitis also decides what kind of antibiotics and duration we need to use. The response to the treatment, what is the extent of vascular insufficiency? Always remember that the duration of the antibiotic treatment is till the infection is resolved and not till your wound heals. So for mild infections, we can give oral antibiotics for a period of 1 to 2 weeks. Whereas for moderate infections, we can give oral or IV depending upon the situation for 2 to 3 weeks. For more severe infections, we require parenteral drugs and usually for a longer period of time, around 2 to 3 weeks. If infection continues beyond 4 weeks of appropriate treatment, then we need to reevaluate that why this patient is not improving. We need to consider further diagnostic studies or alternative treatment. If you have a case of osteomyelitis and if you have not surgically treated it, then you may require prolonged period of treatment, even up to 6 to 12 weeks. Coming to the empirical therapy, certain important points. There are no role of antibiotics in an uninfected wound. I think all of us agree with it. Acute infections in a previously untreated patient in temperate climate, they're usually caused by gram-positive cocci, staph and strepto. So you need to address them. But for patients coming from our part of the world with or patients who have a prior exposure to antibiotics or who have an ischemic limb or with moderate to severe infections, the regimen should cover for gram-positives, common gram-negatives, and anaerobes. If we have deeper and chronic infections, they are usually polymicrobial, having all the entire spectrum of gram-positive, gram-negative anaerobes. So you should cover that. When do we cover for Pseudomonas? If Pseudomonas was isolated in the previous cultures, yes, you should treat it. In tropical countries with moderate to severe infections, you should keep it in mind. And also patients who have frequent exposure to water. What about MRSA? Do we cover for all patients? We use MRSA for the following indications. If a patient has a previous history of MRSA infection, if you have known colonization with the previous year, if you have a failure of the first line treatment, if you have a recent hospitalization, or if the patient comes from a residence in a long care facility, or if you have osteomyelitis and necrotizing fasciitis, then you think about MRSA coverage. So let's move on to the actual drugs used for mild diabetic foot infections. So if your patient is having mild infection, and there are no complicating features, you could use simple antibiotics, which we use. Think about a gram-positive coccus infection. We could use antibiotics such as like your amoxiclav, ampicillin, sulbactam, dicloxacillin, or the first generation cephalosporin. If a patient has beta-lactam allergy, then you omit these drugs. You can use alternatives such as quinolones, doxycycline, or clindamycin. If you have a history, recent antibiotic exposure, then most of all these antibiotics must have already been used. Then you move on to either the second or the third generation cephalosporin, and you can use either a quinolone or a doxycycline or a clindamycin with it. if you have suspect a high risk of MRSA, as we already discussed, then we need to use antibiotics which are susceptible, for which the MRSA are susceptible, such as clindamycin, doxycycline, and sulfamethoxazole. If you have a moderate to severe infection, again, if you have a simple moderate to severe, no other complicating features, you can use a second or a third generation cephalosporin with or without an aminoglycosides. And now we have newer aminoglycosides, which are also better and less nephrotoxic. If we have a recent antibiotic exposure, then straightway go to a third generation cephalosporin, such as if you have like ceftazidime, cefotaxime, ceftriaxone, and you can add an aminoglycoside to it. You can also use alternatives such as piperacillin tazobactam or cefepime, or even a carbapenem sometimes. If you have a very badly macerated ulcer or patients coming from warm climate, you think of adding for a pseudomonas coverage. So you could use antibiotics such as piperacillin tazobactam, cefepime, ceftazidime, carbapenems, and even colistin. If you have a very bad necrotic gangrenous ischemic limb, then you definitely cover for gram positives, gram negatives, but you also need to add a good anaerobic cover. So good anaerobic cover, usually metronidazole, clindamycin are excellent, give an excellent coverage for anaerobes. If you have a MRSA, suspecting an MRSA in a severe infection, then you go on to parenteral glycopeptides such as your vancomycin, teicoplanin, linezolid can also be used, and daptomycin is an excellent drug, which is bactericidal, can be used for an MRSA infection. If you have a resistant gram-negative bacteria, then you straightway move on to the higher antibiotics like your piperacillin tazobactam, your carbapenems, colistin, or the newer lot. A few lines about diabetic osteomyelitis, because this also is a part of the deeper infections. So all this while, surgical therapy in osteomyelitis was the gold standard of care. But now recently certain studies have shown that if you give effective antibiotic therapy in certain selected population cases, then they can be equally effective. And what are those cases? Cases who have limited disease of the forefoot, patients who are medically fit, they have no evidence of a peripheral vascular disease. In such patients, you can definitely try the antibiotic regimen. So we need what antibiotics to select for osteomyelitis. So we have to see which antibiotics have a good penetration in the bone. So some of the examples are beta-lactam. Beta-lactam is inhibitors such as ampicillin, salvacin, piperacillin tazobactam. Even oral drugs, oral and parenteral drugs like clindamycin, fluoroquinolones, rifampicin, they have very good concentration in the bones. We can use combination of drugs usually, because here we need to use antibiotics for a prolonged period of time. And combinations would prevent the development of resistance. So we could, if you want to put the patient on oral antibiotics later, you could add a combination such as rifampicin with a fluoroquinolone. Remember that we always have to use optimum doses. So always the doses need to be a little bit on the higher side of normal, because we want to have adequate concentration in the bone. And we have to give it for prolonged period. So 6 to 12 weeks is usually recommended for non-surgically treated patients. We can start with an initial parenteral therapy followed by oral therapy, which can be effective, cheap, and safe, as already discussed. So typical combination would be something like an IV glycopeptide such as vancomycin or a targocid, teicoplanin, which can be combined with an oral drug such as rifampicin. And we can also include coverage for gram-negative and anaerobes wherever indicated. All these patients who have not undergone surgical treatment will require a long-term follow-up clinic for evaluation. Some patients who have a retained prosthesis or extensive necrotic bone, which is not amenable to debridement, these patients can be given long-term suppressive therapy. So just in brief flowchart to tell you what we discussed so far. So if the patient doesn't have an evidence of infection, yes, no further infection required, but yes, you assess the severity of the infection. The first step, is it mild, moderate, or severe? Depending upon that, we decide, is the antibiotic naive or he has already received antibiotics? Does he have a penicillin allergy? And could there be an MRSA or any other special circumstance such as pseudomonas? If you have, once we have categorized the patient and we have discussed where each antibiotic stands, we can decide the empirical therapy. And finally, once we get the culture reports, we need to amend our therapy based on the sensitivities and clinical response. So what's new? Do we have some new antibiotics which could be easily used? So linezolid is not a new antibiotic, but still I put it here because I wanted to discuss it since we all use it very commonly. Daptomycin is an excellent antibiotic for gram-positive coverage. It's bactericidal, and since it's very not used so commonly, its sensitivity is very high. We have certain newer cephalosporins, the class 5 cephalosporins, such as the ceftaroline, which have excellent gram-positive, gram-negative coverage. They have been introduced by Pfizer in India. And we have certain neoquinolones which are now available, like the levonorofloxacin. The advantage of this drug is that the IV and the oral formulations both are equally bioavailable. That means if you want to treat the patient at home with oral drugs, it's possible, saving cost to the patient. And we have certain newer aminoglycosides such as the isipamycin, which is also a very good coverage for gram-positive, certain gram-negatives, and has got no nephrotoxicity. So few words about linezolid, since we all rampantly use it. So this is a bacteriostatic drug to start with. It does cover the MRSA. It has a good oral bioavailability. That means even if you give IV and oral, it makes no difference. It can limit the fluid load to the patient if you give oral antibiotic. It permits outpatient treatment and hence saves cost. The therapy is limited usually for linezolid to 2 weeks and not more than that because it has certain side effects. So you should always monitor your patient when he's on linezolid. And what are those side effects? The patient can develop peripheral and optic neuropathy, and this can come quite early in the disease. Patient can come with bone marrow suppression. This is a very common finding when we see the patients with linezolid treatment. The patient often presents with thrombocytopenia, leukopenia. The first thing is to stop your linezolid. Some patients very rarely can develop severe lactic acidosis. Patients who are on SSRIs, these are your antidepressants like your fluoxetine and your escitalopram, which we so commonly use. So in these patients, linezolid can cause something called as a serotonin syndrome, where the patient presents with severe tachycardia, patient has hypertension, abnormal behavior. There could also sometimes there could be a risk of hypoglycemia, as this alters the insulin sensitivity. So this molecule can be used, but you need to monitor the patient. Role of topical antibiotic, just to cover my antibiotics topic, there is no robust evidence to support its use. IDSA says no role, but certain communities such as Wounds International say may be used as an adjunct when there are concerns of poor blood supply and in a non-healing ulcers with increased bacterial load. We finished with the antibiotics, but just one slide I wanted to put from the physician's perspective that most of your diabetic patients would be on these commonly used drugs like metformin, SGLT2 inhibitors like your dapagliflozin, empagliflozin, loop diuretics, ACE inhibitors, and ARBs. So these patients, when they are acutely ill, when they are septic, you need to be discontinued because they have certain side effects on such acutely ill patients. In that period of time, you can switch them over with some other drugs. So in the end, I would like to say that with appropriate selected antibiotic therapy, combined with necessary wound care and surgery, which is equally important, most diabetic foot infections can be successfully treated. So a take-home message would be avoid unnecessary antibiotics for non-infected wounds, appropriate cultures to be taken when indicated, know your local epidemiology. For tropical countries, additional coverage for gram-negative bugs, including Pseudomonas when clinically indicated. Resistant bugs are on a rise. Osteomyelitis needs prolonged treatment, and wound care and timely surgical debridement are extremely important to give a good result. In the end, I would like to thank all my surgeon colleagues here, my surgeons and plastic surgeons, without which it would be difficult to manage this Herculean task. Thank you.
Thank you,
Thank you, Dr. Sujata Mehta, for having given an excellent view of the role of the antibiotics in management of diabetic foot. Now, we are not yet, there was one question somebody asked about, Dr. Vivedi asked about the streptomycin powder local application, which was quite well frequently used in the olden days, but I don't think at present anybody uses. Can you guys suggest your views?
We don't use it, sir. I mean, streptomycin powder. It could still be absorbed locally. It could still have side effects, and we have better molecules right now. So I think this was something which was used in the past. Nobody is using it right now since we have safer alternatives.
I have a question.
Any other question?
Yeah, Dr. Sujata, can I ask the question?
Yes, Milind, go ahead.
Dr. Sujata, last year we had a series of 27 patients almost. The culture report showed all the antibiotics which were studied resistant to the uh, antibiotics. In such scenario, what kind of antibiotic you use, uh, what is recommended, are we supposed to increase the dose? Like we started using Zavicefta with azritonam in a double dose, and at least uh, 25 patients became all right because of those. So is there any strategy for such kind of patients, especially pseudomonas, some strains of Klebsiella and Staphylococcus, where
Yeah. So
your culture report shows resistant to almost all antibiotic studies?
yeah. So a very good question. Actually, Staphylococcus MR are almost in most of our hospitals. They have shown very good sensitivity, almost 100% sensitivity to our drugs that we use, like the vancomycin, teicoplanin, daptomycin, dinazolid. They are almost 100% sensitive. In our parts of the world where we do not use MRSA coverage so much, we are blessed because our antibiotics are still 100% sensitive, the higher line antibiotics. Now, regarding the gram-negative organisms, we are facing a lot of problems all over. As you said, I'm very surprised that all 27 isolates were almost completely XDR organisms, I mean, resistant to all the bugs, because somewhere or the other, we do find, I mean, in our setups, at least we are getting organisms if resistant to everything, they're still sensitive to colistins, most of them. So we can use, usually, like, for example, if we have a Klebsiella group of organisms, these organisms have, I mean, certain antibiotics have got preferences for certain bacteria. Like your Klebsiellas are usually susceptible to colistin. If we give an adequate loading dose of colistin and give full-fledged dose of colistins or polymyxin B, they are usually sensitive to it. We can, if they are resistant to it also, to the colistin, then we have certain other antibiotics which are now come to the pipeline. As you said, the Zavicefta, the ceftazidime and avibactam with aztreonam. The reason for the combination of these two drugs is that the ceftazidime, avibactam, it tackles one resistance pattern which is called an OXA48 in the gram-negative bugs, whereas the aztreonam will tackle the NMD, that is the other kind of resistance which is seen in this gram-negative, and together they form a very good combination, aztreonam plus Zavicefta. So this kind of antibiotic coverage, I mean, we have to do some jugglery actually in these patients, try which antibiotics are used, or sometimes we use certain antibiotics just as which can alter the penetration of the drugs in the molecule or will evade the resistance pattern of the bacteria. For example, we have the EDTA molecule, which will prevent the development of resistance in the bacteria. So somehow or the other, we do some jugglery and try to tackle over that period. And sometimes our age-old molecules like Septran, chloramphenicol still come handy when everything else fails. So we
One
need to
important
request our microbiologist.
Chairperson, please take the next lecture because time is already up for this. The question answers can continue in the chat box for this.
Doctor,
Thank you,
Dr.
Dr.
Amay.
Mehta. That was a wonderful presentation.
Amaya, you're not audible.
Am I audible now, sir?
No, you're not. Yeah, better.
Yeah, thank you, Dr. Mehta, for that wonderful presentation. We now move on to another important topic, that is about glucose control in a patient with diabetes foot. And to guide us about this, the guiding principles for surgeons for glucose control in diabetic foot, I would like to invite my good friend, Dr. Manoj Chawla, who is consultant diabetologist at Asian Heart and SL Raheja Hospital. He is an academically active diabetologist with prominent roles in RSSDI and United Diabetes Forum, and to guide the surgeons about the guiding principles of glucose control in diabetic foot, I'll hand it over to Dr. Manoj Chawla. Dr. Manoj is experiencing some network issues probably, so I think he has sent a pre-recorded presentation. I would request the organizers if they can play that, and then we can have some questions as need be.
Good morning, everyone. Let me start by thanking the Mumbai Surgical Society and Dr. Milind Ruke for inviting me to share my thoughts on this surgical platform. It's a pleasure being here and pleasure being amongst everyone. Wish we could all be together and not on this virtual platform, but I'm hoping that things will change soon. So the topic that I've been asked to speak on is control of sugars, guidelines for surgeons or what surgeons need to know. So I shall be speaking about the burden and risk for perioperative hyperglycemia, the principles of perioperative hyperglycemia management, and postoperative hyperglycemia management. Let's first understand the connect between diabetes and hospitalization. Diabetes does increase the risk of hospitalization many-fold. Diabetes increases the risk of hospitalization by almost 2 to 6 times versus individuals without diabetes. It also increases the mean duration of hospitalization. And amongst the cost incurred for diabetes management in India, about 50% is attributed to the hospitalization cost. What would be the association between HbA1c and risk of hospitalization? Again, very interesting to understand that persons with diagnosed diabetes and those who have an HbA1c of higher than 7%, they have the highest rates of hospitalization as compared to those with either a history of no history of diabetes, or those who have history of diabetes but their HbA1c is considered under good metabolic control, which is less than 7%. So if we further look closely in this aspect, 3.1 times higher than those without a history of diabetes, that is the risk of hospitalization, and 1.5 times higher than those with diabetes but at under good control. So clearly, if you have diabetes, there's a huge need for keeping your glycemia and your HbA1c under target control to avoid the increased risk of hospitalization. Now let's look at the burden and the risk of perioperative hyperglycemia. An estimated 25% of patients with diabetes will require surgery at some point in time. The mortality rates in diabetic patients have been estimated to be up to 5 times higher than in non-diabetic patients. Chronic complications directly increase the need for surgery and the incidence of surgical complications due to infections, vasculopathies, and so on. Infections account for 66% of post-op complications, and nearly 1/4 of perioperative deaths in people with diabetes is the occurrence, and tight glycemic control is important to minimize the infection. We did hear a wonderful lecture about the usage of antibiotics and the right kind of antibiotics needed. But the crux of it lies in the fact that you need extremely good glycemic and metabolic control to avoid this risk of infections and prolonged morbidity. So tight glycemic control, especially in the perioperative period, is extremely important in patients undergoing surgeries. So let's look at the connect. Why does perioperative hyperglycemia happen? There will be some genuine cases of pure surgical stress or anesthesia stress. Factors which determine the severity and duration of stress hyperglycemia do depend on the types of surgery, the location in the body of the surgery, how invasive is the procedure, and the use of intraoperative fluids and the kind of nutritional support which is provided. All of this will decide the nature of hyperglycemia. The type of anesthesia also has an impact. So, of course, general anesthesia is associated far more frequently with hyperglycemia due to higher levels of release of catecholamines, steroids, glucagon, rather than just the local or spinal anesthesia. Now, as we can see here, the connect is clear. You have surgical stress. There is hormonal counter-regulatory response. So you have the release of all the counter-regulatory hormones, catecholamines, glucagon, steroids, all of these opposing the action of insulin in the body. There is reduced insulin production from the pancreatic beta cells. There is increased lipolysis. So in presence of relative insulin deficiency, you will have the adipose tissue breakdown, release of more free fatty acids. There is increased delivery of these free fatty acids to the liver. At the same time, there is deposition of more lactate and amino acids coming to the liver. All of these are substrates for gluconeogenesis, glycogenolysis, increasing the hepatic glucose output. Directly or indirectly, through multiple pathways, all of this is contributing to further hyperglycemia. Now, hyperglycemia in and around the presence of a surgical period can be devastating because it will cause further mitochondrial injury, would add to the endothelial dysfunction, cause immune dysregulation, and of course the generation of superoxide ions, as we understand as free oxygen radicals, which will worsen the cell damage. How would hyperglycemia affect wound healing? And this is common for any kind of wound healing, any kind of surgery in a patient with diabetes. So diabetes would lead to hyperglycemia, inflammation, micro or macrocirculatory dysfunction, hypoxia, along at times with autonomic and sensory neuropathy, impaired neuropeptide signaling. What does all of this lead to? A very pro-inflammatory phase. You have a lot of neutrophils at the site, altered macrophage, increased levels of pro-inflammatory cytokines, be it today the TNF-alpha or the interleukins and so on. You also have increased in proliferation at the cellular level. Endothelial dysfunction would lead to impaired angiogenesis or impaired vasculogenesis. You have the decreased fibroblast proliferation and migration. So that's again all adding to your what we generally call as altered immunity in a person with diabetes. Well, this is what is actually happening at the microcellular level. Decreased keratinocyte differentiation and migration, reduced growth factors, all of this delaying any kind of wound healing. Also, the remodeling phase needs to be impacted. Diabetes is going to have multifold impact on wound healing. Let's now come back to the principles of perioperative hyperglycemia management, which every surgeon knows and knows to include the teamwork there to ensure that you have the best outcome post a surgery. Important to screen all your patients undergoing surgery. So screen all patients undergoing any intermediate or major surgeries by checking their HbA1c. ADA also recommends an HbA1c test for all patients with diabetes or hyperglycemia. So those who don't have an history of diabetes do at least a random blood sugar. If it comes more than 140, you repeat that. And if in doubt, you subject them to an HbA1c, which will help you diagnose even patients with undetected diabetes in the past. So preoperative assessment would include everything about the history of the patient, right from the patient's symptoms to the eating habits, the current medications, person with diabetes. You want to know the exact medications that they are taking, their last blood glucose readings, when was the last fasting PP, HbA1c done, any previous or current infections, consumption of tobacco, alcohol, etc. And in the physical examination, you will subject them to a routine general and systemic thorough examination. What are some of the specific preoperative management measures? Well, general principles to minimize hypoglycemia and the incidence of excessive hyperglycemia should guide your decisions around the surgical period. Preoperative assessment for hyperglycemia and hypoglycemia is important. You want to avoid extreme hyperglycemias and, of course, hypoglycemia around the perioperative period. In general, the oral regimen should be discontinued minimum 24 hours before surgery. And this is largely true for major and supramajor surgeries. For these patients, insulin may be administered to them either subcutaneously or in a continuous intravenous insulin infusion so that you are able to maintain optimal glucose controls. And I will be talking more specifically about what really is the regime that we need to follow. So when we talk about the oral medication use, I think this in a nutshell explains what should be done for the use of OHs. Now, yes, all my surgical friends would very often include a physician, a diabetologist, an endocrinologist for help there. But as a surgeon, you also probably would know what has to be done in case you are in a limited resource setting and need to take the decision yourself. So metformin, day before surgery, in general can be taken. On the day of surgery, if the intake is normal and you do not anticipate any major delays or it's a minimal invasive surgery, metformin can still be used. Well, if the surgery is going to be where you anticipate reduced post-operative intake, GI surgeries, etc., or extensive surgery, prolonged surgeries, supramajor surgeries, whether it's an extensive diabetic foot or it's an extensive CA surgery or other aspects, you will of course hold metformin. Well, there is a disclaimer here for us to remember that if your patient on metformin has a low GFR below 45, or you anticipate the use of an IV contrast or dye, then it's best to hold metformin even 24 hours before that procedure. As far as glitazones are concerned, on the day of before surgery and day of surgery, if it's minimal, you can take that. For any major surgeries, you will be holding the glitazones. So when you talk about major surgeries, prolonged surgeries, oral intake affected, as you can appreciate, hold all the OHAs. DPP4 may not continue, but the rest, all of them have to be held. When it comes to SGLT2 inhibitors, the drugs very much in news nowadays, it's preferable that you hold the SGLT2 inhibitors from 24 to 48 hours before any kind of surgery. DPP4 inhibitors in general safe to take. Secretagogues like sulfonylureas, you can continue, but watch out for hypoglycemia. Minimal surgeries, you can use half dosages on the day or just hold it on the day of the surgery. But any prolonged surgical process which may affect the intake, best to hold sulfonylureas too from a day before the surgery. What about insulins? Well, it completely depends on the nature of the insulin. So in general, the long-acting basal insulins, we would reduce the dose by 20 to 25% the evening before the surgery to prevent hypoglycemia, as most patients would be kept nil by mouth from the previous night. Ultra long-acting basal insulins, the extreme long-acting ones, you ideally start reducing the dose even 2 to 3 days before the surgery if it's a planned surgery. The intermediate-acting insulins like NPH, in usual, the evening prior, the dose in the previous evening can be reduced by 50% if the patient's intake is not proper, or you again reduced and brought the patient down to liquid oral intake. If it's for minor surgeries, the previous night's dose can be given as same. On the day of the surgery, you could use a glucose insulin infusion, or if you're giving a light breakfast, you can give 50% of the dose of the NPH or the intermediate-acting insulin. Premix insulins, preferably patients may be shifted to a long-acting insulin ideally. Having said that, in most settings, you will not change the insulin for a day or two. So you can use the premix insulin, but reduce the dose the night before and avoid on the day of the surgery. Again, a lot of this depends on the nature of the surgery, and which is where that teamwork between the surgeon, the physician is going to be important to understand how long will the surgery last, how long is this patient going to be NBM, and then take the appropriate decision. So some of the other preoperative management measures during the fasting state, the bolus insulin is held. So obviously you don't want to use bolus insulin, and you may just give the subcutaneous corrective dosages when the sugars are high in any kind of a surgical procedure which is going to require a prolonged timing or nil by mouth and regular monitoring of sugars. In those patients who are critically ill, it's always better to shift to your insulin pumps, the intravenous insulin infusion pumps, and keep checking sugars 1 to 2 hourly, and then adjust the dose of the IV insulin as per any protocol that you're following. A lot of hospitals have their own protocols, or you may use any of the published protocols which are available today for anyone to follow. Diabetic patients should preferably be scheduled for surgery early in the day, and I think that's extremely important. For a lot of hormonal changes that happens in a patient with diabetes, the fact that they have to be kept nil by mouth, things have to be planned ahead, there's always an appeal to surgeons across that try and keep your patients with diabetes as priority in the early morning. Unfortunately, there are various factors which would define, and very often in a hospital which has predominantly diabetes work, you may have 4 or 5 patients that the surgeon has to operate on the same day, and most of them are people with diabetes. So it will go down to afternoon and late evening also. But where possible, let's keep our diabetic patients as preference in the mornings. Hypoglycemia is actually sugars of less than 70. And if the patient is not nil by mouth and can take orally, you should always prefer to give oral glucose or glucose gels or glucose powders. But where patient is nil by mouth or has had an episode of hypoglycemia which is making the patient drowsy, use intravenous glucose to correct the hypoglycemia and get the patient out of hypoglycemia, especially in the preoperative period, and maybe delay the surgery by an hour or two till you correct the hypoglycemia. On the other hand, if the patient's sugars in the preoperative period are extremely high, you may either delay the surgery if possible, or again use insulin either subcutaneously or preferably in an insulin drip to get the sugars down at least to below 200 and 180 to be in an acceptable range for the surgery that day. During the surgery, the key points to remember for intraoperative glycemic control is try and keep the glucose levels between 140 to 170. A lot of our anesthetist friends will not be happy as the sugars start coming down to 100 because that obviously increases the chance of going into hypoglycemia. The physician, whoever is helping there, must take into account the length of the surgery and then decide the strategy for intraoperative glucose management. For minor surgeries, preoperative glucose protocols may be continued. IV insulin, as I've said earlier, is a very effective method, especially if it's a prolonged surgery or any complex surgery. And in patients with type 1 diabetes, we can follow the general principle of using insulin at the rate of 0.5 to 1 unit per hour. And that can be used in any of the insulin infusion protocols that we follow. In patients with type 2 diabetes, in general, because of insulin resistance, and that typically tends to worsen around a perioperative period, the insulin requirement may go up to 2 to 3 units per hour. You look at the intraoperative glycemic control measures. Well, again, we speak about this specifically. If the surgery has a duration shorter than 4 hours, patient has hemodynamic stability, minimal fluid shift, you will do 2-hourly subcutaneous correctional insulin. That also is possible. But surgeries which may last more than 4 hours, it's better to have your insulin, your glucose insulin drip, or a continuous insulin infusion, depending on the infrastructure in the hospital that you're operating, and measure sugars every 1 to 2 hours to ensure that patient's glycemia is maintained during the operative period, avoid extreme hyperglycemia, and definitely avoid hypoglycemia. What about the post-operative hyperglycemia management? So I think it's important here that when we talk, what even as a surgeon one needs to know is the pre-operative assessment, the things to be done during the surgery, and importantly, what has to be kept in mind in the post-operative period. So what are the glycemic targets for a hospitalized patient in the post-operative period? The ADA 2021 talks about if the patient has persistent sugars of more than 180, start insulin. Target glucose range in the 140 to 180 period. Well, in some select patients, you may target 110 to 140, cardiac surgeries, etc. You may want to keep that specifically there to avoid the infection of the sternal wounds. Or on the other hand, if your patient is extremely elderly or terminal ill, CA surgeries, etc., you may want to go a little lenient on even the glycemic control. The RSSDI 2016 in-hospital glycemic management guidelines, of which I'm extremely proud to have been a part of, which we released in 2016, is also very specific and says glycemic target in ICU ideally to be preferred between 140 to 180. In the non-ICU setting, what's a good target? Keep the patient's fasting sugars between 80 to 120. Pre-meals less than 140, and post-meal is good to be less than 180. That's going to be keeping your patients under good control and avoiding any post-operative glycemic related complications. For in the post-operative patients who continue to be critical and are in an ICU setting, again, if the sugars are more than 180, start the insulin. In these setups, you're going to use IV insulin. And by using IV insulin in any of the protocols, you should maintain the sugar between 140 and 180. As said earlier, in certain specific scenarios, like post-CABGs, etc., you may want to keep it at 110 to 140. Blood glucose monitoring by using either an SMBG, or today continuous glucose monitoring systems are being used more regularly even in hospital and ICU setups. Measure the sugars every 1 to 2 hours. In the post-operative patients who are non-critically ill, it's important for us to make a note of patients' feeding status. If the patient has moved to taking regular oral intake, insulin regimen very often can be the standard basal bolus regimen. You are giving a long-acting basal insulin at bedtime, usually measuring the sugars in the daytime pre-meals and giving short doses of bolus insulin. So that's the standard procedure there. There are clear means of calculating the total daily dose of the person, and which I will leave to the specifics of the physicians deciding. But the total daily dose can be decided based on the patient's requirement, and 50% of that can be given basically as basal insulin at bedtime, and the remaining 50% can be divided into short dosages of bolus with every meal. And that's the best policy that is followed, again, to remind that this is what works and not our earlier means of sliding scales. So sliding scales have been the thing of the past, and that creates an area where the patient sugars rise. You give more insulin, patient goes into hypo, you stop. So sliding scale has largely been abandoned, and it's the basal bolus regime which is now practiced worldwide, and that is what should be done. This is an example of a correctional insulin protocol. As I said, there are different protocols which you can follow. This is just one of them, giving an example of how much extra insulin you may give if the patient's blood glucose lies in any of these ranges. So as you can clearly see, if the patient sugar is in the higher range of 180 to 220, you may want to use 4 units of any short-acting insulin as an additional insulin there. Post-operative ambulatory period, well, continuous glucose monitoring with either intravenous or subcutaneous insulin in
Yeah, Ameya, you can take the question answer. I think the video for 20 minutes was done.
I was thinking that probably it is already about time. Should we allow a question or two, or because I think the speaker is
If
also
there are
not there.
any important question, one or two you can take. Otherwise, we can move to the next session.
Yeah, I think I couldn't see any in the chat box, so maybe
Fine.
we
Then,
can move to the next
then
session.
Manmohan, please take over.
Thank you, sir, for the opportunity, and over to the organizers.
We are obliged by your presence, Ameya.
Thank you, Ameya.
Manmohan, start the next session. Dr. Kamath?
Yeah, sorry, I had there are some connectivity issues.
No issues.
Yeah, so now we'll begin. Thank you so much, our chairpersons, for this session, Dr. Ameya Joshi, Dr. Suresh Rao, and our speakers, Dr. Sujata Mehta, Dr. Manoj Chawla. So now we'll go on to the session 3, the symposium on recent advances in management of diabetic food. The chairperson for the same is Dr. Pratap Varute and Dr. Dhyanesh Belekar. Dr. Pratap Varute, a very good friend and consultant surgeon from Kolhapur. He is instrumental in forming and registering the 2 societies in Kolhapur, that is Kolhapur Surgical Society, that KSS, and Society of Critical Care Medicines at Kolhapur. He is a joint organizing secretary, Massicon 2008. He has organized many operative workshops, and he is organizing secretary for the FIAGES and IAGS skill courses. He is honorary secretary of FIAGES and IAGS and honorary treasurer for the first Maha Criticon. He is organizing secretary to Massicon 2018 and a president of Maharashtra State Chapter ASI 2017 and 18. He is an elected Governor Council member of ASI 2019 to 2021 from Maharashtra. Then we'll have another Dr. Belekar is another chairperson who will be there with us. Dr. Belekar is the executive committee member of Maharashtra Mumbai Surgical Society. So may I hand over now the proceedings to the chairpersons to conduct the symposium on recent advances. Dr. Yeah.
Thank you, Manmohan. Thank you for the wonderful introduction. Thank you, Niranjan Agarwal, sir, President Mumbai Surgical Society, for inviting me to chair the wonderful session of today morning, that is recent advances in the management of diabetic foot. As you all know, the diabetic foot treatment has evolved in a recent past, and many new modalities of treatment and have come up with the event of today's scenario. So to talk about the first lecture, we have a first topic is of PODO scan. which will be delivered by Dr. Rajiv Singh. The time limit is 18 minutes and the question answer session is 12 minutes. Over to you, Dr. Rajiv. Dr. Rajiv is a consultant diabetic foot surgeon at SL Raheja Hospital, Nanavati Multispeciality Hospital, PD Hinduja Hospital, Tunga Hospital, Malad, and Karuna Hospital, Borivali. He is a director of Murari's Health Center, Ghatkopar. He had been a speaker at multiple national and international conferences, and he has published 13 national and international papers under his name till date. Dr. Rajiv Singh, please. Yeah, Rajiv, you can go ahead.
Yes, sir.
You can share your screen.
Yes. Good morning, everyone. I would like to thank Dr. Niranjan Agrawal sir and Rajesh Yadav sir to give me opportunity to talk in Woundcon. I'm going to talk about photo scan. Let the foot speak about your foot problem. As we all know, the diabetic foot lesion is like iceberg. Only small part is visible. This is the small example. This is small scar we can see on the below the lateral malleus. After operation, it is a big wound which is reaching till the below knee.
You can't see the screens, Rajiv.
Slides are not visible.
Slides are not visible, Rajiv.
Now it's visible, sir. Hello.
Yeah, it is.
Yeah. Good morning, everyone. I'd like to thank Niranjan Agrawal sir and Rajesh Yadav sir to give me opportunity to talk in this Woundcon. I'm going to talk about photo scan. Let the foot speak about your foot problem. As we all know, diabetes is the emerging problem in the developing and developed world. By 2035, it is expected to be 625 million people with diabetic in the world, and India will be the capital of diabetes. A diabetic foot lesion is like iceberg. Only small part are visible. This is a small example. A pre-operative, a small wound is seen below the lateral malleolus. After operative, it is reaching till the below knee. Worldwide, every half a minute, a diabetic lose a part of a foot and the leg to the amputation. If we see the 5-year mortality rate, diabetic foot ulcer fall next to the lung cancer and pancreatic cancer, that is 45%. Now, let us talk about photo scan. What is photo scan? A photo scan is simple, non-invasive, accessible abnormality of the nerve based on the plantar distribution of pressure. A most efficient and accurate way to assess the plantar pressure distribution system of the static, dynamic, and postural. Enable precise immediate evolution condition related to the diabetic foot. Plantar pressure system is based on the science of pedobiography that measures and scans the pressure area extracted on the human foot involved in doing any physical activity. This is how we do podo scan. Human evolution from quadruped to the biped. Human feet is also under evolution. Human foot has culture variation. Indian feet has shallow medial arch. Shallow medial arch increase the medial mobility at the mid-tarsal joint. What is biomechanism of normal foot? Heel strike in the central. Pronation is controlled by small muscles. First metatarsal contact time is less. Weight shift from first metatarsal joint to the other metatarsal joint. Supination of forefoot is complete stance phase. Plantar fascia is important component of foot. Plantar fascia gives stability to the foot intake of position. Small muscle control reduce the shear force, energy efficient biomechanism. This is flow chart of the gait. First we stride our foot, followed by stand and swing. Stand, weight acceptance and single limb support, and swing, limb advancement. This is normal walking cycle. Initially, we can see the heel strike to the ground. Same thing we can see on the pedogram. Forefoot contact, then heel lift, followed by toe lift. It can be divided in the three phase: heel strike phase, mid stance phase, and propulsion phase. Heel lift and toe off. If we divide the timing, 60% normal walking gait cycle is spent on the stance phase, about 40% in swing phase. Timing, 15% we start at 0%, 15% on the heel strike at this stage, followed by the mid stance phase, then lifting of the propulsion phase, and followed by the toe off, that is 100%. Same thing we can see on the pedogram. Heel strike 15%, followed by mid stance phase, the forefoot contact about 45%, heel lift 60%, on propulsion phase, and toe off about 100%. There's different type of foot pressure measurement system: ink pad, foam pad, Harris mat, static foot pressure measurement system, digital foot pressure photography, dynamic foot pressure measurement system, in-shoe pressure measurement system, gait analysis laboratory. What does the podo scan show to us? It is the pressure divided by time distribution under the foot during static and dynamic measurement. What the gait lines show us? It is anterior-posterior acceleration of the center of the pressure or medial-lateral displacement center of pressure, pronation or supination of the rear foot, midfoot or forefoot, or displacement of center of gravity. This is a small video of the normal walking cycle. Heel strike, forefoot contact, heel lift, and toe off. This is normal dynamic static pedogram showing the plantar pressure. And this is, we can see the small video of pedograph, heel strike followed by forefoot, heel lift, and toe off. Why podo scan? Foot ulcer in diabetes complication of medical disease is not a primary surgical disease. Pathobiomechanicism changes due to advanced peripheral neuropathy in main etiological factor. Adequate and proper understanding of diabetic peripheral neuropathy altered biomechanism is essential for preventing high-level amputation. Diabetic foot ulcer is biomechanical problem. No amount of antibiotic or dressing will heal the ulcer unless the pressure is reduced. What is the factor contributing to the pressure formation? Moisture, friction, poor blood circulation, foot deformity, pressure, and neuropathy. As we all know, the contact time increase lead to the capillary pressure, which lead to the collapse of vein, which followed by the tissue ischemia and necrosis of the tissue. As peak plantar pressure is very high, lead to the anorexia or ischemia of the tissue. In non-diabetic patient, it recovers instant, but In diabetic patient, it delay recovery in the diabetes, which lead to the inflammation, warm, or edema, lead to the blister formation. This can be contaminated and lead to the ulcer formation. The sensory neuropathy damage lead to the loss of sensation, diabetic patient, inability to feel, increased pressure, loss of position sense. We change the walking pattern, hyperpronation in diabetic patient. Motor neuropathy lead to the muscle imbalance and weakness, deformity, change walking pattern, hyperpronation, and increase first metatarsal contact time. This is a small video how to do the podo scan. We have to ask the patient to stand static on the podo scan with arm open and see front. Just for 20 seconds, we can check about the static phase, whether pressure is falling, which area is more, peak pressure or maximum pressure, and which area. Now about the gait, we have to just ask the patient to stand, turn back, and follow the camera stand. We have to see the bipedal posture of his calcaneum posture. Then same, we have to ask the patient to squat and sit down. So any valgus or varus deformities there will come to know. Now stability test can be done. Any neuropathic abnormality is there. First we have to ask the patient to stand with eye open and do the test for 20 seconds. Same thing, we have to ask the patient to do the same test with the eyes closed. If any swinging due to neurological abnormality, we can make there is pressure increasing in the foot pressure, which lead to the ulcer formation or any callus or corn. Now dynamic assessment can be done. We have to ask patient just to walk through the podo scan. We have to ask the patient just to keep walking, and podo scan will analyze whether it's right foot or left foot. Because patient is initially nervous. When we ask the patient to walk just his normal cycle for a few minutes, so he follow the normal gait and footprint which is walking normally at home. What the plantar pressure assessment show to us? It provides the information about dynamic loading of the foot as well as information specific to each region in contact with the ground. Important of plantar pressure assessment indicate the foot and ankle function, weight bearing, weight shifting flexibility, balance assessment, and foot type, whether it's flat foot or high arch foot. This is a report we get at last after doing all this. We show us whether the pressure is more on the forefoot or rear foot. But is in bipedal we can see after squatting whether it's valgus deformity or varus deformity. Stability will know about the swinging test, whether there's more swing on the eye open, eye closed. A dynamic test about the gait analysis. This is three-dimensional rear view of the normal patient. We can see the straight line transverse tibia and calcaneum. If we draw a line from the calcaneum which follow to third metatarsal, that is normal. If any valgus deformity, it is moving inward and there's pressure on the first, second, and third metatarsal. If any varus deformity, there is the pressure on the third, fourth, and fifth, and first two. This is a small video. You can see the straight, this valgus deformity in the foot. What is biomechanism of injury in diabetic foot? Pressure, the force per square centimeter of area on the foot. What is normal? Perpendicular body surface, or what is shearing force? Tangentially to the body surface. What is mechanism of diabetic foot ulcer? Impulse loading is more relevant than only high pressure. Impulse loading is a product of pressure and ground contact time. Most of patient is non-neuropathic. They don't have any pain sensation. Repetitive mode of force Routine unprotected walking can damage the feet in the diabetic patient. Diabetic foot ulcer is a biomechanical problem, and no amount of antibiotic or dressing will heal the ulcer unless the pressure is reduced. Early detection and protection of high pressure area in the foot and correction footwear orthotics is only the strategy to prevent the loss of limb in diabetic patient. How we can offload? It can be surgical and non-surgical. According to alignment, different diabetic footwear available in market. Like this is the front waist sandal. If there is wound on the great toe, first metatarsal, we can give the front waist sandal. If there is wound on the calcaneum, we can ask the patient by offloading by the heel waist sandal. After stabilizing the charcot joint by conservative method, we have to ask prevent the shearing force. We can ask the patient to wear the diabetic sandal with footbed, which prevent the shearing force and stabilizes the joint. If the patient is non-diabetic but still he is having pain like plantar fasciitis, heel pain, metatarsal, we can do the foot scanning and customize the 3D insole for the patient, and we can insert in the patient footwear whether he wear and he will be comfortable. A recurrent of foot problem will disappear. When you should use the diabetic photo scan in diabetic patient? If the patient is obese, limited joint mobility, scar, neuropathic fracture, incorrect footwear, connective tissue changes, charcot foot, foot deformity like bunion, hammer toe, claw toe, recurrent corn and callus, flat or high arch foot, recurrent ankle sprain, forefoot pain, metatarsalgia, age-related issue, neurological condition, balance issue. In diabetic patient somatic neuropathy disorder, we can see the patient is frequently fall in the due to balance in neuropathy, peripheral vascular disease, foot pain, heel pain, and plantar fasciitis. At last, I like to just tell that listen to your feet; they are the foundation of your body. Thank you.
Thank you, Dr. Rajiv. It was excellent, elaborate discussion on photo scan. I think the treatment after this is to have a surgical or a mechanical offloading and to choose proper footwear. Before that, you do a photo scan.
Yes, sir. Yes, sir.
It's essential. I think there are no. We will take the question answers at the end of the session. We'll straight away go to the second session, that is from Dr. Tushar Rege. Dr. Tushar Rege is a diabetic foot surgeon to a governor of Maharashtra and consultant at Lilavati Hospital, Sushrusha Hospital, Raheja, Fortis Hospital, and Wockard Hospital. He will be enlightening us on newer local applications for diabetic wounds. Over to you, Dr. Tushar Rege, sir.
Yeah, good morning, everybody.
Good morning.
Am I audible well?
Yes, yes, yes.
Yeah. Dr. Niranjan Agarwal, Dr. Rajesh Yadav, chairpersons, then Dr. Manmohan Kamath, Dr. Milind Rukke. It's really nice to be here on the home ground. Before I begin my talk, I want to mention one thing. As Dr. Ashu Rastogi mentioned that he was the black sheep today because he was talking medicine in a group of surgeons. And unfortunately, I'm getting the same feeling because though I'm a surgeon and into diabetic foot surgeries, today my talk essentially will be on local applications. But then everything is so important when it comes to all these things because diabetic foot is a huge burden. It's a real huge burden. And to tackle diabetic foot, we should be aware of all the intricacies which come with the diabetic foot. Let me tell you, a foot surgeon or anyone treating diabetic foot will be encountered with two types of wounds. This is one type which is seen on the screen, so-called a dirty looking wound. It would be an exam question in the third MBBS surgery exams. And that question used to be, how will you differentiate between a healthy granulation tissue and an unhealthy granulation tissue? And the standard answers were that an unhealthy granulation tissue rises above the surface. There is coarse granulation tissue. It does not bleed easily on touch. And the fourth thing is there is going to be an infective type or a purulent or a foul smelling exudate. And this is exactly what you see in this type of a wound. The other type of the wound is diametrically opposite. And that is this healthy granulation tissue we can boast of is a very thin exudate without any offensive smell, lying flat on the surface of the wound and can bleed easily on touch. So these two are the essential things which we should be aware of when we talk of a wound or when we talk of local applications. And the first part of the talk is when I talk about these type of wounds. And whenever I look at this type of a wound, I have to go into something called the biofilm. This is something which is now it's coming as a short note in DNB exam, short note in third MBBS exams, because this is something which is now really started affecting the wound. And what is a biofilm? It is just a layer. It's a layer, a slimy layer containing glucose, proteins, fluid, all produced by the bacteria. And this biofilm covers the entire wound. Bacteria are all proliferating below, and they get protected by the antibiotics which are either being applied topically or by antibiotics which are given systemically. And why does this happen? Because they develop what is called cross resistance. That means if one bacteria is resistant to antibiotic A and the second bacteria is resistant to antibiotic B, ultimately both will become resistant to both antibiotics A and B. This is the main problem of a biofilm. And a majority of all these biofilms will have, majority of all these chronic wounds are likely to have a biofilm. And why are they difficult to manage? The most important thing is because many of us still do not have the concept of a biofilm, though of course it is now being propagated. We are all looking at a thing like biofilm, but without this concept and without effective management of biofilm, remember all ulcers are unlikely to heal, or a large number of ulcers would just become more and more chronic. Huge number of bacteria in this biofilm, they just rapidly keep multiplying. Again, more of a medical talk here, but on the left side, you see all the diverse gram-negative bacteria. There can be gram-positive bacteria like Staphylococcus, Streptococcus. That means for all practical purposes, every possible bacteria can be there in this biofilm, therefore rendering effective treatment highly ineffective. That brings us to the first local application, and that is cadexomer iodine. I'm not trying to volunteer or promote any product, but these things are extremely important in understanding how a particular thing acts. What is cadexomer iodine? It is just iodine. We've been talking of plain iodine. We know about povidone iodine. Cadexomer iodine is iodine in a starch globule. It is something like a laddu or a modak, where there is an outer layer of cadexomer, which is something like starch with iodine inside. And then what happens is when this cadexomer, which covers the wound, comes in contact with the exudate, it starts swelling up. It sort of absorbs the exudate and prevents biofilm formation. It dehydrates the biofilm. In effect, this cadexomer actually tries to destroy the biofilm, slowly liberates iodine. And now, again, this is important, slowly liberating iodine. And why is it important? Because all along we've been trying to say that iodine is cytotoxic. Iodine will not allow a good granulation tissue to form. It would be toxic to the tissues. So by this slow liberation of iodine, there is a definite antiseptic action. because this cadexomer or that starch-like envelope is slowly releasing iodine. As a result of which, this combination of cadexomer on top and iodine within does a lot of things, like it breaks the biofilm, reduces bioburden, that means kills the bacteria, destroys the bacteria. Because a lot of exudate is absorbed, it improves granulation tissue, and ultimately what we want is a wound closure which is taken care of by such formulation. This is just to tell you the difference between povidone and cadexomer iodine, but I think this is not relevant right now over here. There are a lot of studies, but the pointer or the thing which I would like to mention in this particular slide is that because the biofilm is taken care of, because the exudate is absorbed, and because of the slow release of iodine, such combinations of cadexomer along with iodine actually has a significant efficacy in ultimately epithelialization, which effectively means wound closure. And here I'm making a very controversial statement. In a surgeon's forum, I'm saying debridement alone is insufficient. I'm not saying debridement is not necessary. This slide should not be misquoted or misunderstood. But it is important to know that only debridement does not help. Now, what are we trying to say? In a diabetic, remember one thing, a diabetic wound is different from other wounds. A diabetic ulcer is different from other ulcers because a diabetic is an immunocompromised person. There are multiple things which are going on in the body of a diabetic which precludes wound healing. So I debride the tissue. I get an extremely good tissue, which I'm happy that it is a well debrided tissue. What happens next? If proper care of this tissue is not taken, it's a matter of 48 to 72 hours that a fresh biofilm forms, and the same problem could be repeated again. And therefore, in spite of debridement, what is extremely important is that you do not allow the biofilm to form in spite of your debridement. And that is a part of continuing diabetic care. We then talk of these type of ulcers or clean ulcers. And in these clean ulcers or healthy granulation tissues, there are a lot of local sprays which are now available. These are sprays which have silver. These can be nano silvers, micro silvers, colloidal silvers. Colloidal silver usually come with the gels. And what is the action of these silver sprays? The action of these silver sprays is that it is a strong bactericidal action at the local level. One more thing, which is a thing of caution, which I would like to say is, we always tend to wash these wounds with normal saline and then apply a silver solution or a silver based ointment or a gel. This is something which is not to be done, because the moment the silver comes in contact with saline, it forms a chloride which makes the whole silver ineffective against bacteria. So if a silver spray is being used, it is extremely important that the wound has to be dry, or you do not wash it with saline and then put a silver spray. There is hypochlorous acid, again, HOCl. We have been using usols in the past. But the thing over here which I would like to tell you is that hypochlorous acid is an important ingredient in killing or destroying bacteria, because hypochlorous is a medium which is required for the neutrophils to actually engulf and destroy a pathogen. Therefore, a simple spray of these non-irritant sprays which contain hypochlorous acid again goes a long way. See, these are simple things, but actually has a significant bearing on wound healing. So a simple spray by hypochlorous acid, and these bacteria are definitely much better inhibited than the regular dressings, and the same thing can be continued. At the same time, these sprays ultimately get converted to plain water, and therefore they have absolutely no irritation. They have absolutely no cytotoxicity as far as the wound is concerned. Talking about the local applications, I would now like to go to the growth factor concentrates. It is extremely important that there are many of these growth factors which are ultimately important. As we all know, how does the whole thing start? It starts with a wound or an ulcer. Whenever there is wound or an ulcer, there is going to be inflammation, as a result of which there is migration of all the blood components to the site of the wound. And the most important over there are the platelets. These platelets have a variety of healing factors which are liberated at the site of wound or at the site of inflammation. Once these platelets aggregate at this particular site and liberate their factors, then the various things of granulation tissue or epithelialization followed by remodeling occurs. It is very important to know that there is an inflammatory stage which is extremely important for all this raw material to come to the tissues. But then that inflammatory stage has to go to the proliferative stage. Now, this is something which you must understand, that if the wound does not proceed from the inflammatory stage to the proliferative stage, it remains in that state of chronic inflammation, and that is what we call a chronic wound or a wound which does not heal. And these are the wounds which are laden with this biofilm. So this small diagram is actually trying to show you that after inflammation, there is formation of granulation tissue, there is reepithelialization and extracellular matrix which is deposited, and ultimately the wound remodels to become a clean epithelial tissue. And there are a lot of growth factors which we really do not go into the details right now. But what is most important is that in each stage of wound healing, a different growth factor is to be used or is used. With this, we come to a special growth factor concentrate. Now, there are a lot of growth factors available in the market as gels, local application, there is platelet-rich plasma, some things which are very easily done, some things which are done complexly. I am telling you of one complex thing which is done, and that is blood is collected, almost about 16 to 20 cc's of blood. This blood is mixed with a certain solution which activates the platelets. Now that is important. Platelets are so-called stimulated or they are activated. And then when these platelets are stimulated, we get an upper layer of growth factor concentrate. This is not a platelet layer, but it is a growth factor concentrate. Now this growth factor concentrate is taken in syringes. It can be stored at room temperature for about, I think, 2 to 3 hours or so. And if it has to be stored for about a longer time, then it has to be stored in the refrigerator at about 4 degrees, 4 degrees Celsius. Now, the importance of these growth factors is that these are concentrated growth factors, and they have a far better bearing or far better healing than the local applications which also contain growth factors, because there is nothing else other than these concentrated growth factors. So this again probably would go a long way in healing wounds. And the last thing which I would like to touch is an acellular dermal matrix. Now, whenever there are large wounds, the important thing is wound closure. There are various types of grafts which are available. And as we all know, there are autografts, there are xenografts, then there are engineered tissues, and there are allografts. That means from one human to the other human. Now, what is done in this is that skin is harvested. The skin is completely, so to say, denuded. It does not have any protein material. There is only dermal matrix. It's something like putting a scaffold on which you expect the skin tissue or the routine tissue to grow. With that in view, you have this acellular dermal matrix, which is extremely good as a scaffold or as a cover on which normal skin would grow. Now, this is something which actually can be used almost as a replacement to skin grafting. In some cases, of course, after putting the dermal matrix, extra wound care needs to be taken for a complete closure. But all said and done, we are talking of the final slide, and that is the surgeon's knife remains the best tool to heal an ulcer, because even today as surgeons, we would find probably a skin graft as a relatively minor procedure to cover a wound. But there are times where, due to certain compulsions, due to patient inhibition, there are so many people, in spite of explaining to them that a skin grafting would not be a grossly major procedure, there are worries and there are apprehensions as to whether my donor site would heal, whether I am fit to undergo one more surgery. So all these things come in the way. And it is only then, though we are all as surgeons are fully conversant that it's the knife which is something which is actually going to help our treatment, there are certain indications where we cannot wield a knife. And that is the time when all these other methods of treatment are helpful, or at least they are something in our armamentarium. But remember, here when we have a huge diabetic foot load, a large number of them are not people who can afford treatment. All these engineered products or all these newer products are not very easily accessible to the society. In one of the conferences, Dr. Rajapal Sabapati had from Ganga Hospital had said, and these words are still ringing in my ears. Sir had mentioned that the only thing which is still not developed resistance in wound care is the surgeon's knife. And this is a very, very important statement, that all antibiotics, all methods of treatment would keep changing, but ultimately nothing beats a good debridement. This was just an overview. This is absolutely a non-surgical talk, but this was an overview to tell you that diabetic foot wounds or diabetic wounds are very difficult to heal. And if at all we have to heal the wounds or close the wounds, which is the ultimate goal, we have to resort to every possible thing. I'm not saying that surgery is not the thing. In fact, it is one of the most important things. But in addition to surgery, what is important is that there's so many other applications. What we said, newer local applications are available, and it is important to make a judicious use. I'll give you an example. I've seen in my practice so many times patients applying epidermal growth factors or PDGF, platelet-derived growth factors, on a highly infected wounds with slough, just because it's a costly ointment, and they thought that probably applying the costly ointment will heal the wound. So it is important that a judicious use of all these are necessary. The other thing which I would like to say is that in newer applications, there are so many things, so many more things. I've just selected a few which I thought are relevant, number one. And because our topic, there are other speakers who would be speaking on a lot of other things like vacuum dressings, or there are foam dressings, So I've deliberately not touched, though they are also a part of the newer applications. With that in mind, I think our final aim is that the wound closes, the wound heals, and whatever are there in our armamentarium are to be used judiciously. Thank you. Thank you so much.
Thank you, sir. There are 3-4 questions for you in a chat box. One is, how long do I apply the growth factors for? How much time?
Shall I answer now?
Yeah.
The growth factor concentrate will depend on the size of the wound, sir. What is done is that these growth factors are injected in the periphery of the wound, because the healing starts taking from the periphery. If it's a clean wound, by mean the slide which I had shown, well granulated, healthy granulating wound, then let us say a 3 by 3 centimeter wound would take about 3 weeks to heal. As I told you, if there is an opportunity for a skin graft, nothing beats a skin graft. But in regions where skin graft cannot be used, then these things can be used.
Any experience of use of honey?
Honey I have not used, sir. In fact, there is a proposal from the Ayurvedic college, which is in Mumbai, Poddar, where they want us to conduct
Previously, we were using potato slices, and we used to go to the gynec wards and taking out the placenta.
the lambriotic membrane.
Embryonic
Yes,
membrane. A lot of
absolutely.
things were tried to heal the wound. How to, sir, third question is how to clinically decide when to change the local application.
Sorry to interrupt. Can Dr. Regi answer them in the chat box directly? So
Yeah,
that
yeah, no
because we
problem.
have already quite delayed.
Okay.
We can move to the next talk. Apologies for doing this, but I need to maintain the time.
Yes, sir.
I'll type out, sir. Thank you. Thank you so much.
So the third talk is in continuity with the second talk, that is advanced wound care dressings. The speaker is Dr. Pawan Bellehelli. He is a MS from Ramaiah Medical College, Bangalore, and DNB Orthopedics from Cosmat, Bangalore. He is a MCH Orthopedics from Mumbai. He is working as an ankle and foot surgeon at Karnataka Institute of Endocrinology and Research, Bangalore, and presently heading the Department of Podiatry at KIER. Holding the post of Treasurer of Indian Podiatry Association, Karnataka chapter, member secretary for Independent Ethics Committee, KIER, past secretary, Research Society for the Study of Diabetics in India, Karnataka chapter. Over to you, Dr. Pawan.
Good morning, everyone. Thank you so much. First of all, it's a very difficult task for me now that Dr. Tushar sir has already spoken to meet his standards, but I'll try my level best. And before I start, I would like to thank the Mumbai Surgical Society for having me here. The topic that has been given to me are the advanced wound care dressings. I'll try to touch on most of these dressings which are commonly available and are being used. I'll start sharing my screen now.
We can't see, sir.
It's still processing, sir. Give me 2 minutes.
Okay.
Is it visible now?
Not yet. It will come. Yeah, now it's there.
It's visible, right?
Yeah. Look at the slides now.
Yeah, I have put it on slideshow. It's just processing, sir. Give me 2 minutes. There's some issues with the connectivity, I guess. Is it visible now, sir, in full screen?
Yeah, you can go ahead.
But it's not visible here. That's the problem. I'm sorry for this, but some issues. My share screen has gone blank. Is it visible now, sir?
Yeah, the first slide is visible.
It's in the slideshow.
Now it is there.
Right.
Yeah, you can start.
Thank you so much. I'm sorry for the technical problems. So starting, what are we looking at when we are talking of ideal diabetic foot wound dressing? So the things that we are looking at are It should be skin friendly. It should not cause maceration when we do the dressings. Should be able to absorb the exudates. Should be antimicrobial and prevent biofilm formation, as Dr. Tushar was saying. Should not damage the healthy granulation that has already developed. Should aid in epithelialization. Should decrease the pain during dressings, especially when removing. Can we think of smart dressings? Yes, these are the next level of dressings, which thankfully some of the research institutes, including ours, are looking at, wherein the dressings themselves would sense the wound type and act accordingly. And last but not the least, they should be easily available and cost effective. But now that we have spoken of the ideal diabetic foot wound dressing, should we as diabetic foot surgeons wait for this perfect dressings? I mean, as the slide says, it will be just waiting for that perfect person in your life, which we know is difficult nowadays. So coming to the most important question, the $1 million question, we have so many dressings with us. Which dressing should we use? I mean, we are flooded in the market with all type of dressings, including hydrocolloids, foam dressings. So which one should we use for a particular wound? So today when I talk about, I'll be just touching upon the different types of dressings and their properties. What are the dressings for debridements specifically? Wound specific dressings, what are we looking at? And some of these advanced wound care dressings, including showing you some of the cases. Now, yes, this was touched upon by one of my previous speakers. The time concept, which was given by Schulze in 2003 and later was modified by Falanga in 2004. This has been there for almost 15-16 years, and it has stood the time test of time. And we all know that TIME is very, very common. Everyone knows about tissue management, inflammation, infection control, moisture balance, and epithelial edge balance. But now the most important letter that has been added to it is the S, that denotes the surrounding skin and its importance in healing up of a diabetic, especially a chronic diabetic foot ulcer. Now, these are the current therapeutic approaches which we have for a diabetic foot wound. We have antibiotics. We had questions on honey. I'm sure many of my speakers will be more than happy to take it. We have polyhexanide, methyl biguanide. Now, this is the one that Dr. Tushar was talking about as anti-biofilm strategies. We have gallium, we have phage theory, lactoferrin, HBOT, biotherapy, which includes the maggot debridement. But yes, the one that is very, very important and we surgeons always believe in is the mechanical methods, as Dr. Tushar was again saying, that it's the surgeon's knife which plays a very important role, specifically for a diabetic foot wound which has come to you initially. I mean, after a debridement, probably you can go ahead and select the necessary dressing materials that you think are appropriate for that. So yes, these are one of the classifications of dressings wherein they can be divided into passive dressings and interactive dressings and occlusive dressings. Now, passive dressings are usually used for low exudating and epithelializing wounds. They provide protection by covering the wound and protect them against dehydration, like foams, films, and silicone layers. Now, interactive dressings are the ones which we are more concerned about, because although we have a lot of these interactive dressings in the market, the common physician or common practitioner who gets the diabetic foot wound initially, they still don't know as to which one goes where. So this is where I'll try to elaborate. Occlusive dressings are the hydrocolloids. Now, this was a very beautiful table that was given by Dr. David Armstrong et al. Right back in 2013. It was published in Best Practice Guidelines for Wound Management in Diabetic Foot Ulcers. Now, he has classified each one of them, giving the indications and the contraindications for each. So the first one being alginates or carboxymethyl cellulose. Now, these are very helpful in absorbing the fluids. They promote autolytic debridement. They help in moisture control and are conformable to the wound beds. Now, they are basically used in moderate to high exuding wounds, but we have to remember that we should use them we should not use them when it's a dry and necrotic wound, especially when we have very friable tissues, because these friable tissues can start bleeding when you start using alginates in them. Now, foams, yes, these are the next big thing, as many of the companies have been doing their everything to promote these foams. But we have to understand that, again, these foams cannot be used on dry necrotic wounds or wounds which have very minimal exudates, because the whole idea of using foams is to make sure that peri-wound maceration is prevented, or if the wound already has a peri-wound maceration, we use foams so that there is not horizontal spread of the exudate into the peri-wound area. Now, yes, we have had questions on honey. Now, one thing that I have to tell very, very honestly is, see, when you have things with you, you would rather use everything in your armamentarium which is best suited for your wound. Now, honey can definitely be used, but they have to be used in low economic settings. I mean, where you don't have anything available. So that is when you can try to use, but because honey has its own associated issues. For example, if you are using honey in people from villages, you never know, because these diabetic foot wounds are really neuropathic, and we have seen people who have started using honey coming back with ants in their dressings, coming back with rat bites in the other parts of the foot. So be very careful when you are using honey. Hydrocolloids, they absorb fluid and promote autolytic debridement. Hydrogels, they rehydrate wound bed, moisture control, they promote autolytic debridement. Iodine, yes, as Dr. Tushar was saying, but one of the major problems, not with Kedoxamur, with plain iodine is the systemic absorption. So you have to be very careful if you are using iodine, plain iodine for a long time, especially in diabetic foot wounds, which are very chronic, and you have been dressing them continuously with iodine. So you have to be careful with that. Low adherent wound contact silicone dressings. I will show you some of these dressings. These can be very easily used in geriatric patients who have very friable peri-wound skin, and you are afraid that any very aggressive dressings can give rise to other types of wounds or ulcers in the peri-wound skin. Now, PHMB is very well known. We have a lot of literature now for its antimicrobial action. And yes, if the patient is affordable and the patient has time, you have time, you can always soak the wound, especially a very odorous or a wound which has a lot of slough, in PHMB for 10 to 15 minutes, and then do the necessary dressings. You will get absolutely excellent results with this. Odor control, yes, these are again seen in patients who have been coming to you from faraway places. They usually come back to you on 4th day or 5th day, and usually the patient's attendants will tell you that, no, sir, we cannot stand the odor of the diabetic foot wound. So that is when you can think of using them. They usually have activated charcoal, but again, remember, you should not use these on dry wounds. Protease modulating dressings, yes, they help in clean wounds that are not progressing despite correction of underlying causes, exclusion of infection, and optimal wound care. Silver, yes, every other company comes to you with silver in alginate, silver in foam. It's we all know the antimicrobial action for silver, but yes, these are very well used in critically colonized wounds with clinical signs of infection, low to high exuding wounds. You can also mix these with other type of dressings, especially foam dressings. If you say that there is a lot of exudation, so the foam comes on top of it as a secondary dressing. So these can be used. Not to mention the polyurethane films. These are the moisture control, breathable bacterial barrier transparent, but the cost is a major factor when you start using a polyurethane films. Now, coming to the dressing for debridements, you see there can be a very non-selective dressing like a simple wet gauze to a very selective collagenases. I think some of them are giving us questions on debridase and things like that. Papain-based dressings, collagenases. You have to understand that these are used when you have a wound which is showing slough and you want to de-slough it. And whenever you try to do the mechanical debridement remains the best. But if you see that the mechanical debridement is causing them pain, or there are other contraindications, that is when we think of using these type of dressings. Coming to cases, this was a 67-year-old male with diabetic for more than 20 years with CKD and peripheral arterial disease. There was a simple chapped sole which got infected, and the infection extending proximally into the retrocalcaneal area. Obviously, the patient underwent PAD correction initially. We had to undergo debridement, and as you see, the tendoechlis was exposed. Now, this patient was elderly with CKD, so obviously doing plastic surgery in him had its own challenges. So that is when we thought of using Integra for these. Now, this acts as a good substitute when you want to prepare the wound bed. We wanted to see whether these things actually help when the tendoechlis is exposed like that. We tried to make sure that the patient was infection free. As you see, after the debridement, we started using Integra, and we had to use it with WAC. So, and that was after the first removal of WAC after 4 days. Integra still being taken up. And the problem in this patient was there was a lot of peri-wound maceration. And because of that, we were worried where the patient will develop any secondary infection. So that is when we started to use foam dressings in him. You see a biotin foam dressing along with a silver we started using. Now, the advantages in these type of dressings are it conforms to the wound bed. Upon contact with the exudate, the foam conforms to the wound bed and reduces pooling. There is vertical absorption that takes place. So ideally, the peri-wound maceration decreases. So after removal of WAC, you can still see some amount of tendon still not covered. There was good granulation that we had seen, but then we started dressings with foam, and you see almost the whole tendoechlis is being covered. And even though the skin grafting in this patient was also difficult because of the comorbidities, so we just started using regular recombinant gel factors, and that is how we start seeing the epithelialization. And sorry, I don't have the most recent images because of patient could not come to me because of the corona. I have asked him, but the wound has decreased in size, and this is how our software, the Woundwise, tells us that we are basically, the software looks at the high red. We would like the high red to be highest.
Dr. Pawan's signal is not appropriate. Dr. Pratap?
Yeah, I think he's lost signal. Owen, can you hear me? Yeah, we lost his signal.
Move to the next talk.
Shall I go?
Yeah.
So we will take the fourth topic of today's recent advances, that is vacuum assisted closure for diabetic wound to heal the diabetic wounds. So the speaker is Dr. Sanjay Vaidya, who is a practicing consultant diabetic foot surgeon attached to Raheja Hospital and PD Hinduja Hospital. Associate Professor for Fellowship in Diabetic Foot Surgery, MUHS, Nashik. Treasurer, Diabetic Foot Society of India. Was Project Manager for National Wound Care Project, an initiative of World Diabetic Foundation conducted by Diabetic Foot Society of India. He has undergone specialized training and acquired the postgraduate diploma in laser medicine and surgery from Russia. He is a member of the group to develop standard treatment guidelines for diabetic foot by the Ministry of Health, Government of India. And Fit First Clinic, Advanced Foot Care and Wound Management Center, he runs in Mumbai. So over to you, Dr. Sanjay Vaidya.
Good morning, everybody. Thank you for your kind introduction. And let me thank Dr. Agarwal, Dr. Rajesh and Milind for giving me this opportunity to talk on this topic, which is very commonly, of course, being used. This is a topical wound dressing, negative pressure wound therapy, or a WAC. Is my screen visible?
Yes, sir. You can go ahead.
Okay. Let me declare that I have no commercial interest in any of the company or the products which I am displaying. When as surgeons, we look at different options for wound closure, this reconstructive ladder is very helpful in deciding which modality to choose, starting from a very simple method of closure, going to complex reconstructions such as microvascular surgery. And as you can see now, negative pressure wound therapy has become an important step in this ladder in the last decade or so. What is negative wound pressure therapy? Of course, all of you know that it is a wound dressing system that intermittently or continuously applies subatmospheric pressure on the wound bed. And we can use it in many of the difficult to heal wounds, large wounds, in presence of compartment syndromes. And of course, when we talk of advantages, ultimately what we are looking at is for a better and faster healing. One must know what are the contraindications for NPWT. Remember, whenever there is a necrotic tissue with HR, if there are exposed blood vessels, if it is a wound with a malignancy and fistulas, these are definitely strict no when you are using a negative pressure wound therapy system. Looking at different types or variations in NPWT, there are topical dressings which give negative pressure on the wound bed surface. And then there are vacuum assisted closure systems, which can be a single use portable device, or it can be a conventional vacuum assisted closure systems, or VAC associated with a irrigation system. So looking at a couple of dressings which give us a negative pressure effect, Hydrofera Blue, which is available in India. It is basically a polyurethane foam which is combined with methylene blue and crystal violet. It basically creates a negative pressure on the wound bed by capillary flow action. But as you can see here, what is important in this, apart from exudate management, where you can use it in mild to moderate exudates, it is also helpful in removal of biofilm, where the pigment gets removed and the biofilm also is removed in the process. Vacutex is another wound dressing which has got a capillary action. This is not yet available in India. I have some limited experience of using it in few patients. It is basically a polyester with cotton filaments, which is a 3-layered dressing, which has got a capillary action, which is similar or autologous to NPWT. And this is one example, what I have shown here, a patient with a diabetic foot with a unhealthy wound on top with a biofilm. After using few serial dressings changes with Vacutex, a nicely clean granulating wound, which was subsequently skin grafted and has completely settled out. Coming to our vacuum assisted closure systems, again, I will first touch upon portable or single use devices which make use of battery powered small gadget size of a pager, which we used to use before the advent of mobile phones, which is attached to a dressing. The dressing typically would absorb about 300 cc's of exudate, and there, of course, the pressure is always applied continuously and there is no adjustment available in the pressure. It can be useful in certain locations. As you can see here, this was an elderly gentleman with a diabetic foot with osteomyelitis of the second MTP joint. He was very keen on toe preservation. As soon as you can see, I have done a thorough debridement. This is, of course, combination modality because you can see that I have put culture-specific antibiotic beads in the wound and applied a single-use NPWT and you can see a very well healed wound within 6 weeks. This NPWT single use can also be used in patients prophylactically, say in a CABG patient who is diabetic, to prevent any wound complications. As you can see here, primarily this single-use NPWT was put on the sternal suture line and it has nicely healed. But it can also be used secondarily in infected wound. As you can see here again, a post-CABG patient who had a dehiscence of the wound. Luckily, the sternum was not infected, a good debridement, closure, and single-use NPWT was applied for exudate management, and patient went on to heal. Talking about traditional VAC, all of you are aware, I need not talk about the system, the canister and the tubings, or the type of foam which has been used. But it's important to remember that we must cut the foam exactly to the size of the wound to fit the wound bed before we are fitting it. If the foam is coming outside the wound, that would lead to maceration of the peri-wound area, which is absolutely not desirable. With irrigation system, when we have NPWT, we can either use normal saline, Prontoson, or some such solution, which typically can be used. Say you can keep the settings so that we can irrigate and instill the solution in the wound every 3 hours or 4 hours. Normally, soakage time should be kept for about 10 minutes. And again, the NPWT system starts working. It's of course helpful in removal of debris, and we get a wound which gets ready for skin grafting much faster than conventional NPWT. Again, if you use too much of fluid, that can cause surround peri-wound maceration. So be careful when you are using instillation. Try to restrict to a quantity which is slightly suboptimal than what is shown on the machine. I'll just go to the practical aspects. I'll show you different kinds of case studies where I have used NPWT effectively, and also show you some combination modalities where NPWT helps us in a faster wound closure. This is one case where, as you can see, in a diabetic foot where I have done a fifth toe amputation, there's still some amount of slough sitting distally and proximally, unhealthy granulation tissue, exposed tendons, applied a conventional NPWT, nicely granulated wound, which are subsequently skin grafted, and a late picture showing a well-settled graft. Another example where a patient came with a bad sepsis, non-viable grade 2 and 5th toe, spreading infection on the plantar aspect, a forefoot amputation, and a thorough debridement was carried out. Still, a significant amount of slough is present. NPWT was applied, and within few sittings, as you can see, there was a nicely healthy granulation wound bed, which was subsequently skin grafted. And again, this is a late picture to show you that this is a well-settled skin graft with which patient was walking with, of course, the appropriate footwear. Showing different sides. Again, this is a lady who came a couple of months back to me from outside Mumbai, where she had met with a car accident where the orthopedic surgeon had put an external fixator, and she had a degloving where she lost the skin. That's when she came to me. As you can see, NPWT was applied. Now, this is where the skill of the operator who is putting the NPWT comes into place, especially where this kind of X-fix is put, because there can be chances of leakage if it is not applied properly. And you can see after VAC, a very nicely healthy granulated wound, which was subsequently skin grafted. Again, I always put VAC on top of a skin graft for one sitting for a better take of the graft. This is another lady who came with a known case of diabetes, hypertension. She was debrided twice outside, where you can see dorsal debridement, as well as there are some incisions taken on the lower leg, which were inadequate, I would say. So after she reached us, again, I have done a thorough debridement. NPWT was applied and nicely healthy wound bed was ready for skin grafting, which was subsequently skin grafted. Another example of a different site, as you can see, a patient with a pressure sore. She had a lot of comorbidities. The relatives were very reluctant to give consent for any kind of a reconstructive procedure. So I continued with negative pressure wound therapy dressings. And as you can see, a very nicely healed wound, complete closure achieved only with NPWT dressings. This is again another use of traditional NPWT. Again, a male patient referred with breathlessness, obviously because he was septicemia. Local GP were doing regular dressings. Again, thorough debridement, NPWT applied, serial dressings continued till a normal healthy wound bed was achieved, which was subsequently skin grafted and a well-settled skin graft. This is a couple of examples of NPWT with irrigation. As you can see, this diabetic lady had a hot water burns on the dorsum of the foot, which had debrided. Still, the granulation was unhealthy. That's when I have used a NPWT with a irrigation system, and within couple of WAC applications with irrigation, the wound was absolutely healthy red to undergo skin grafting, which was subsequently skin grafted, as you can see, and this is a late result showing a very well settled skin graft. Another example where a very badly infected diabetic foot, again a 4-foot amputation was carried out, and as you can see, the infection was extending much higher up to middle 1/3 of the leg. A thorough debridement was carried out, followed by NPWT with irrigation system, and then 4 serial applications, and the patient was ready for skin grafting, where as you can see, the wound has been grafted along with percutaneous endoachilles lengthening, which is very important to prevent recurrent 4-foot ulcers in patients who have undergone 4-foot amputation. This is something which we routinely do when we are doing skin grafting for 4-foot amputations. Talking of combination modalities, it is basically a multidisciplinary approach. If you want to achieve faster wound healing, we can have different combination modalities along with WAC. This is one case where, as you can see, I had done a good debridement where the flexor tendon was infected of the second toe, following which got a culture sensitivity done, which showed that it was sensitive only to colistin. Now, colistin being nephrotoxic, normally we don't like to give colistin intravenously. So these biocomposite colistin beads were prepared and packed in the wound. This wound was heavily exudating wound, so it was a little difficult to manage with the foam dressings or routine dressings. Therefore, a WAC was applied on top with suboptimal pressure. It is not something which you will keep 120 millimeter mercury negative pressure, what we normally keep. Keep a lower pressure just to suck out the exudate, at the same time not to disturb the beads. And you can see a very well healed wound after a few applications of NPWT over the beads. Another example of a post CABG patient again had little infection in the sternal wound, where after debridement, again culture specific meropenem beads were put, and on top of that WAC was applied, and you can see a nicely healed wound at the bottom. Talking of WAC with hyperbaric, again it gives us faster wound healing, better chances of wound healing. Especially we have been using it in necrotizing fasciitis, where we get extensive wounds. As you can see here, this gentleman who came with creatinine of 4.5, WBC 46,000, CRP 550, Procal was 5.5. So emergency debridement was carried out and WAC was applied. You can see within 15 days of application of NPWT with 14 sessions of HBOT, the wound was absolutely healthy, red, ready for skin grafting, which was skin grafted, and this is the result 5 weeks post skin grafting. And as you can see, when the patient had come to us with such a sepsis, within 8 weeks from the time he was operated, he was ready to be back on his feet. Another example of time. Okay. Again, another example of necrotizing fasciitis is thermal injury. Again, hyperbaric oxygen. You can see a well-settled skin graft after 1 year. This is again another example where patient had necrotizing fasciitis, blisters, had a PVD, where angioplasty was carried out, followed by thorough debridement, NPWT with hyperbaric and skin grafted. Again, a couple of more examples just to show quickly. NPWT with Integra dermal template. This patient was sent to me with a spreading gangrene, which following grade 2 amputation after peripheral angioplasty. And as you can see, angiography showed the restenosis. So plasty was done again. 4-foot amputation was carried out, and there was some exposed bone for which.
Dr. Vaidya, how many more slides do you have?
Just a couple of more cases. I can just
I
go
think
very
you
quickly.
need to hurry up because your time
I
is
will.
already up.
I will. And Integra was applied on top of the Integra. Again, NPWT was applied. Subsequently, once you got a good wound bed over Integra, skin graft was applied and a well-settled skin graft. This was again patient who had a FEMPOP bypass, following which multiple toe amputation was carried out and NPWT applied. Patient was not willing for skin grafting, hence a Raycosma RBM YAG laser was used along with NPWT as a combination modality, and you can see a very well healed wound within 4 sittings. And the last case is this 28-year-old female who came with a sudden onset of gangrene. This was in COVID times. Vascular surgeon did a FEMPOP bypass, but he said this is poor runoff, so go for BK amputation. I thought trying to give a trial with a limb salvage, did a 4-foot amputation, a good thorough debridement of the heel, and you can see along with VAC, again RBM YAG Raycosma laser was used, till wound was healthy granulated, put a Integra on top to get a good support for the heel, and subsequently it was skin grafted, and you can see a very well settled graft, and patient is standing back on the feet. Thank you very much. Thank you for your patient listening.
Thank you, sir. Excellent case, excellent cases and demonstration of various modalities, combining various modalities to heal the diabetic wound. And it is good to see that the bag does not only it is used for diabetic wounds, but all other post-operative wounds, traumatic wounds, and that is good for the delegates.
So you can take the question at the end of the session.
Yeah. Okay. Now we will go for the 5th talk of the today's recent advances session. That is of hyperbaric oxygen therapy from Dr. Manoj Gupta.
Dr. Varute, one more thing, if time permits, please allow Dr. Pawan to complete his presentation.
Yes.
Right.
Sorry, sir. I have just logged in through my mobile. I'm trying to restart my computer, so I don't know. If it restarts, I'll definitely finish it.
We'll take it at the end.
No, let Dr. Manoj Gupta finishes his first.
Yes,
and then
absolutely, sir. Absolutely. Thank you so much.
Yeah, Manoj. Hello. Dr. Manoj Gupta is a Prana Hyperbaric Oxygen Therapy Center. He runs, he's a director, Oxymaxis Hyperbaric Oxygen Therapy Center at Prabhadevi, Sai Lee Hospital and Diagnostic Center, Borivali, and the Hyperbaric Oxygen Therapy Academy. It is recognized by MUHS, Dr. Pawan Gupta. Manoj Gupta.
Let me share my slide. Can you see my slides?
Not yet. Yeah, now we can see.
Yeah. Can you see?
Yeah. Make it a slide slow, sir.
Yeah. Good morning to everyone. Special thanks to Mumbai Surgical Society and their president Niranjan Agarwal ji, who has invited me for this special session on Woundcon. I'll be speaking on hyperbaric oxygen therapy in diabetic foot. Last time I had spoken about this in Wokhad Hospital. I think I was given only 8 minutes last time by Dr. Niranjan, but this time he has given some more concession to me. So I'll be speaking a bit in detail today. So let me introduce what is hyperbaric oxygen therapy first. Can you see my slides properly?
Yes, sir.
Yeah. Actually,
you can convert to slideshow.
Yeah, that is what I'm searching.
Down.
The next one. After animation, the next one. This one.
Next one.
Move your cursors toward the right. Yeah.
So what does hyperbaric oxygen therapy means? Like what we do, we give 100% oxygen under a very high pressure. Normally what we see is we live in 1 atmospheric pressure. And when you go in the chamber, the pressure is doubled or it may be tripled depending on the condition for which the patient is being treated. So hyperbaric oxygen refers to intermittent treatment of entire body with 100% oxygen at a greater pressure than normal atmospheric pressure. Nowadays, many people, they ask me what indications. These are the approved indications worldwide and recognized by FDA USA. Generally, we follow FDA USA, but there are many protocols which are being followed by China and Japan and Russia, where more than 14 indications. There are some countries who are giving in 60 and 70 indications hyperbaric oxygen therapy. But most commonly seen indications we at our center or maybe worldwide are on the screen. The most commonly what we see, 40% of our cases are mainly arterial insufficiencies, which may be central retinal artery occlusion or diabetic foot wounds or any kind of selected problem wounds. We get cases of compromised grafts and flaps, crush injuries, decompression sickness, delayed radiation injuries. Nowadays, Tata hospitals are referring a lot of patients to me for radiation proctitis and cystitis. It has become one of the common indications of a radiation complication now. Idiopathic sudden sensory neural hearing loss. This is also a very common indication now. Dr. Hetal Marfatia from KM Hospital, she is heading the department of ENT. Recently, she spoke to me and said she will be sending a few students of ENT who will be doing research on idiopathic sudden sensory neural hearing loss. Then there are indications like intracranial abscess, necrotizing soft tissue infection, refractory osteomyelitis, severe anemia, and thermal burns. In this slide is head injury. This is a very common indication nowadays. JJ Hospital has a machine is in their neurosurgical department, and there are few machines being installed in army hospitals in the neurosurgery department. So stroke is another indication which is not included in this, but now with consensus, many indications are being added. How we deliver oxygen in the chamber? There are different types of chambers. We call it as a class A chamber, class B chamber, and class C chambers. Class A chambers include multiplex chamber in which more than 2 patients can be taken at a time in the chamber, and the entire chamber is pressurized with the air, and oxygen is delivered by putting mask on the face. If you see the mask on the face, you will be able to see how the oxygen is delivered in the mask. But the entire chamber is pressurized with the air. This is another chamber. This is a modular chamber which we have in Borivali, in which 2 patients we take in, and there is an assistant who accompanies the patient in the chamber. And such chambers can be used in the critical patients where you need an assistant of some paramedical person inside the chamber. This is a luxurious chamber which is there in many countries nowadays. In Qatar, there is going to be a World Cup soon, where many football players are being taken inside the chamber to increase their capacity or endurance while performing on the field. These chambers will be soon installed in India. At present, in India, we have only 80 chambers, unfortunately, but very soon we are going to have multiple chambers all over the India. Problem with such chambers are the cost factor. Such chambers are very high cost, so it becomes very difficult to get the return on investment. So many people avoid installing such chambers. This is a monoplex chamber. We call it as a class B chamber. This is also very commonly installed all over world nowadays, wherein one patient can be treated at one time. And in Mumbai, I think there are 7 or 8 chambers at present. of which 2 chambers are with me. And there are some corporate hospitals who have installed Raja Hospital as one chamber with them. I think Dr. Sanjay Vaidya was speaking about NPWT with hyperbaric. So he is regularly using hyperbaric for diabetic foot patients and many other indications. These are class C chambers or animal chambers. We are going to manufacture this animal chamber very soon. Some Gaushalas in India, they are going for this hyperbaric chambers for animals, which are regularly used for veterinary, like veterinaries. Now, what are the mechanism of actions of hyperbaric oxygen? These are the 5 common mechanisms by which hyperbaric oxygen works. For various indications, I've showed you 13 indications, 14 indications. This is how different indications and how the HBOT works on different indications. There is a direct pressure effect, which works in decompression sickness and cerebral gas embolism, neovascularization, which is seen in radiation, tissue injury or selected problem wounds. Today I will be speaking on this. Gas gangrene, necrotizing soft tissue injuries, refractory osteomyelitis, there is an antimicrobial effect. Vasoconstriction, we get a lot of patients of crush injuries and compromised skin grafts, in which this is very useful in reducing the edema and saving the grafts. Then there is hyperoxygenation in the chamber. This is very, very important thing, particularly in acute ischemia in diabetic foot. This is a very, very important aspects of mechanism of action. What is how is HBOT used in diabetic foot? Today, Dr. Abhay Darvi correctly spoke about the psychiatric aspects, which has to be considered for all the wound patients. Many patients, they are confused, they are lost, they are perplexed, they are unclear how to go about the treatment. So they keep searching for the doctors who can be the best for the treatment of diabetic foot or any kind of wounds they are suffering from. This is how we generally select the patient, assess the patient. We do a lot of investigation, finally select the dressing, and we select the different types of treatment or modality, whether surgical or medical line of treatment. Besides various common investigation, what we do, the most common investigation what we do is transcutaneous oximetry. Today, Dr. Milind Ruke spoke about TCPO2. This is a very, very common investigation which we do at our center, and it has to be done almost in 50% of patients for rejecting the patient rather than selecting the patient. We generally reject many patients for HBOT if there is no indication. This is how transcutaneous oximetry is carried out. We put probes on the wound, on the foot. There is a, if you see, there is a photo in which there is a middle toe which is showing gangrenous area. Accordingly, the number 2, the lead on the screen, if you see, it is showing a hypoxic region. So we detect whether the wound is hypoxic or ischemia. If the level of oxygen in this, if you see, this is how we do the algorithm. The right side of the screen, if you see, if it is more than 40 millimeters, the value on the screen, if you see here, if it is more than 40 millimeters of mercury, then generally the patients are not indicated for HBOT. But if it is below 40 millimeters of mercury, what we do is we give oxygen challenge test. We give 100% oxygen at 1 atmosphere in a normobaric pressure, and see whether the oxygen level on the screen is rising above 40. If it is rising up to 400 millimeters of mercury, then it is a good indication for hyperbaric oxygen therapy. But if it is going below the level of 30 or maybe below the level of 25, then we label it as critical ischemia, and such patients we generally don't take up for hyperbaric oxygen therapy, and we ask the patients to go for other modality of treatment. So transcutaneous oximetry, I feel, should be indicated in all those patients in which there is a borderline case and there is a feeling that patient may be helpful, may use this hyperbaric oxygen therapy or may not use that. Hello?
You can go ahead. Go ahead.
Yeah. So how does HBOT works in diabetic foot patients? The most common thing what it does is vasoconstriction. Many patients who are referred to me, they have a lot of edema on their feet. So when you give hyperbaric oxygen therapy, it reduces the edema and swelling within 3 to 4 days of starting the treatment. It works as an antibacterial. It is both bacteriostatic as well as bactericide. It helps in killing the bacteria. Most commonly, it helps in killing the anaerobic infection, bacteria when hyperbaric oxygen is started. It helps in enhancing some antibiotic actions. Most commonly, aminoglycosides and sulfonamides are given in the patient. If it is given together with hyperbaric oxygen therapy, it works very well or wonderfully well in controlling the infection. Recently, the mucormycosis infection, which is spreading, amphotericin B is known to be a synergistic drug with hyperbaric oxygen therapy. If it is given together, it helps in healing the wound of mucormycosis very fast. It helps in formation of granulation tissue, endothelial cell proliferation. It helps in new vessel formation or angiogenesis, and also in formation of epithelial cells and fibroblastic cells. And it improves the elasticity of the skin so that the skin edges come close to each other. It helps in improving the immune function, like it improves the function of leukocytes. It helps in improving the alkalinity of the area. Now, mucormycosis is a condition in which I'm stressing on mucormycosis because this is a condition in which hyperbaric should have been given, but it was not given recently. It makes the wound alkaline. So when if you see most of the wounds, they are acidic in nature. If you give hyperbaric, it makes that wound alkaline and helps in healing the wound faster. Also in diabetic neuropathy, if the patient is having a lot of pain in that region, this hyperbaric oxygen therapy helps in relieving the pain of the patients of diabetic foot. This is the same slide what I showed in the previous slide. These are some publications, some RCTs in which if you see the percentage in which hyperbaric oxygen therapy saved the amputation, like it prevented the amputation in percentage. If you see in the patients who were not given HBOT, there were higher numbers of amputation compared to those who were given HBOT. These are all RCTs which were done in past. There are very few papers Indian doctors have published. Soon we are going to publish some papers of our centers. This is another paper in which if you see the percentage of amputation which was reduced in patient given HBOT and who were not given HBOT. In 89 and 96%, the number of amputation which was saved. Then this is another study which was done in 95 and 2008 in which the limb was saved by giving hyperbaric oxygen therapy. These are my cases which we have done at our center. This was a patient who was referred with cellulitis and some gangrenous changes. He was given hyperbaric oxygen for 20 days. After debridement, we started the hyperbaric oxygen therapy. And if you see the granulation tissue formation followed by skin grafting, and patient is doing well even today. This is another patient referred to me. Patient came in this condition. He was debrided, hyperbaric oxygen was started, and only with hyperbaric oxygen therapy and good dressing, you can see the epithelialization of the wound, and the wound was closed in 30 days. Another patient, she was advised amputation of her above ankle. She was given NPWT along with hyperbaric oxygen therapy. She showed a good granulation tissue, and then we did skin grafting at our hospital, and she did very well after that, and amputation was avoided. Another patient with a lot of fluffs on the wound, we started hyperbaric oxygen therapy at this stage, and the granulation tissue, we prepared the wound bed, and then we went for skin grafting, and patient did well after that. These are the cases where we have failed, actually, what we can say. There are some conditions where patients, they come and they expect a lot by doing hyperbaric oxygen therapy. After reaching this point, we did this transcutaneous oximetry test, and we could avoid further sittings, and patient was asked to go for amputation after this. This is another patient referred by Dr. Bal from Raheja. The patient, after given 10 sessions of HBOT, it dried up completely and this limb was saved and no amputation was done further. Another patient with a very bad wound, and then we gave hyperbaric oxygen therapy for 10 days and patient did well after that. Another patient where there's a wound below the toe, and this patient was given hyperbaric oxygen for 15 days and there was granulation tissue seen, and patient did well after that. This is an amputation stump in which patient was not responding to the dressing. So we gave hyperbaric oxygen for 10 days. You can see a good granulation tissue which was prepared, and then later on the patient went for skin grafting. Now, what are the risks versus benefits? Many patients, they do come to our place and it is sent as a last option to my place. So what we generally speak to doctors, or whenever a patient is referred by a doctor, we generally suggest doctors should speak to the center why they are sending the patients for HBOT. Generally, patients, when they come to me, they are psychologically completely down, maybe financially they are down, and they ask us whether this hyperbaric oxygen therapy will be useful for the patient or not. So I would always suggest to all the doctors, never consider HBOT as a last option. If there is no unacceptable risk, then patient should be sent, and if there is an indication. And we generally, we have guts to say, patient, kindly do not go for HBOT, you better go for some vascular surgery or something, maybe amputation, if HBOT is not going to benefit the patient. Why is HBOT indicated? Generally, when doctors, they send patients to us, there is an indication, there is a presentation of the patient. Sometimes there is an indication, but presentation is not good. We have to explain in such conditions what will be the chance. There may be 50-50% chance of having a good result from hyperbaric oxygen therapy, or there may not be any result from hyperbaric. So we have to weigh whether the patient will have outcome after giving hyperbaric oxygen therapy. Sometimes the patient comes with no indication at all. There are so many patients who are being treated with no indication. So there are few centers in Mumbai, actually they are running a hyperbaric center with a bag. When we say hyperbaric oxygen therapy, it means the pressure should be more than 1.5 in the chamber. There are some doctors in the suburbs who have called me and said there are some centers who are running an air bag, which is not actually a hyperbaric chamber. It is a pressure of 1.3. And still they are being called as hyperbaric chamber. Those are not hyperbaric chambers, so don't get fooled by such people. And those are non-medicos who are running such centers, claiming it to be hyperbaric center. Knowledge and experience, what and how are you going to approach for the treatment? As I told you before, like we generally speak with the consultant the way we are going to approach the patient, whether we should for transcutaneous oximetry test or we should go directly for the hyperbaric treatment. Accordingly, we decide and tell the consultant. This is regarding diabetic foot I am speaking, but Tata consultants, Tata radiation department nowadays, they have given a protocol to meet me first before they start for hyperbaric oxygen therapy. Like such patients who are coming from Tata, they require longer treatment for cystitis and radiation proctitis. So it is always good to speak to the hyperbaric consultant to have a good approach and treat the patient in a proper way. Good results come from experience. Experience comes from bad results. It's a good saying. So generally we say you should always speak to an experienced person to get a wonderful result from it's a takeaway message, conclusion, HBO remains a safe and effective therapy in diabetic foot patients, provided you select a proper patient for giving hyperbaric oxygen therapy. A careful pre-assessment, generally we do pre-assessment of patients before going for hyperbaric oxygen therapy, routine investigation, along with some patients who are having kidney failure or maybe some cardiac failure, or the patient's ejection fraction of heart is low, then we generally take utmost care whether to put the patient in the chamber or not, because it may bring unnecessary risk to the patient than giving a good result. So careful pre-assessment is very, very important for treating the patients with hyperbaric oxygen therapy. Thank you very much.
Thank you, sir. We'll take the questions at the last of the session, end of the session. We'll go to the straight away. We will go to the last stop of the today's session. That is continuation of the podo scan, that is surgical offloading and footwear. So it will be delivered by Dr. Madhu Pereyaswamy. He's a consultant plastic wound reconstructive surgeon, Department of Plastic and Reconstructive Microsurgery, Ganga Medical Center and Hospital, Coimbatore, Tamil Nadu. He had won many awards and honors. He is a gold medal for paper presentation as DEFCON 2012, Hyderabad. He is a guest faculty at various conferences. MR Vaidya Best Paper Award at DEFCON 2017, Chennai, and guest faculty at GSP SA Con 2018 at Vadodara. Over to you, Dr. Madhu.
Thank you, sir. So, can I share my screen now?
Yeah.
So,
yeah, it is well.
Yeah. So, my topic today.
Audio is little less.
Just a minute, sir. Is it okay now, sir?
Little less.
Just a minute, sir.
So will it be possible to remove your headphones?
No, I'm not talking through the headphone. The mic is on the system mic. Just a minute. Setting controls. Audio setting.
So you can just unplug your headphones and try the laptop.
Is it?
Yeah, just unplug it from your laptop.
The screen was already shared. You can share it again.
So we are not able to hear you.
Can we finish the talk of Dr. Pawan in the meantime?
Just a minute. Yeah.
Yeah, now we can hear you.
Yeah, is my audio okay now?
Yeah. Now it's okay.
Yeah. So.
But the skin.
Yeah, I'm just sharing my screen now.
Yeah.
Yeah. Is it okay now?
Yes.
Yeah.
Now it is.
So, sorry for the initial glitches. So today's talk is going to be about offloading in the diabetic foot. So what exactly am I going to talk about? I'm just going to talk a little bit about what is offloading, what are the methods of offloading, mainly external and internal. And to settle a little bit of confusion, I'm also going to talk about a little bit about the natural history of a non-ischemic diabetic foot and how exactly a surgeon can make a difference by changing his protocol a little bit in treating these diabetic foot wounds. So a wound, as we all know, is defined as a disruption in the continuity of any epithelial lining, be it skin or mucosa. It is called acute when it heals with a scar in a predictable time frame, which is usually less than 4 weeks. And these wounds are called chronic wounds if they are not healed by greater than 4 weeks. And we usually think that chronic wounds need some help to help them to heal. So coming directly to the pathology of diabetic foot wounds, in our practice, the majority of wounds, about 85%, are pure neuropathic wounds. That is, we have palpable pedal pulses. There is at least one palpable pedal pulse, and the minority are because of dysvascularity, which in our practice we take as non-palpable pedal pulses. So today I'm not going to be talking about the ischemic foot or the dysvascular foot. So in a vascular foot, an ulcer forms when there is a combination of both a sensory loss together with deformity. So this deformity can cause changes in the shape of the foot or loss of the cushioning sole of the foot, which leads to high pressure areas, causing callus-like responses, which if left unattended, go on to become an ulcer. So this is usually the gamut of presentations, and as the previous speaker, Dr. Gupta, had spoken about, there is a lot of confusion about how exactly do we put in a protocol to treat the varying presentations of diabetic foot that we have. All we think about is this dressing, that dressing, surgery, debridement, grafting, reconstruction, healing the wound. But if you put all these into a proper perspective, rearrange the entire scenario, you will notice that there is a progression of the disease from the left end of the screen to the right end of the screen, where you see a very severe form of the disease. This just reflects the natural history of the diabetic foot, at least the vascular diabetic foot, where an abnormal pressure leads to a callus-like response, which further progresses to an ulcer, which gets infected at some point, becomes gangrenous, finally leading to a minor or major amputation. So currently, we surgeons mostly limit our practice to the right end of the spectrum, that is infection, gangrene, and amputation. What I am going to try today is to change the surgical perception of this disease so that we can actually start shifting our practice to the left end of the spectrum, which is the ideal area where we should be actually intervening so as to lead to maximal tissue preservation, which is the only thing that can cause a change in the outcome or long-term outcome of these patients. It's not only about healing the ulcer, it's also about preventing a recurrence. So as you see, what I'm going to demonstrate is the same great toe problem, which can present as stage 1, a foot at risk, where there are only calluses. Such patients also go to doctors. Many of these patients do attend medical practitioners. But unfortunately, sometimes it's the ignorance of the medical profession about how to treat this problem is what causes the problem. The patient may be put on various creams, various types of footwear, and some of them do progress to the next stage, which we call the ulcerated foot. There is an ulcer, there is colonization, but there is no invasive infection. And there is a good pulse, there is no Charcot, and there is no ischemia. We call this the ulcerated foot. If this is ignored, the same ulcer can develop an invasive infection which may or may not lead to soft tissue loss. This now starts increasing in complexity and requires multidisciplinary care. Under this heading, we also include patients who have early ischemia or early Charcot with good bone stock. And if even at this stage, you leave this patient unattended, they may progress to frank necrotizing infection, even which poses a threat to life. This is what we summarized in our staging, which we call the Ganga Hospital staging, which we divide into 4 simple classes, whether it's foot at risk, the ulcerated foot, the crippled foot, and the final stage, which we call the critical foot. So though today's topic to me concentrates particularly on the class 2 foot, I'm also going to very briefly show you how to approach the other 3 classes also. Of course, there are other staging systems which also reflect the natural history, like the Meggitt and Wagner, which was originally quoted for the dysvascular foot, and also the University of Texas staging, which gives us permutation combination of about 16 possible stages and is not very useful, or it is not practical to use it in a clinical setting. This is more suitable for study purposes. So class 1 foot, our choice is to use the conservative management, or what we call the external offloading. So what do we mean by offload? So offload doesn't mean taking away pressure. It means redistributing pressure. In fact, the definition on Google itself tells you to offload means to rid oneself of something by selling it or passing it on to somebody else. Here, oneself means the area of pressure, that is the ulcer, and somebody else means the rest of the residual weight-bearing contact surface of the foot. And by looking at the formula for pressure, which is the force per unit area, we also recognize that pressure is directly proportional to force, but in any patient always remains constant because of his body weight is constant, whereas it is inversely proportional to the weight-bearing contact surface area of the foot, which means that deformities and soft tissue loss will only lead to an increase in pressure, whatever method you use. And this will only lead to a recurrence of ulcers down the line. So hence, the best chance we have at preserving the foot and giving these patients a good residual quality of life is by preserving the maximal surface area of the foot. So what are the guidelines present, the latest guidelines on offloading foot ulcers in diabetic foot? What do they tell us? They tell us that for healing, please note the word for healing, not for preventing recurrences. A neuropathic plantar forefoot or midfoot ulcer in a patient with diabetes, the non-removable knee-high offloading device, that is what we call the total contact cast, is the first choice. The second choice is a non-removable or a removable cast walker. The third choice is a removable ankle high walker. But if all of these fail, the final option that you're left with is surgical offloading. So our model is to put surgical offloading first, where it not only reduces the pressure, but also reduces the incidence of recurrences so that the patient has fewer incidences of ulcers down the line and is able to preserve the maximal contact surface area of the foot. So in class 1 foot, the foot at risk, the idea would be to reduce debride the calluses, which by itself reduces the pressure by 30%, and then give him good footwear. To give him, what do we mean by good footwear? To understand a good footwear, we need to know the basic parts of any shoe. The basic parts of any shoe is the sole and the upper. The sole can be divided into a posterior heel and an anterior sole proper. The sole itself is made up of an outsole. There is a cushion in the middle which is called the welt, and there is an insole. The insole is the part of the sole, usually removable, which is in contact with the foot of the patient or any person for that matter. The upper can be divided. Just let me switch on my laser pointer. Yeah. So the upper can be divided into a quarter, a counter on the heel. These are lace-ups, and a forward shaft of the shoe, which can be reinforced by a toe box, an extra piece of leather, which is called the toe box, and an extension of the shaft, which we call the tongue. So the most important area in the footwear is the insole. This can be produced by making negative or positive casts of the foot, and also by digital scanning techniques such as the pedobarogram and the pedoscanning techniques. So this is what we call the insole. The upper in any shoe can be classified as a ball Oxford closure, where you have a separate tongue. Here you cannot stretch it out more than a particular point, or a Blucher closure, where the tongue is just an extension of the shaft. Here a slightly wider opening is possible, whereas in any frank diabetic foot, the preferred type of upper closure is a lace to toe, where a maximal opening of the upper can be done. So this can be either lace closures or it can also be Velcro closures. Where do we prefer Velcro closures? We prefer Velcro closures in patients who have a labile volume of the foot. For example, a cardiac patient, a patient with swelling, whose swelling is minimal in the morning, and as it goes to the evening, it becomes higher. So always prefer Velcro closures for such patients. So what are the common modifications that we offer to patients? Because my time is limited, I'm not going into very much detail in this. So the common sole modifications include metatarsal bars, which are useful in 4-foot metatarsal head ulcers because they correct the clawing of the foot, or a rocker bottom sole, which is B and C. The rigid rocker bottom sole or a creep rocker bottom sole, which is slightly softer. These rocker bottom soles help in mimicking the action of the metatarsophalangeal joint dorsiflexion in people with very stiff feet. The next type of modification is the heel wedge. This is particularly useful in patients with an equinus contraction. But if you note, you must always limit this angle to around 20 to 30 degrees. If you give too much of an angle, then the foot slips within the footwear and there is too much of loading, just like a high heel shoe of any woman. The other modifications, which are mainly useful in postural abnormalities of the calcaneum because of pronation or supination, include sole wedges and also Thomas heels, which are nothing but flat heels. So these increase the stability and also try to correct the postural abnormalities of the foot. These wedges can be either in the insole or on the outsole. So as I said, total contact casts and removable cast walkers with either closed heels, closed toes or open toes are the preferred non-surgical ways of offloading the diabetic foot. And as the latest guidelines say, footwear is not recommended for active ulcers. Active ulcers need knee-high offloading. Footwear is only recommended, be it therapeutic footwear or ready-made footwear, is only recommended when you have a healed foot in remission. So now we go to the next class, that is the class 2 ulcers. You have an ulcer, you do not have infection, that is invasive infection, you do not have ischemia, and you do not have Charcot. So these are the ideal patients for surgical management, early surgical management in the form of internal offloading. So for the purpose of this, we can divide the sole of the foot into 5 areas, and we have also included the dorsal ulcers. I'll tell you about it later. So for this purpose, you can divide the foot into toe ulcers, of which the most common is the great toe. In fact, great toe ulcers form around 30% of all diabetic foot ulcers. There are 2 types of diabetic great toe ulcers, I'm sorry. One is the IP joint ulcer, which occurs exactly at the IP joint of the great toe. Here I'm using my thumb just to show it as the great toe. Thumb, like the great toe, has only 2 phalanxes. All the other toes have 3 phalanxes. So the great toe has 2 phalanxes and only 1 IP joint. That is interphalangeal joint. The next joint is the metatarsophalangeal joint, which is underneath the ball of the great toe. So this is the proximal phalanx, this is the IP joint, and this is the distal phalanx. So if you have an ulcer under the IP joint, it is called a plantar hallux IP joint ulcer. If you have an ulcer beyond the IP joint, it is called a plantar hallux tip or subungual ulcer. This differentiation is very important because the pathomechanics of both these ulcers is very different. For paucity of time, I'm going to be very brief about the biomechanics. Please bear with me if you don't understand. I'll be happy to clarify at any later stage. So, for IP joint ulcers, the most important pathomechanic is the tightness of the metatarsophalangeal joint because of the windlass mechanism and multiple other factors. So what I want you to understand is tightness at the metatarsophalangeal joint causes an IP joint ulcer. It can be a hallux rigidus where there's absolutely no passive mobility, or there is passive mobility, but during weight bearing and gait, the mobility is reduced. So in such patients, early cases in the clinic, patient only wants a very small surgery, you can go ahead with a focused plantar fasciectomy under local anesthesia, suturing done, patient discharged the same day. The only problem is a high recurrence rate. These patients have to be followed up very closely because the success rate of this procedure, since it is very simple and addresses only the soft tissue component, is about only 60%. There is a 40% rate of recurrence. Hence, if the patient is not a good patient for good follow-up, please do not stop with this procedure alone. The gold standard for any IP joint ulcer is a Keller gap arthroplasty. It was a procedure that was originally defined for hallux valgus correction. It involves excision of the base of the proximal phalanx. That is, you excise the proximal third of the proximal phalanx, as I had shown in this picture. This is the bone to be excised. The objective of excising this bone is to take away the insertion of all intrinsics to the great toe. All of the intrinsics to the great toe insert into the proximal phalanx base. Hence, you excise the proximal phalanx base, the great toe now becomes essentially a floppy great toe. Sorry. And this increases the range of mobility of the great toe even during weight bearing. The tip ulcer is essentially because of a distorted clawed great toe, which instead of the pulp to floor contact, causes a tip to floor contact where there's very little cushioning because of the unbalanced pull of the flexor hallucis longus, where the balance is lost because of intrinsic atrophy. So here, the very simple procedure of just doing a flexor tenotomy, you can do it closed with a 16 or 18 gauge needle, keeping the ulcer under tension, or you can even do a open flexor FHL tenotomy under local anesthesia, helps heal the ulcer for good. Minor toes, again the same problem, intrinsic loss, clawing of the toes, either a mallet toe where the MTP joints are inline, or a clawed toe where there is hyperextension of the MTP joints. The procedure of choice is again an FDL tenotomy. You do an FDL tenotomy, the patient gets a very good healed wound. So this is a very simple procedure. If you fail to do this, this ulcer will go deep, touch the DPX, touch the FDL tendon which is inserted onto the DPX, and rapidly progress to a midfoot abscess, which then progress is up the tarsal tunnel into the leg and can even be the reason for a below knee amputation. So just awareness of such procedures among surgeons will actually help to save so many of these unnecessary amputations. So now coming to the next area, plantar forefoot ulcers, which are ulcers under the metatarsal heads. So these are mainly associated with an overactive Achilles tendon. So any Achilles tendon that is overactive will cause increase in the load of the forefoot. The job of the Achilles tendon is to load the forefoot. So if you lose the Achilles tendon, we will see what happens later in the talk. So here you have a tight Achilles tendon, you have an abnormal loading of the forefoot, you have metatarsal head ulcers. So the idea would be to do a release of the equinus. You can either do a gastrosoleus recession or you can do an Achilles tendon lengthening proper, and this helps reduce the pressure on the forefoot. This can also be combined with correction of any deformity or any abnormality of the bones of the forefoot. If there is a loss of the normal anatomy of the bones of the forefoot, we prefer to excise that particular involved bone under the ulcer through a dorsal approach. Or if the anatomy is normal, as you can see here, we will just do an oblique osteotomy of the distal part and allow the bone to collapse or shorten. For example, here you can see the length when compared to the third metatarsal and the first metatarsal. You can see that the second metatarsal is longer, whereas once we do the osteotomy, they all fall into line, thereby reducing the pressure, preserving the transverse arch, and also preserving the weight-bearing surface area of the foot. The first metatarsal head ulcer, it's a very important metatarsal head. We prefer not to excise it unless and until it is very badly deformed. So the procedure of choice here is a peroneus longus release combined with an EHL Jones Steno suspension, which is a procedure that is originally designed to correct the claw toe. So any claw toe, when there is a clawing, there is a proportionate flexion of the proximal metatarsal. So any collapse occurs in the Z form. So if there is a dorsiflexion of the proximal phalanx, the next obvious deformity in the proximal bone will be a flexion. If there is a plantar flexion of the distal bone, the deformity will be a dorsiflexion of the proximal bone. This is basic physics, and to correct that, we do a Jones Steno suspension where we take the EHL and reroute it into the metatarsal shaft.
Dr. Periaswamy, can you finish now?
Yeah, if I can just go in 2 minutes. How much time do I have?
You actually already finished your allotted time.
Yeah, I'll just take 1 minute. So midfoot ulcers, it is usually due to a Charcot midfoot break, can be taken and can be found by lateral x-rays. The treatment depends on the stage of the Charcot disease. And heel ulcers, it is mainly, as I said, due to underactivity of the Achilles tendon if you can see, if you put a patient with a heel ulcer on the pedobarogram, you'll notice that there is the entire load is on the heel. So overactivity of the Achilles tendon, it is on the forefoot, and loss of Achilles tendon, it is on the heel. So this is a sequential pedobarogram of a 13-year-old girl with an Achilles tendon injury which was repaired. You can see even in children, if they lose the Achilles tendon, they start to bear weight only on the heel. And this is the reason for a heel ulcer. And without correcting the Achilles tendon mechanism, whatever ointment, whatever flap, whatever shoe modification you give, unless it is a crow boot that prevents ankle movement, there is no chance you can heal the heel ulcer. So there are various procedures to reconstruct the Achilles tendon. You can put in grafts, you can put in tendon transfers, you can do flaps. Does it work? Yes, this is a patient 11 months after an FHL transfer. If this is not possible, the only option is to do a fusion of the ankle. So I'm not talking about reconstructive surgery, class 3. The idea is to debride, graft, flap, do whatever you can, heal the ulcer, but again, do a corrective surgery class 4 as in class 2 so that the ulcer does not require. So major amputation, when must you go in for a major amputation? Advanced Charcot's arthropathy with extensive bone loss, unstable patient with sepsis, extensive comorbid factors, or for example, there is extensive bone loss here, or very extensive infection and sepsis within the ankle joint, or major gangrene. Please don't wait. Take an early decision to amputate. Saves a lot of time for the money and for the medical system, and always finish it off with a very good process. Make sure that the patient is mobile. So approach, I'm summarizing the approach to a diabetic foot at risk, preventive podiatry, ulcerated foot, surgical offloading, crippled foot, debridement and reconstructive surgery followed by surgical offloading, critical foot, major amputation. I'm sorry for reaching my time. Thank you for allowing me to do so.
Thank you, Madhu.
Dr. Pratap, you can ask Dr. Pawan. He has got only 3-4 slides to show.
Pawan, are you there?
Yes, sir, I'm there.
You finish off within 2-3 minutes.
Cases.
Yeah.
I'm so sorry for the technical. Is this visible? Am I audible?
Not yet. You are audible, but yeah, now you are visible.
So these are the clinical cases that I wanted to show for some of the PHMB cases that we did. These cases have been shared to me by one of my colleagues, Dr. Sanjay Sharma. So as we see, this is one of the wounds where basically there is a lot of slough. It's an extensive wound surrounding the distal third of the leg. Tendons were visible. So what we did was we simply used a PHMB solution, soaked it with PHMB solution for 10 to 15 minutes before a debridement was done. And then we dressed the wound again with a PHMB gel. So you see the wounds have improved drastically. This is another case study of a hallux ulcer. Basically underwent amputation. Patient developed a non-healing wound. And here we used biotin silicone because of the age of the patient, the surrounding skin, which was fragile. And by simple third dressing of biotin silicone, we found out that wound was almost starting to heal and just required normal dressings to make sure that the wound healed because the wounds were in non-weight bearing areas. Now, this is the next one. Diperoxychloric acid is the new kid in town, as we can say. Now, this has really helped us in this COVID pandemic because we have been able to educate the patients, attenders, how to use diperoxychloric acid. This was one of the study which was done by Dr. Arun Bal sir, and actually has showed very good results when people can start taking care of their own diabetic foot dressings at home. There is a complete kit which is available. But the only problem is proper orientation and training of the patient's attenders to make sure that patients understand what is a sterile dressing, how to go about it, and how to do it. Now, this was the Woxil study, basically heel ulcer, which had given rise to an abscess. So we had to debride it and start using Woxil. Amazing results. Last but not the least, Whatever we spoke of all these time was probably dressings after debridements that we were using. Now this is a dressing, Amcoplast powder. This is basically human chorion and human chorion into powdered form, which can be used in clean wounds, which you have already debrided, and you are seeing that there is no progression for of these wounds. In such cases, we can probably think of using these granules to fill up tunnels, to fill up wounds which are deep enough, and we see excellent results again. So yes, selecting the appropriate wound dressing, how do we go about it? If there is an epithelial wound, we have to just think of promoting the healing. If it's a granulating wound again, we have to just think of promoting, but only if there is slough and other debris and necrotic tissue. That is when we have to think of the primary thing still involves a proper debridement, surgical debridement, following which, depending on how the wound status is, how deep the wound is, how bad the biofilm is, how bad the slough is, you can take care of so many things using all the things that you have in your armamentarium. Coming to the summary, dressing in diabetic foot will continue to evolve along with humanity, as we have been seeing over the last 20 years. The search for the perfect diabetic foot dressing will continue. And the surgeons of today should have the necessary knowledge about these advanced wound care dressing. Cost still remains a major hindering factor for availability of these dressings to the common man, but I'm sure the companies are doing their bit to make sure that these become easily available and less costly to the common man. And yes, combination of one or two or more of these advanced wound dressings, as I showed when I used a biotin foam with a Integra, can really show very good results. But however, we have to remember the combination should be very practical and evidence-based rather than trying to use all the special advanced dressings in one patient. Thank you.
Yes, sir. Pratap sir, you can wind it up.
Niranjan sir, we are already, I think, late by half an hour.
Please wind up. Please wind up.
So I declare that this session has ended, and
thank you, Doctor.
Already the next chairpersons are there in the room. So
thank you, Dr. Varute, for chairing
leave.
this session.
Yeah.
So you can request the delegates to type their question in the chat box, and the faculty who have presented may please see the chat box and answer them directly.
Yes, sir.
Yeah.
Thank you, speakers, and thank you, Chairperson, Dr. Varute, and Dr. Rajesh Singh, Dr. Tushar Rege, Dr. Pawan Beliali, Dr. Sanjay Vaidya, Dr. Manoj Gupta, and Dr. Madhu Pereswamy. Thank you so much. Now we'll go to the session 4, that is a symposium on the surgical issues in management of diabetic foot. To chair this session, may I invite Dr. Satish Dharap. Dr. Satish Dharap is HOD and professor and additional dean of academics in TN Medical College and BYL Nair Charitable Hospital, Mumbai. He has many achievements to his credentials. He's a past president of the Indian Association of Trauma and Critical Care. And then we have Dr. Pradeep Sharma, who's a consultant surgeon attached to Jahangir Hospital and Inamdar Multispeciality Hospital, Pune. He is a convener of FACRSC examination and Association of the Colorectal Surgeons of India, and also had been an ex-vice president and treasurer and academic convener of the same. So may I request our chairpersons to take over and start this session, as we are running behind time. I think we should start the session at the earliest. Thank you so much.
Thank you, Dr. Kamath. It's a great pleasure to be here. And as surgeon, most of us get patients quite late, and we are still at the stage where we need to debride. So I request my colleague, Dr. Pradeep Sharma, to take the proceeding and introduce Professor Ramakant.
Thank you, Satish, and thank you, the organizing committee of Woundcon. To introduce Professor Ramakant, he is known to almost all the surgeons in India because he has been the past president of Association of Surgeons of India in 2012. He is an ex-professor and head of Department of Surgery at the King George Medical University and the affiliated Gandhi Hospital in Lucknow. And he has also been the recipient of the WHO Director General Award in the year 2005. So with great pleasure, I hereby invite Dr. Ramakant to talk on what is the role of debridement in diabetic foot infection. Dr. Ramakant, please.
Hello, good afternoon. Am I audible?
Very much, sir.
Okay, thank you very much. So first of all, I'm really honored to have Dr. Niranjan, Dr. Pradeep Sharma, and Dr. Dharap, who are my chairpersons, and it's a pleasure to be with you. Dear friends, I am going to, should I share the screen now? Share the screen?
Yes, sir.
Okay. Share. It's okay?
Yes, sir. Please go to the slideshow.
All right. Friends, today I'm talking on the topic is extensive, or I'll say aggressive debridement in diabetic foot. We have been listening to debridement, and I know that is also very important, but I'll just show you a bit different opinion and experience. And what I want to say is the 19th century, the treatment was only amputation, and you can see this in what primitive way it was done. And 21st century, we have a lot of advancements. So people will talk about it, and we have been listening. Where external fixator, internally you can also change synthetic, bones are available. So many, and vascular surgery and grafts and all those things have flaps and those have come. But
sir,
what
you
is
can
important?
speak a bit loud, sir.
Okay.
Yeah.
Yes, I can do.
Or either increase the volume of your laptop, whatever is suitable.
Okay. Let me see. So I'll have to minimize possibleness.
नहीं तो आप जरा तेज बात कर लीजिए.
हाँ मैं कर रहा हूँ. चलिए.
हाँ, right.
Is it better now? No?
Yes, sir. Yes, sir.
Okay, if it's all right, so all right. So now I'm saying that if they are treated with chicken-hearted debridement, I'm not saying debridement plain, but if you're chicken-hearted, you are scared and not doing the proper job, then it can be never better. You see, these patients which I've shown, there are a lot of patients with me who have lost their limbs. This is just a cartoon, person who was selling fruits. You can see another gentleman where staged amputation was done. They kept on doing debridement, and took months and months, and they lost both the limbs. You can see this here also. One limb lost, and second, sorry, there, and this is also debrided, and it is not properly treated. I will not say the debridement is wrong. The point is that technique is wrong. Similarly, the poor patient is a rare thing, but she was also diabetic and insulin-dependent diabetic, and she had all these problems and was treated like that. Friends, so therefore, what is simple that the treatment has to be absolutely scientific and it has to be with the updated methods. Now, I'm sure that you all know me, my love. Greetings from Lucknow. I'm Dr. Ramakant. Now see, I'm again showing, and don't be frustrated, I'm just showing there are people who have done, this is called debridement, and the patients have been running for months together. You can imagine the disease has already gone up. It will require an aggressive debridement, honestly. See this is also called a patient sent to the institution with debridement. I don't accept all these things. There is slight redness, which had got no meaning. Here, it is slightly better. Then coming to this, that we have to, I'm sure I'm not going to speak on this, but what is important that these factors have to be seen. If you find any one of these things are there, especially ischemia, neuropathy and all that, and then pressure point phenomena, we are all learning about it in microscope. It's important. If you operate any patient do aggressive debridement or debridement even in a poor vascularity, be sure it won't heal. So we have to go for that. So tissue hypoperfusion, ischemia and infection, they're very important. And friends, defective cellular immunity is associated, defective humoral immunity is associated, synergistic effect of ischemia and impaired immune response, atherosclerosis, all of these factors, they lead to ischemia. And therefore, the diabetic foot, I will say in very simple language, it is the tip of the iceberg which we are seeing commonly. And I'll show you how. Now, you should evaluate for these things. This is simple and we all know it, but I'm just trying to emphasize. Now, I'll show by cases. That will be better for you. So I'll just show. Here is a case. 73 years old lady. She was mother of a medico. Diabetic, 30 years, hypertensive, cardiac problem with CHF. Renal parenchymal disease, minor injury 2 weeks back. Infected and necrotizing fasciitis was there. Operated twice. Debridement was done at some other place. And naturally, some surgeons had done it. And presented to me with fever, rigors, pus discharge, edema, and she was also incoherent. So see, this is after 2 surgery when she presented to me. It looks very innocent. It is not. And you can see this was not healing because they kept on cutting very smaller tissues. And you can see the infected, unhealthy granulation tissue, and the disease already almost reaching to this point, and the toes are all edematous. You can see still closer view. Now I'm showing the other limb also shows the foot that there is a bruise in the, after some injury, and naturally vascular, you can see coronary venous insufficiency, and all those things are visible. Now, friends, she was incoherent. You can see this blood urea level was also high, so she had KW, which was proved later. Now this was done. Exactly at that time, we don't have any video, but I operated, and this is the extent, and my concept was, because the vascularity was good, and the pulses were palpable. So I will excise the tissue to the level when I find the bleeding is profuse and good. That means I am happy. Vascularity was also good in her. This lady, she did not have the ischemia of the limb, and therefore we did it. Now, what is different here? See, we do this most of the time in local anesthesia. So therefore, no spinal, no general, nothing like that. And you must be doing the same. Now, after doing this, we will dress in different way. I'm not going for a very high-fi, those, dressing materials and those things. It is difficult and cost-effective problem. But anyway, they're good. But on the same time, we have some different understanding. Unless needed, I don't do that. Now, what is important, I put feeding tubes there. Now, because I have excised every dead tissue, there's only healthy tissue, daily dressing will not be required. And you can see, I am also giving local antibiotic in here, gentamicin or anything, enzamycin, whatever you want. This is off-label use, which is not described. And I remember Armstrong, the famous person in diabetic field, he also accepted when I was presenting some time back that he also said that I also use it, but I call it off-label use. That is what I am also calling. Now, you see, after that, I don't require anything else except the Sofratule or Tule grass dressing. And then these tubes are put according to the size of the wound. And through this, you will be out of the dressing, and we can keep on pushing every 4 or 5 hours a small amount of 2 or 3 ml of saline with some antibiotic or even plain saline, so that it remains moist. It does not become dry. The amount excised was, you can see it here. Then you can see the idea was that if there is an ooze here, that means this shows compression dressing is required, elastocrate was applied, and that is a satisfactory point, and it's not going to bleed much more. Now see, the first dressing removed after 48 hours, and you can see that gauze is there, there's some blood stains, and you can see the tubes are here which were used. This is the next picture of that, and you can see the Sofratule. Then you see the bare picture on the first dressing after removal of all these things, and you can see it's all red. There's nothing like a dead tissue. There's no other problem here. 7th post-operative day, then the 17th post-operative day, going on well, and advised split skin graft at this stage because granulation tissue is very healthy, but she refused and did not, accept it. And because her daughter's marriage was there. That's what she said. Anyway, we've informed them that contracture will be there, but she did not. So we kept on seeing the natural what is happening. 28th postoperative day became smaller. Then on 32nd postoperative day, still smaller. And you must be seeing the toes are being pulled. It's quite possible. And then 39th day, healing was complete. And you can see the scar is there. But I know this can definitely cause a tear. It can cause problems. But she did not accept it. The point is, within 39 days, the wound had healed. And those debridement, which are chicken-hearted, you will find the months, and I'll show the patients too. Now then, 76 years old man, diabetic, 27 years uncontrolled, hypertensive, blood pressure controlled, had accidental injury, laceration in the foot and leg, treated by several therapies, and finally debridement when even lower thigh got involved. Duration 33 days already. Necrotizing fasciitis with gangrene and multiple pockets of pus and intramuscular plain, referred for amputation, vascularity satisfactory, and no neuropathy. Now, this was a gentleman, and you can see this, we operated, and all that was excised, and it is a very extensive excision, and we had to do under local anesthesia, and we required 2-3 times to be given, because it took a lot of time. Then you can see again, same thing, feeding tube for moisturizing and antibiotics in this gentleman. And then you can see when we're opening the dressing, and you can see after, around 3 weeks' time, the granulation tissue came nicely. So we kept on, doing the mesh grafting, or skin grafting was done. And you can see back also had the same thing. The grafting was done here also. And then you can see that here, this point appeared because a split skin graft I was telling him, and that he did refuse because he already gone so many surgeries. So that shows some contracture. But what is happy and satisfying to me where I'm talking today is that he had a neuropathic ulcer also, which looked to be there. So we just kept on dressing it and he's a poor person, so walking aid of this type. And will you believe, after nearly 4 months of the proper treatment, this person, gentleman, could reach to Hajj and brought back the Abe Jam. And I'm so happy to remember it. Third case, another lady, same problems, injury, badly treated, and looks like as it is healed, but all it was steaming with a pus inside. You can see some amount coming here, and you see it's quite an extensive problem. And then we had to do aggressive debridement. It is in the process; it's not complete now. And you can see this; it has gone through the tendons higher up. It always happens. In the foot also, you'll see the same thing. Some slides come. And this is how we kept on cutting and removing. All this tissue, which was whitish, was excised. Nothing dead was left. And later on, it was a patient who after 4 or 5 weeks, I don't remember exactly, so I've not written, that this wound became like this. So naturally, mesh grafting was done. It was a big, huge area. So this was nothing short of mesh grafting, and ultimately it all healed. That was also a successful story. Classical example of tip of iceberg, central plantar abscess, necrotizing fasciitis. I'm sure all of you are aware, and this is a tip of the iceberg. People will talk about this is small ulcer, and you remember that things are here also. This is also, infected. It is all diseased, and when you see in details, and you can see there's so much of, and erythema is here, and ultimately what extensive surgery should be done is something like this. I'm confident about that. This is the total treatment, proper treatment which should be done. And this is the way we have to open the plantar space, total deroofing of the iceberg phenomenon. Friends, another patient similar, you can see, came with a small abscess, claiming that it is a very small thing. Similarly, you can see when you examine, you are finding it has gone here, it is shining here, and it was very fluctuant. And here also, you can see the blackness was coming. Now, what happened? We just put a sinus forceps here. It was so much of pus coming out. You can see this, and here also the gangrene was there. And see this, the extension through the posterior tibialis tendon has gone up. So we have to excise all that area to that level. Now, see, this is a very small video of the same thing, very small, but I'm sure it gives an idea what has to be done. If you do anything short of it, be sure about it will just waste time, and maybe that you are going for a staged amputation. So therefore, you will have to be very clear. You can't leave all these things. And this is not in the foot only, it has gone much higher. And this is common. It is not uncommon. Now, you see, after everything has been done, then you can see this again, the feeding tubes. And then you see the upper part, the dorsum also had some problem. So we excised that part also. And then they all healed in time. Fifth case is another tip of the iceberg phenomena. Here also you can see similar plantar space infection. And then we had to operate like this. It's a very dirty slide, but at the time when we were operating, we had not very good facility of recording. So anyway, a photograph is there for mobile. And then this is another case. At first look, someone advised major amputation. He sent for it. But detailed examination and tests indicated a chance to be taken, and it next explained well about probabilities, because it looks like if gangrene and amputation was advised by his surgeons, but there was surprise coming up because vascularity was whatever I could feel, and then handheld Doppler, with color Doppler he could not afford and there was no time. So therefore, we had used handheld Doppler always, and therefore we found the vascularity is not bad. So I took a chance, and this was the picture, very frustrating. I told you again, this is also a mobile photograph, and you can see that it was, people thought it has to be cut. I'll just show you, you can see everything like this. And see, when we started cutting, it was very superficial. It was not deep. And therefore, once we excise the skin subcutaneous tissue and the tissue around, you'll find it became like this. And the vascularity was not bad. And therefore, this patient could be managed by this. And here, another case, same thing. I still say with full emphasis that this was nothing short of what we have done, because here my objective was, let the patient somehow the other, this one, should be able to walk on his heel. Heel was good. So therefore, I did not take a chance. A very poor person, finally he could walk on his heel. And this I'm showing, this is a slide borrowed from Dr. Bal long time back. The important, and what I'm showing, deformed foot, whatever, is much better than a prosthesis. And therefore, for a poor person, walking on heel is much better than trying for anything else and looking for a prosthesis. It's not possible. Here I'm talking, the last is a very unfortunate story of a medico who's my class fellow also. He's Dr. R.D. Sharma, 75 years old medico who had a very poorly controlled diabetes for 26 years, hypertension, KW syndrome, operated case of 3-vessel angioplasty following minor injury in Australia when he had gone there. Second toe, it got infected and it started producing to gangrene. He came back to India and Bareilly debridement was done by some surgeon. And naturally, that was again the same thing, because he was a doctor known very well to people, and therefore they did not do what honestly I feel today that it should have been done. 2 months later, he presented to me after several debridement, I should say. Gross ischemia, no vessel palpable from femur onward, confirmed by color Doppler study. I again, friends, will tell you that you should have a hand Doppler also. And this is another example where color Doppler shows the same thing, but we put the handheld Doppler, we found there's a good flow. So therefore, I took a chance. And I told him that we will do aggressive debridement, but he did not agree. He refused it. Dear, you do only debridement at size this toe, and a plastic surgeon joined. Also, we got a consent signed by him. And then ultimately we did really without satisfaction. And 1.5 months he kept on. Then he was advised HBO. And Lucknow, this is available. So we did hyperbaric oxygen. So it took 1.5 months to give him for that. And it was, there's a minor improvement observed. And then we found that he kept on dressing and he did not agree for any opinion. And therefore, third toe also started getting disease. CT angiography, endoscopic atherectomy at SGPGI referred, and I got it done. And minor improvement, and because of corona epidemic, he again waited for 2 months that I'm not going to the hospital for any surgery, and now disease has spread. I'll just show you photographs. This is a, I will say, unfortunate story. You see, he came this to me like this, and this was the tissue, and this was a enlarged view of that. Then this you can see here, it was some sized, and then we at this stage we advised that hyperbaric oxygen. This became all red. There was some ray of hope, and we all felt that possibly things may settle down, but it did not, and this worsened again. And after the 2 months of that corona period, now he came and sent me photograph. Pus is oozing. The third toe also is involved, and you can see this. The disease has spread quite a lot. It has gone up to this, and I'm confident it has gone above the this ankle. And here also you can see it. This is all frank gangrenous, and this is all blown up, bloated up. And from here you can see the blackening has come, and from this side with posterior tibial test and this gone up. Now see, this is the last picture. Now he's admitted in PGI, and I requested my friends to manage him and see this. What is happening is that skip areas have come up ischemia. This is all edematous, pitting edema is there. This is all tender. He is in high pyrexia, and this is the picture. So friends, what I want to say that in this patient, I went for cost containment and calculated everything. To some extent, it came down. Expenditure by now is 5.3 lakhs, and he has still to go far and far. Imagine this dressing, then the HBO, and then other things, debridements, and all those things. Therefore, I always opt, if possible, and things allow, you never do a plain debridement where you're finding that things are not going to settle down. Friends, this is what my message is. And by the time I have operated in last 22 years, more than exactly 1,969 cases by this method. I got myriad of photographs, and luckily I'm happy that God blessed me, and most of the time successful, but sometimes some problems do come, and for that we have to definitely take help. Thank you very much for listening carefully. Thank you.
Thank you, sir, for a very excellent talk. And there is one question in the chat box. what antibiotic would you instill inside the tubing place for the debrided wound? What quantity would you use, and wouldn't it lead to maceration in that case?
Yes, I'll tell you. The antibiotics chosen well at that time, majority it was gentamicin, because sometimes we were using gentamicin beads also. So I kept on just only 1 ml of gentamicin that was taken, and this was dissolved with 3 to the total volume should not be more than 4 ml, and that is 4 hourly or 6 hourly we give, so that it does not become sodden. It just remains moist, because we have excised everything, because there is moisture already there. But many times we saw it become dry. So therefore, the antibiotic at that time was either gentamicin or enzamycin if the kidney problem is not there. And this is the off-label use. I told you, Armstrong, famous person, all of you know him, and he also accepted he does it. But then again, it is an off-label use. It's not prescribed. But benefit is there. You can try that part. That's what I can say. No other antibiotic.
Right. Thank you, sir, for an excellent talk. And that was really a very, very vast experience. And you shared your experience with us. Thank you very much.
Thank you very much, Dr. Pradeep and Dr. Saram.
Thank you, sir.
Thank you, sir. Thank you very much.
Yeah.
Should I?
Satish, can you introduce Dr. Amrish?
Yeah, it's my pleasure to introduce Dr. Amrish Palyar Singh. He is former head of the Department of Surgery at BYL Nair Charitable Hospital and Topiwala National Medical College. He is consultant plastic surgeon practicing at Bombay Hospital and Breach Candy Hospital and Hinduja Hospital. He will be speaking on reconstruction in diabetic foot. Over to you, Amrish. You are muted. Please unmute yourself.
Thank you very much, sir. Am I audible?
Yes, yes, yes.
I'll start.
Amrish, any issue? You, you need some help?
Yeah, because I can't see my file here.
Can we take the next talk in that?
Fine.
Huh?
Yeah, 1 second.
You can sort it out. We'll finish the next one before you.
Yes, you can. No problem.
Dr. Dharap, call the next speaker.
Yeah. Dr. Bal is there? Bal, sir?
Swapnil, is Dr. Bal logged in? Vama, is Dr. Bal logged in here?
Yes, sir. Yes, sir. Yes, doctor.
Swapnil?
Yeah, he is.
Yeah, he is here. Sir, are you ready with your talk? Can we start with your talk, sir? Dr. Bal?
Yeah.
He's still muted. He's muted.
Yeah.
I'm sharing my slide. Just hold on.
Right.
Chairperson can introduce him, though he doesn't require one.
Yes.
So I have great pleasure in introducing Dr. Bal. I think everybody in India knows him. He was the one of the pioneer in foot surgeries and starting this fellowship program for diabetic foot infection. Another interesting thing is that he's also a PhD in political science from the University of Mumbai. He's a consultant diabetic foot surgeon at Fortis and Hinduja Hospital, Mumbai. He's a visiting professor at Amrita University in Cochin. He's presently the president of Diabetic Foot Society of India and secretary of Association of Diabetic Foot Surgeons of Denmark and vice president of International Surgical Society for limb salvage. He is also the course director for fellowships in diabetic foot surgery under the MUHS. So with this introduction, I have great pleasure in presenting Dr. Bal. Dr. Bal, please.
Yeah, okay, let me share my screen.
Yes, we can see it. You can just go to the slideshow.
Okay, I'm just going to shut off my video because I have some
net problem.
Net problem, but I can't see the video icon.
Okay, sir.
Can you just shut off from their end, because otherwise my slides will not run.
So you just go to the slideshow next to animation. In the menu up.
So we have stopped your video. You can.
Yeah.
Yeah. Okay. Then I will go make a slideshow. That's not a problem.
Yeah.
Okay. Okay. Right. So.
So your face is not seen. You can change the angle of your
no.
webcam.
No, I have purposely switched off the video because I have an internet problem. Both won't run. So my topic is common amputation in diabetic foot management. I have made it simple. So this is a disclosure. One of my colleague has contributed some data to this presentation. This is used to be, as Dr. Ramakant had said, the earliest 19th century situation where mortality was very high and was done without much of anesthesia. So the seconds count. We must remember that every second somebody dies from diabetes. Every 20 seconds somebody is amputated. More than half of all foot ulcers become infected and requiring hospitalization, and 20% of infected ulcers undergo amputation. So following the first lower limb extremity amputation, contralateral amputation in 68%, mortality rate at 50% within 3 years, and institution or invalidness in 25% of remaining permanently. Not in India, we don't keep them in institution, but they remain at home. So this is a very famous Eurodial study which was done in 14 European hospitals in 10 countries to find out what are the independent risk factors for lower extremity amputation. So they were deep ulcer, peri-wound edema, foul smell, probe to bone positive test, fever, but the most important is a elevated CRP, which is one of the risk factors for a higher level amputation. Similarly, this was a 11-year prospective study of hospital admissions in Ipswich Center in UK, and they found that a team approach reduces the major amputation by 62%, total amputations reduced by 70%. So there is an improvement followed by a team approach. So close coordination between the team members helps to reduce the major amputations. So the decision which one has to make is to amputate for saving life, or there should be limb salvage. This is a very major decision. I think whatever we know, all of us, and whatever some pictures which Dr. Ramakant has shown, shows that people keep on debriding without realizing what they are doing. So this is a main decision every diabetic foot surgeon has to decide and take a call. Limb salvage and not life salvage, not a limb salvage is the goal. And the question we need to ask us is that will this patient be more functional with a salvage lower extremity or with a below knee or above knee amputation? So both start with the same approach. You have to ensure good blood flow, control infection, stable soft tissue envelope, and good biomechanical concepts. Non-invasive vascular evaluation, all of us know ankle pressure has to be above 50, ankle brachial index has to be optimum, skin perfusion pressure has to be optimum, TCPO2 minimum above 30. But most important, clinical judgment is more crucial than all this. If your clinical judgment is correct, many of the time, as Dr. Ramakant has also shown, that it works well if your clinical judgment is correct. So the threshold predictors for wound healing in lower extremity are these. As I have explained, this is a Doppler which is above 0.5, TCPO2 above 30, serum albumin. If the serum albumin is below 2.5, even the higher level amputations or any wound will not heal, and absolute lymphocyte count above 1500. Now, this is something new which I just wanted to share with you. This is a study which has been published in European Journal of Endovascular Management, and it has brought out the thing that it's a novel scoring system which has produced two indexes as called as a small artery disease and medial artery calcification, what is known as a SAD and a MAC index. Now, these SAD index, that is small artery disease, is decided on a clear-cut X-rays of a AP and lateral view of a foot, and medial artery calcification is decided on an angiography. So as our experience, all of us have that many times, even after angiography, the wounds don't heal and patient still lands up in a below knee or above knee amputation. In our setup, it is more crucial because patient has to pay many times and it's a prolonged illness. So this study very clearly shows a study consisting of more than 600 patients spread over 3 years. And it showed that if SAD and MAC index is above 1 or it is reaching 2, then even with angioplasty, the wounds will not heal. And then such patients have to be given two choices, some palliative treatment or immediate above knee or a below knee amputation. Patients are less likely to be active if they are above 65, 70, they are alcoholic or suffer from hypertension or dementia. Debridement, as has been shown, has to be very thorough. Necrotic or a senescent tissue has to be removed. Sharp debridement is essential for ulcer therapy, and we should not underestimate the power of knife. So proper debridement involves all this, but in case of infected wounds, immediate surgery is mandatory in spite of all these factors which we try to control. So general principles: creation of adequate protective soft tissue envelope, prevent equinovirus by rebalancing tendon and tendoachilles lengthening, preserve all viable tissue during the debridement. And angiosome concept has to be followed. There is a 50% higher salvage rate if you follow angiosome, and twofold advantage of vascular bypass over a endovascular procedures. So these are few picture of a correct angio debridement, and then you can see these are late arrivals. Such patients are very difficult to manage. This is how the schematic drawing. Now this I just want to comment. This looks like a below knee, but this has been shown for a science for a removal of a talus. So these are the schematic drawings of various amputations. For big toe, try preserving the MTP or at least 1 centimeter of the proximal phalanx. Base of the distal toe insertion has to be preserved. Remove articular cartilage. And you can see that if you do a correct amputation, remember the traditional incision used to be on the plantar surface, which has been taught for years. But every scar on a plantar surface is a future ulcer. So you have to be very careful about plantar incisions. Ray amputation, better to excise the MTP and the complete ray. As far as the fifth ray is concerned, you have to preserve the base because that is where peroneal tendons are inserted. So this is how you can do a ray amputation, and then later on you can do a grafting. So if there are more than 2 toes are involved, either big toe or a small one of the smaller toes, or more than 2 smaller toes, then it is safer to remove all the smaller toes, keeping first toe. But now the recent biomechanical evidence over last 3 years shows keeping first toe, it really does not help because it starts deforming. So the standard procedure is that if you have more than 2 toes involved, then it is safer to do a transmetatarsal amputation. So transmetatarsal amputation ensure adequate perfusion and You have to do a plan osteotomy, create a parabola with second metatarsal slightly longer, and mandatory tendo-Achilles lengthening. You can see this is how it looks. Lisfrancs preserve the proximal portion of the second metatarsal, tendinosis of tibialis anterior tendon to the cuboid. Try using plantar skin to cover the anterior aspect of the amputation stump, and resect at least 1 centimeter of a distal Achilles tendon to avoid equinovarus. And this is how it has to be done. It requires a very corrective footwear which needs to be fabricated. This is a Symes amputation which can be done, but the problem with Symes amputation in Indian context, you don't get a proper Symes prosthesis or a support. So people start walking on the stump, especially in the rural area, and then they come back for a below knee amputation. Below knee amputation, the sural artery is usually spared of peripheral artery disease. So use the posterior myocutaneous flap. Tibial osteotomy 12 to 18 centimeters from the tibial tubercle. Also, fibular osteotomy 1 centimeter proximal to the tibial osteotomy. In case tibial length has to be reduced to 8 centimeters, then you'll have to excise the whole tibia and resect the peroneal nerve. Anterior distal edge of the remaining tibia is to be beveled. Tendinosis to the distal TA to the tibia, and two-stage procedure in an infected patient is always better than having a primary closure. Above knee amputation, preferred site is 15 centimeters above tibial plateau. Equivalent anterior and posterior myocutaneous flaps. Suture adductor muscles and iliotibial tract to bone end, and quadriceps and hamstring to be sutured to each other. Tendo-Achilles lengthening, as all of us know that it is very important thing, and you can see one of the examples of why the forefoot ulcers keep on recurring. The ulcer like this will not heal unless you do a tendo-Achilles lengthening. Similarly, tendon transfers. When you reduce the length of the foot, see, foot is a very biomechanical structure. The 2/3 of the foot is in front of the fulcrum, which is ankle joint, and the pulley is formed by the gastrocnemius soleus. If you reduce the length of the foot to half, but the strength of the pulley remains same, then you will have to correct that balance. And there are two tendons which you need to correct. Either you do a tendo-Achilles lengthening or a gastroc resection after doing Skillfaller's test, or in addition you have to transfer the tibialis anterior tendon to the other side. You can see this is how it is done. Similarly, for a recurrent ulcers which occur on the plantar surface in spite of tendon balancing, you may have to do a pan metatarsal head excision. As you can see, this ulcer was there for many years, and then with a pan metatarsal head excision, it healed. It has to be done on a from the dorsal approach, and you can do either single incision, and many of the procedures are done by many people with a transverse incision. Summary: amputation is not to be seen as a failure of treatment. Limb salvage needs to be considered as an energy expenditure is much less. Will this patient be more functional, as I said earlier, with a salvage limb or a below knee amputation is the first question we have to ask when we see the patient. And remember this dictum, mobility plus activity is a longevity. If you keep the patient offloaded for a long time, there are studies which we have done in Amruta Institute in 2015 and a Georgetown study which has come out in 2019, which has shown that if you keep the patient offloaded for a long time with whatever device, there is a very high cardiovascular mortality. So either you have to heal the wound very rapidly, or you have to do a very early higher level amputation, because the newer prosthetic science can give a very good prosthesis, but you have to take an overall picture into consideration regarding patient's social support, patient's financial condition. All these factors do matter in India. So just to end again, stress is that function is the goal. It is not the only limb salvage, the function. Unless that limb which you have salvaged is a functional, patient will be immobile, and that is a very high cardiovascular risk. And try to limit amputation to minor amputations, because this is all statistics shows that 83% of non-traumatic amputations are for diabetic, 10%, 10 times risk of amputation when compared to non-traumatic people. 15% below knee amputations are converted to above knee. 15% of minor amputation and 32% of major amputation result in long-term placement in nursing home, or in our society they will be completely immobile. And 30 to 50% of major amputation, many patients are wheelchair bound. So I would like to end you by showing this famous saying by George Bernard Shaw, that people are willing to pay large amount of money for amputation, but very few rupees or few dollars or few pounds for the saving the feet. Thank you.
Thank you, Bharat sir. That was a excellent talk. And there is one question in the chat box.
Yeah.
Sir, what is your experience or take on knee disarticulation? What is the best indication for knee disarticulation? And won't it be advantageous having preserved a longer length?
Yeah, that is true. See, there are many centers in UK, and especially in Georgetown University in United States. They do in a selected cases through knee amputations. So it's a useful thing. Somehow we have not been able to do, for a simple reason. Majority of our patients who come, they have a bad infections. So in such patients, to try to preserve the length or go above and do through knee, and if it gets infected, it patients lands up with above knee. So that is the main concern. But I agree this should be done so you can preserve the length and give a good prosthesis.
But sir, won't it cause problem because of the presence of the femoral condyle? Won't the tip of the stump become very bulky? Because it is said that when you want to put in a good prosthesis, the stump has to be a conical stump, not a bulky stump, not a blobby type of stump.
That's true, but now still there are a lot of newer varieties of prosthesis which are available. If the patient has no financial problem, you can devise a very good prosthesis and they can still walk. So every case has to be decided on its own merit, and you have to think of the patient's financial condition, because these through knee prosthesis are quite costly. And if the patient is unable to afford that, and then if it requires some repairs and all these post prosthesis expenses, then it's of no use. So you have to take each case on its merit and decide. But it can be one of the good options.
Okay. And can you tell us any society which can work for providing prosthesis to lesser privileged people of the society?
There are a lot of societies like Siddhivinayak Temple, which funds many of our patients. There is a Mahalakshmi Trust in Bombay, which funds many of our patients for prosthesis, not only for prosthesis, but for the treatments, even during pandemic. They are helping us to do that. So there are because I am practicing in Raheja, which is at Mahim. So these are the two institutions in which we send the patient, and many of these patients are funded, if not fully, at least a major amount by these trusts.
Okay.
Dr. Amrish, are you able to share your slides now? Dr. Amrish, are you able to share your slides?
Please unmute yourself.
Yeah, are you able to share your slides? You are muted, still muted.
Sir, he's trying. I'm there on call with him.
Achha. Swapnil, what is the issue with his sharing the slides?
After sharing the screen, somehow he's not getting an option to share his PPT. So I have his PPT as a backup. I will share it if it doesn't happen.
You think you're going to
Dr.
take
Balyar
time?
Singh, I think it may be better to do that. Please unmute yourself and let Swapnil share the screen from his end.
No, my presentation is not there with him. I have to send that. One second, I'll try once more.
The next option, if he is not able to do it in a minute or so, we can go to the next session and he can be adjusted in the next session. That itself is a rehabilitation session. Actually, virtually the time is of more essence. People get too much jittery just sitting on the chair.
Dr. Amresh, can you disconnect from the meeting and join back again?
Okay, fine, I'll do that.
Yeah, just leave the meeting and join back again.
Dr. Kamath, I think you start the next session. He can present in the next session.
Okay.
Thank you, everybody. Yeah.
So, thank you so much. I think Dr. Dharap and Dr. Pradeep Sharma for chairing this session. And,
thank you so much.
Thank you, Dr. Ramakant and Dr. Arun Bal for excellent presentation. The next session is session 5, which now I think Dr. Milind Ruke will take over as MOC from here on. Are you there, Milind?
Yes, I am there.
Yeah, great.
Am I audible?
Thank you so much.
Okay. So
you are very
we'll
much
start
audible.
with, yes, I welcome all the delegates and the faculty and chairperson for this, and we'll start the session 5 immediately. And it is a symposium on rehabilitation and prevention. And for that we have chairperson Dr. Anjali Dhawale, who is a consultant surgeon in Dhawale Hospital, Nanded. Dr. Anjali, you're there?
Dr. Anjali hasn't joined, so you can move to Dr. Rashmi. She has joined.
Okay, so the second chairperson for this session is Dr. Rashmi Mehta, who is a consultant general surgeon for RK Hospital in Santa Cruz and Sarla Hospital, Santa Cruz. She is also attached to SL Raheja Fortis Hospital, Mahim. So I would request the chairpersons to introduce the next speaker. I think Dr. Rashmi, you are unmute yourself.
Good afternoon. The next session is on rehabilitation, and the first speaker is Dr. Vibhakar Vajrajani. He is an alumnus of MP Shah Medical College, Jamnagar, having done his MBBS and MS from there. He was a consulting general surgeon at Rajkot from 1990 to 2002, and subsequently he has been practicing as a diabetic foot surgeon. He has trained in diabetic foot surgery from Raheja Hospital, from London, Chicago, and he has done antibiotic stewardship course also. He has written 2 Gujarati books for prevention of amputation in diabetic patients, namely Bachavi Pag Ghumiye Jug and Chat Sawal Pat Jawab. He has also published a book for doctors and wound care professionals, namely The Science of Wound Healing and Dressing Materials. He has presented papers in international conferences and appeared as a faculty in many state and national level conferences. He has delivered 100 public awareness lectures in Gujarat. Over to you, sir, Dr. Vajrajani.
Am I audible?
You have to speak a little louder and please share your...
Yeah. Am I audible?
You're audible, but you have to speak a little louder, sir.
I'll do that. Hello? Hello? Is that okay?
Yeah, go ahead.
Yeah, okay. So I share my screen. Yeah, okay. Okay, so I think I'm audible. Okay, and I have shared the screen. Is that visible?
Yes, sir.
Yes, it is. It is. It is
Okay,
visible.
okay. So good afternoon, friends. At the outset, I thank Dr. Milind and the whole team of Mumbai surgeons for inviting me to share my views. The topic looks very simple, but it is very difficult. See, rehabilitation of diabetic foot patients. Friends, rehabilitation is a process of helping a person who has suffered an illness or injury restore lost skills and so regain maximum self-sufficiency. It is ensuring recovery from any kind of disability, injury, or the habit. Rehabilitation does not reverse or undo the damage caused by disease or trauma, but rather helps restore the individual to optimal health, functioning, and well-being. This is what is rehabilitation means. Now, there are different types of rehabilitations: occupational, physical, and speech. We will not touch the speech part, but the stages of rehabilitation starts from when the patient gets entry to us. Patient comes to us for the first time. Phase 1 of rehabilitation is control of pain and swelling. Then phase 2 comes is improving range of motion and flexibility. Then improving strength and begin proprioceptive and balance training. Then balance training and sport specific training if required in some of the patients. And then gradually return to full activity. Now, each type of rehabilitation therapy can be assessed in different various health settings. See, it is inpatient rehabilitation, then outpatient rehabilitation, and home-based rehabilitation services. Now, why we think of rehabilitation is $1 million question. See, all the speakers have told, they know, and we all know that there are chances of reoccurrences of ulcerations in a diabetic foot up to almost 100% in 40 months of time. And the amputations are mostly 85% of amputations are due to diabetes. This is the burden. And that's why we need to see that once the patient has foot problem, must be educated, rehabilitated to do a normal activity for a very long time. Another very important thing is diabetic peripheral neuropathy. And this changes the anatomy and physiology. And because of nerve conduction problems, muscular dystrophy and weakness, and impaired neuromuscular coordination, there are so many problems in day-to-day activity. Friends, range of joint motion, stretching exercises, Bergen-Allen exercises, proprioception and balance exercises, they are very helpful in patients with or without diabetic foot problem. And it is said that it increases the blood flow and helps the process of healing. In diabetic patients, we also know that regular activity, physical activity is always important. And to improve the circulation, and that improvement in the circulation will reduce the fibrosis and the range of motion problems in different joints. See, the quality of balance is linked to vestibular, somatosensory, visual sensitivity, and motor outputs. This is the thing. The neuropathy creates a problem. Each of these efferent and efferent systems can be compromised in diabetic patients, but somatosensory sensitivity and motor outputs are more susceptible to damage by diabetic peripheral neuropathy. And here is the role of exercise and training. Friends, to all my diabetic patients, even if they have foot problem or not, my advice is from day one, cycling, swimming, and upper limb exercises. Because during their lifetime, when will they get a problem in the foot and they stop doing activity and exercises? We don't know. So if they are doing cycling, swimming, and upper limb exercises also regularly, I think that would add to the recovery if they get a foot problem. Cardiorespiratory resuscitation is always there in any patient, like post-operative patient of any specialty, but deep breathing exercises, pranayams, vastrika, breath holding, all these are better and they take care of better if the patient has diabetic foot problem as well. When the patient gets admitted, the inpatient rehabilitation starts with immobilization, rest and elevation. This will restrict the spread of infection, reduce edema, reduce inflammation, and will start recovering. Foot and ankle exercises are very, very essential if it is permissible. Patient should be advised to stand by the side of the bed. If the one foot is not working, patient cannot use one foot, but still on the other foot, normal foot, patient should be asked to stand by the side of the bed and start using walker as well as and when possible. When the patient is at home, outpatient, every visit, the patient should be advised to do the exercises. They can be advised to go to a physiotherapy clinics which are well established and equipped. They should use walkers, specialized footwear, Pro and PCCs that we'll see afterwards. Gait training is very, very essential. Psychotherapy and of course, entertainment of any sort is a part of rehabilitation. Midfoot problems, pronation, supination, plantar dorsiflexion, eversion, in all these types of exercises the patient is supposed to do. We have probably forgotten the toe movements. The diabetic patients, they cannot do abduction and adduction of the toes from day one. I think we should start giving them the advice so that they can pull in, they can become better afterwards. Major amputations, compression, bandages after the stitches are out, shrinkers for the better shape of the prosthetic stump, standing on one limb and balancing. Sometimes what happens that for 3 months, the patient doesn't do any activity. And after 3 months, the patient goes for prosthesis, but the prosthesis cannot fit. Patient cannot stand up. So this is an advice which we should give to a patient. BK patients, sometimes if they are ischemic and we have done below knee amputation, their knee goes for some flexion deformity, permanent flexion deformity, and then prosthesis becomes difficult, standing erect becomes difficult. So AK and BK patients, they must be advised different types of activity of the movements of the ankle and even hip joint, rotation movement, abduction movement, adduction movement of hip, because above knee prosthesis fitting and the movement again is a problem. This is an example, little bit of even flexion deformity. The patient cannot be fitted with a better prosthesis. Friends, scar stretching exercises are very, very essential. Once the healing is good, but if it crosses a joint, once the patient starts walking, that scar breaks and re-ulcerates. So these are the examples of very good healing, but then the scar breaks. And then the problem here is the scar ulcer, which occurs, reoccurs and reoccurs. Here, excellent healing, but if we don't advise them scar stretching exercises, this breaks like this and creates a problem. So the patient cannot live normal, healthy life after even the wound has healed. See, our desire is to give them an excellent footwear so that they can live their normal life without complications and without deformities. But unfortunately, the patients come with these types of footwear where the footwear cannot take care of their feet, and so our rehabilitation cannot work. So we need to give them a proper footwear so that they can maintain the shape of the foot and maintain healthy post-diabetic treatment, foot treatment life. See, giving a 4-foot ortho-wedge footwear looks very simple, but to walk on a 4-foot ortho-wedge footwear like this is very difficult. We need to educate them. Otherwise, they fall down on the 4-foot ortho-wedge footwear. Here, heel wedge footwear, we advise the patients, but training is essential because so many patients have heel walk gait, and if they wear this, they fall down backside. So we need to train them how to walk on a footwear like this. And again, a rocker bottom type of a footwear what we provide to our patients with the midfoot problems and all. Training is very, very essential. Otherwise, they just cannot accept our footwear and they will go on complaining. If there are midfoot lesions, the device is like the removable total contact cast or removable casts, all these are available, which needs to be advised and needs to be given training of. Only difficult part to rehabilitate, to see that a patient of Charcot foot lives a normal life for a very long time without amputation is a $1 million question and a very difficult task. See the ulceration, re-ulceration, the collapse and deformities and all these are so bad that we treat by total contact cast or whatever the cast or whatever is the device like Crow, whatever is available. But we need to train them, we need to educate them, and we need to see that they have better compliance. Otherwise, this fails, and patients of Charcot foot, they go for amputations. See, unstable ankle again needs a special care because the patient cannot walk on an unstable ankle. We need to provide them a specialized stabilizing orthosis, which may be right up to the knee joint, or it can be even patellar tendon bearing orthosis where the ankle is taken care of and patient can do their day-to-day activity. Our purpose of rehabilitation is to see that whatever problem the patient has, either we remove that problem or we see to it that the patient has somewhat normal life to live. Air cast type of pneumatic walker devices are there for plantar ulcers, for Charcot foot, and they give excellent results. Our aim of prevention will be discussed afterwards in the second lecture also. But to keep a patient healthy, to keep a patient disease-free, we need to provide them the footwears to prevent the deformities of the toe also. Any footwear, if it is worn, but if there is a space for the toes to deviate, then there is deformities of the toes, and that deformity then creates a problem. So we have a footwear with a filler. This is a filler. So footwear with a filler will maintain the anatomy in which we have kept the foot after operation. So that is an essential part. And gait training, you know, after operation, even without the amputations also, sometimes patients need support of crutches or wheelchair or walkers. This is an essential part of training and rehabilitating our patients after operation or with foot problems. Now, anything what we do is going to reoccur if there are certain problems, certain anatomical and pathological problems. See, Achilles tendon, which is short, it needs lengthening. There are some silicone injections and callus can be treated. Metatarsal heads can be resected, osteotomies and correction of all other types of deformities. This is an essential part to keep a patient disease-free. And friends, preventive exercises have a role. Preventive exercises, they keep the psychology of the patient good. It maintains the blood supply, and especially the patients with neuropathy, they will not go for more and more deformities if preventive exercises are done. There are studies on preventive exercises and healing of foot wounds. In a couple of studies, it is shown that in prospective experimental pilot study following a 12-week exercise program, the patients practicing the exercise were reported to have faster ulcer healing compared to those who did not participate in these exercises. So exercises which are possible should be advised and patient should do. But to rehabilitate a patient, a farmer, a laborers, sometimes housewives, elderly patients.
Sir, your talk time is over.
Yeah. So we need to take care of them and educate them. So to summarize, let me tell, because diabetes is a lifetime disease and we need to educate them to keep healthy. Food problem is costly, gives psychological trauma, it is time consuming. Early to work should be our motto. Physiotherapy, psychotherapy, rehabilitation therapy are essential to live with healthy food, and regular exercises are best for early rehabilitation. I think, thank you very much. This was the last slide. Thank you very much, and thank the whole Mumbai Surgeons Association team to invite me. Thank you.
I think we'll take the questions at the end, Dr. Niranjan.
Yes,
And
yes,
a
very good.
warm welcome to Anjali Dowle, madam, who has joined now. She's the next chairperson with Dr. Rashmi. Dr. Anjali Dowle is a consultant dynamic general surgeon from Nanded, presently treasurer of Maharashtra chapter of surgeons. She is executive member of Association of Breast Surgeons of India, also of Venous Association of India, and was the scientific chairman of 2017 Massicon Nanded. Madam, welcome, and I think both of you can now, Rashmi madam and Anjali madam, can continue with the proceeding by introducing the next speaker, Dr. APS Suri.
Thank you, Dr. Milind Ruke, sir. The next speaker is Dr. A.P. Suri. To introduce Dr. A.P. Suri, sir is a president of Indian Podiatric Association. He has completed his podiatric education from Harvard University, USA, and presently sir is head of department at Fortis Hospital, New Delhi. So welcome Dr. A.P. Suri, sir. He will be talking on prevention and care of diabetic foot, do's and don'ts. Over to you, sir.
Thank you, Chairperson, for that introduction, and thanks to the. Am I visible? Yeah.
Yes,
yes,
sir.
Sir. Yes, sir.
Yeah. I'm sharing my slides. Thank you for the organizers, Dr. Niranjan Agarwal, Dr. Kamal Gupta, and Dr. Yadav for inviting me in this forum. And all the topics since morning have been very elaborately taken out. The topic given to me has been prevention and care of diabetic foot, and I think a lot of things have been covered by the previous speaker as we have listened. Foot care and podiatry prolongs the life of the legs. That is very important. All diabetic patients who are under care of a podiatrist once in a year or twice in a year, internationally also we see that that is the thing that is a main model of prevention for these diabetic patients. I think everybody in the panelists and delegates would be knowing these do's and don'ts. I don't want to go into the details for this prevention program. But a point to mention here is that all patients, all diabetic patients, by the time they are sitting in the clinic, they should have some handouts of these things, that these are the things to do and these are the things not to do, so that we can really prevent the whole vicious cycle of this, what we have been listening since the first lecture of today. Self-examination, this is also one of the very good models of prevention, that all patients should be advised to examine the plantar surface of the foot when they have neuropathy. A simple neuropathic ulcer like this causes the whole vicious cycle, and that leads to the amputation or the forefoot, midfoot, or the below knee amputation, and what Dr. Bal and everyone has been, Dr. Ramakant sir has been speaking in the previous lecture. If you look at diabetic foot, it is a high risk foot. Peripheral neuropathy, peripheral vascular disease, and altered biomechanics. These are the three main domain of the diabetic foot, and we have to tackle this one by one as we have to prevent these patients into this. A simple neuropathic ulcer comes over here. Patient don't feel that they are walking barefoot, and this is a non-infected neuropathic ulcers. A lot of patients they have 2 toes amputated, but then also they are walking barefoot in the office, and this is the office pin impregnated here. So education of the patient is very important if we have to prevent these patients from getting into amputation or more infected diabetic foot ulcer. Foot examination by 10-gram mole of filament. This should be the part and parcel of every physician or every surgeon, or even the paramedics who are dealing with this in the diabetic foot care department, that we need to have this instrument to check for the peripheral neuropathy by the time the patient comes with this. Also, foot examination is very important. As I said, self-examination, giving insoles to the patient, finding out high pressure areas, and 128 hertz tuning form, and foot examination by monofilament. This is one of the most preventive models for early detection of neuropathy, because if we find early detection of this neuropathy, we can really give good education to the patient, what type of shoes to wear, what type of soles to wear, so that we can redistribute the pressure from the high pressure areas to the low pressure areas. Coming down to peripheral vascular disease, lot of time they are the shoe bite, they are in the tight shoes, they go to pilgrimage, they have swelling in the feet, compartment syndrome, and then they develop into this peripheral vascular disease. Checking for ABI index, Doppler scans, and even toe pressure. Sometimes they have distal calcification, so we should rely on the toe pressure more to find early detection of this peripheral vascular disease, and that can again be a very good preventive model for these patients to go into these amputations. Now I'll share this slide by Dr. Rogers, that if we can early detect neuropathy and peripheral arterial disease, we can really prevent this patient from getting into injury, wounds, infection, gangrene, and later down to amputation. So from here to here, the whole vicious cycle can be prevented if we can really prevent or early detect neuropathy and peripheral vascular disease. Coming down to altered biomechanics, this is also very important thing. You see a lot of these diabetic patients, they have low arch, they have flat feet, rocker bottom soles with a Charcot's foot, or they are hallux valgus, hallux rigidus, bunions, or they have high pressure on this area. So we can do plantar testing over here with the plantar scan and find out the high pressure areas, and then we can offload with giving specific insoles, where we can shift pressure from the medial side to the lateral side, or lateral side to the medial side. We have a longitudinal arch and a transverse arch, and these type of insoles can be given inside the shoe of the patient, and they really like it, rather than giving a diabetic shoe or a diabetic sandal. Because of the cosmetic reasons, these patients are not able to wear, or these type of Poron sheet insoles or orthotics like this can be given, where we can really prevent these patients from altered biomechanics, because we have seen that altered biomechanics with neuropathy is the main culprit for the formation of these ulcers. These are different type of diabetic shoes which can also be given to the patient. If we come down to preventive model, most foot problems are preventable through early identification, as I already said, and prompt treatment by skilled health professional, that is you and me. If we look at prevention model, there are two models. One is primary prevention and one is a secondary prevention. If you look at primary prevention, no successful clinical trials are there. Metabolic control is important, and smoking cessation. These are two very important in the primary prevention, that if we can do that. And HbA1c control and role of physician is very important in a diabetic foot care multidisciplinary teamwork. Secondary prevention, we need to identify high risk foot. Like I said, early identification of neuropathy, peripheral vascular disease, low arch feet, Charcot's foot is very important to early high risk foot education, foot care, and management of active foot problem. A simple foot ulcer is a neuropathic stage or a non-infective stage. If we can handle at that area, we can maintain moist wound healing, we can give them good dressings and antibiotic coverage if it gets infected. In the initial phase, there's no role of giving antibiotics to these patients. So management of active foot problem is very important. We have to maintain a secondary prevention model. There are some innovations in prevention. I'll cover this in next 5 or 10 slides. Temperature monitoring, surgery to improve ankle motion, activity monitoring, shear reducing insoles, and neuropathic footwear. If you look at temperature monitoring, this is a touch thumb temperature. This is a very good model which can be given to the patient. IDF gives free of cost to the patient. We also give that to free of cost to the patient. It has got a long arm which can be applied with a thermal scanner. The patients can themselves apply on the dorsum of the foot or the plantar surface and find out the temperature difference. If there's a more than 2-degree temperature difference, we tell the patient to come back to the doctor or go to the foot clinic or to diabetologist or physician. And early detection or rise in temperature by this thermography is very important. And early detection of Charcot's foot can be prevented by using this type of test and temperature. Infrared temperature assessment, this is also very important, but yes, it's not available in our country. Very costly. A single unit costs about 30 to 35 lakh rupees. So by these type of pressure ulcers, they can be very well early detected by infrared temperature assessment, and we can really prevent these pressure necrosis and necrotizing fasciitis which is developing on the heel area. Charcot deformity, I think we have been listening since morning. Dr. Ashu has taken a very elaborate lecture on Charcot deformity, but this is something we can early detect This is something that we have to see a devastating bone and joint deformity. It is usually misdiagnosed as cellulitis, gout, or deep vein thrombosis. Any patient who comes with a unilateral, a hot swollen foot, you should first think of Charcot foot. Second should be your cellulitis, gout, or vein thrombosis. If we keep on this, because if we are suspecting Charcot's foot, that is one we can really prevent this. This is something, if we don't early detect, this is a stage where patients land up within 2 to 3 years of time, total disarticulation of the tarsal metatarsal joint. So there are two very important things in the preventive model. One is TCC cast. I think the day you see a patient in your clinic, before doing anything, advise this patient that you have to do offloading, offloading, and offloading. And this could be possible only by total contrast cast. If there's no ulceration, or you go into this AFOs, cast walkers, RCWs, they can be removable and irremovable cast walkers. There's a whole debate on this model, but yes, this is one of the gold standard. By the time you convert this active Charcot to inactive Charcot, otherwise they get into rocker bottom deformity, total collapse of the arch, and then the ulceration occur and whole vicious cycle. And most of these patients will go into a below knee amputation. And this is rocker soles. It rocks soles from the heel. There are different models. This is a Mollister Optimal sheet. This is again a shoe from Italy. We were using many years back at our center for 2 to 3 years. We were getting directly from Italy, but not available now. This is going to be launched in India. But these are very important rocker sole shoe which can be given to a Charcot patient, and they can walk comfortably. They can go to the office and they can do. But this is something a very good preventive model, and I think everybody should practice this in this. Pressure ulcers, this is one thing. When the patient comes, long-term admission in the clinic, in the hospital, you see a pressure ulcer developing here on the posterior side of the Achilles tendon. On the lateral arch, when the patient is on the left side or right side, you see. And this is how, if with pressure ulcer, if patient has got underlying peripheral vascular disease, and these ulcers can really devastate and go into a very major amputation phase. So it is a big financial burden also, because patient has come to the hospital for something else and they have landed up with this, so which is totally a preventable thing we should be practicing. So whenever we have to guide our nursing staff to get rid of these pressure ulcer, or patient should not get into these type of pressure ulcer. So this is also one of the prevention we should practice in our practice when the patients are in the hospitals. How to prevent it? Temperature difference. We should see how much time the patient is lying on the bed on one side. So nursing staff, we have to really take care of the nursing staff. We should maintain guidelines in the hospital how to prevent these type of pressure ulcers, and regular shifting in the bed, mainly in the ICUs or neuro ICUs. I regularly get calls from the neuro ICUs or from the cardiac ICU when patients are lying for weeks together, that how we have to prevent these pressure ulcers. Callus, many of time patients come with this clean callus. Callus debridement should be part and parcel. Even your paramedics can do that. But giving insoles is very important to these patients. You should offload this. Taking care of nail is again very important. You can see this is in here. It takes many years for this deployment. So whoever doctor is treating that should debride this, should take care of the onychomycosis. So regular examination of a diabetic patient is very important, because these nails, they don't develop over weeks, months, or together. They develop in years. So we should take care of these type of things if we have to really prevent that. There are a lot of surgeries to improve ankle motion. We have already listened, tendo-Achilles lengthening, gastrocnemius resection. These are very common to, we have to relieve pressure in the forefoot area. After doing a midfoot amputation, as Dr. Bal has said, we need to do ankle TA lengthening. That is very important. Until others, a lot of time we give them soles and shoes and front offloading. But even after doing grafting, we have seen that these patients, they come back again with a re-ulceration. So you have to think of these surgeries to improve ankle motion. Tendon transplants are very common, and we should practice that. Another very important thing is fat pad restoration. A lot of patients, they're diabetic, they come with corn calluses, they do corn surgery, they have done cauterization for the warts or these. And when they come back, they have a frank abscess cavities underlying over there, or a frank callus developing there. So fat pad restoration is very common for hallux valgus. Many a time, diabetic patient, they have steroid injections in the heel area. Plantar fasciitis, so dystrophy of the fat pad tissue occur, and there we can take the fat pad tissue from the own body and inject that in the heel area in a diabetic patient is very common, and that can really relieve the pressure over this. Activity monitoring is important. Shear reducing insoles and neuropathic footwear, as I said, is very important part and parcel of this prevention model of these diabetic patients. So we should always think of this. Even when the wound has healed, we should take that what type of insoles have to be given to the patient, what type of arch the patient has, where the pressure is there on the middle of the foot, on the heel area, or on the forefoot area. We need to reduce these pressures for these patients. This is one patient who came to our clinic with a callus over here. So if you don't debride or if you don't offload, very important. Offloading is also important, and debridement at this level and debridement at this level and offloading, because patient doesn't give the compliance and he has a petechial hemorrhage, and subsequently he has a frank abscess cavity over here, and one toe has to be amputated because of the osteomyelitis in the head of the second toe. So these are very small things, but yes, prevention is very important in these type of patients, because you can see the subsequent photographs of the same patient he has landed into if you don't offload or if you don't debride it. This is a callus. I think every panelist or every delegate in this forum should be alarmed that if you see a patient like this, never let the patient go back home. You need, or your staff needs to debride this. Take a 50-number scalpel and just debride these calluses. You don't need any local anesthesia or anything, and give them a soft insole of any insole, PPD, Evazode, Plastozode, Poron, any whatever is available in your city, in your clinic, you should give that, so that we relieve these areas of high pressure areas. Otherwise, the whole vicious cycle will develop, and these patients will get into this cycle. As I've seen, I'm again using this slide, that early detection at this phase and early detection or get rid of this callus. These are the three very important take-home messages of this presentation of mine, that you should early prevention, so that we need to amputate these patients. Fat pad restoration, as I said, is very important. This is to enhancement of fat pad, fat transfer to the dorsum of the foot, allows healing of non-infected neuropathic ulcers. Even the ulcers have healed, they don't have the fat pad tissue. A lot of time when we do MRI studies and see the fat pad under the metatarsal head has an anterior deviation. So when the patient is walking, as the foot goes on the heel of phase, more pressure is coming on the metatarsal heads because there's a fat pad anterior deviation. So that fat pad restoration is very important technique in that areas where we can improve the cosmesis and offload the high pressure areas. A lot of things are available, dermal filters, allograft, autologous fat transfer. But yes, it's not evidence-based. If you have to try, you can try yourself, but I will not say that it's evidence-based to use these techniques. We have talked about in wound care shoes. This is something which is a rocker sole shoe, with rock soles from the heel to the front part of the foot. So this should be in the kitty of every foot care surgeon or a foot care specialist you are practicing. When the wound has healed, you should be in the practice to advise patient to use a rocker sole. This is very important, where rock soles and the pressure, because of the Lisfranc mechanism, your pressure doesn't comes on the metatarsal heads and forefoot area. Podiatry is a very important preventive care, early identification, thorough foot examination, prevention of high-risk condition. As I've said in my previous slide, this is very important. If we can early identify the high-risk patient, and only think these are available, that we need to stratify level of risk, educate people at high risk, identify problems according to them, treat them, taking care of dry skin. In a lot of patients, they have autonomic neuropathy, they have dry skin. We should advise them, nothing is available. Mustard oil, coconut oil, or foot care cream should be advised to these diabetic patients. Health professionals need to be trained in diabetic foot care, and new treatment modalities. A lot of these VAC therapy, PRP, stem cells, other technologies, and extracellular matrix. A lot of new dressings are there. So we should be able to use this. So what is the answer for prevention? It is only education, education, and education. We have to educate our patients on diabetic foot care. We have to tell them what type of footwear to use, how to take care of the cons, calluses, and high pressure areas. Early identification of neuropathy and early identification of peripheral vasculitis is the only take-home message where we have to do the prevention model. Indian Podiatry Association runs this model on learning, healing, and helping our patients, so that we need to prevent. We stand for I Prevent Amputation, and that's all. And that's we are doing an IPA-con on 24th, 25th July, and that's for all today. Thank you so much.
Thank you, Dr. Singh. Any questions?
Swapnil, is Dr. Baliar Singh sorted out? Swapnil? Swapnil, is Dr. Baliar Singh sorted out, or should we move to the next session?
I think move to the next session, Niranjan. I think it's not sorted out.
Okay, fine. Dr. Ruke, chairperson, please thank the speaker and Dr. Ruke please carry it forward.
Yeah. So I think thank you, Dr. Anjali Davle.
Ruke sir, just hello.
Yeah, Dr. Anjali, please go forward.
Yes, sir. Just if the time permits, can I ask one question?
Yeah, why not?
Yeah, excellent talk. Now, in this preventive aspect, I want to ask to both the speakers that what is the present position of the gate labs in India? Because I have seen these gate labs are only available in corporate setup. And what is the scenario in the rural India? That is one. And second, the special making of these shoes. Uh, are we providing any training, or is there any sub-centric areas where these special footwears can be made? And these are my two basic questions, sir.
Dr. Suri, can you answer that?
Yes, yes, madam. Hello. Under
Yes, sir.
Indian Podiatry Association, we are running a training program. This is for the one is for the doctors and one is for the paramedics. We are running this training program to train paramedics how to take care of the wounds and how to take care of the diabetic foot for neuropathy examination, for insoles, offloading, and dressings. So this is very important. That training of our staff is very important. Another thing is that we are also running an online fellowship program for the doctors under an FDFM program. You can download that on the net. And this is also a very good training program, even for doctors and surgeons and physicians.
Okay. And what about the gate labs, sir? Is there any role of gate labs? Because I have seen certain patients in their uncontrolled diabetes and they have an altered gait. And in such scenario, to make the special footwear, there is a role of gate labs, and they are available.
Not many centers have got gate lab, but if you have a plantar pressure sets, you can find out the pressure and gate analysis.
Okay.
No, yes,
Dr.
gate lab
Anjali,
is very important. If there, hello.
Yes, yes.
Yeah, when we can role of gate lab is very important, mainly for the in US and Europe. It's mainly for the research purpose, not on the day-to-day clinical practice. Day-to-day clinical practice, we can just use the plantar pressure techniques to find out the high pressure area. According to that, we can devise an insole or an orthotic, and that can be given inside the shoe of the patient. Where I show you some photographs of the orthotic, they are customized and they can be given inside the footwear of the patient to relieve the pressure, or redistribution of the pressure is important.
Okay.
Yeah.
Thank you so much.
Dr. Anjali, to add to what Dr. Suri said, you are right.
Yes.
These gate labs are available in the private setups. So there is a lot of corporates. There is Autobox company who have gate labs, gate training labs. Also in MGM hospital physiotherapy departments, they have gate training labs. So I think there are a few labs in India where gate training is done and studied.
Okay.
So Manipal University has got very good gate lab. Manipal Hospital, physiotherapy department.
Okay.
So I thank the chairperson for this session, Dr. Anjali Davle and Dr. Rashmi Mehta, and thank for very nice lectures by Dr. V. Vacharanjani and Dr. APS Suri. We move on to the next session of session 6 of invited talk, and for that we have chairperson Dr. Sunil R. Singhal, sir, who is a general surgeon and endoscopist, special interest wound and diabetic foot care. With him, we have Dr. Ashwini Wagh from Sushruta Hospital, Dadar, and she's attached to Dr. S.L. Raheja Fortis Hospital, Mahim, and Dr. P.D. Hinduja Hospital, Khar. I think I hand it over to you as chairperson to take the proceedings forward. Dr. Sunil Singhal, sir.
Ashwini, unmute
Ashwini
yourself.
Wagh.
Thank you, Dr. Milind. I'd like to invite Dr. Kamal Gupta for the next session. Dr. Kamal Gupta will be talking on time principle in the management of diabetic foot. Dr. Kamal Gupta is a certified trained specialist in laser proctology, fellow of the International Society of University of Colon and Rectal Surgeons, and he is a postgraduate faculty for DNB for general surgeons. I'd like to invite Dr. Kamal Gupta, please.
Thank you, ma'am. May I share my screen, please?
Sure, sir. Please go ahead.
Yeah, respected chairpersons, dear colleagues, a very good afternoon to all of you. Before I start, I would like to say thanks to Dr. Niranjan Agarwal and office bearers of Mumbai Society, Surgical Society for inviting me for this talk. In general surgery, two branches are there which are most neglected. One is proctology and second is diabetic foot. So before I start, I would like to say a big thanks to my great teachers and my friend, Dr. Niranjan Agarwal for teaching me proctology and Professor Ramakant, who brought me into the field of diabetic foot. So coming to today's topic, that is time principle management. And the time principle, already most of the speakers, they have spoken on, different parts of it. So it is more of a concise form. And time principle is not limited only to diabetic foot, but any wound which is present anywhere in the body. So time principle, the idea is, it is based on how to assess a wound, then intervention, and what is the final goal. And time means tissue, infection, moisture, and edge of wound. Now, what is the importance? The importance is, the most important, we should know the debridement. Ramakant sir has covered it beautifully. Exudate management, how to manage it. Most of the speakers have spoken about that. Bacterial balance. Now, antibiotic lecture we had in the morning. Then identify and remove barrier to the wound healing. So we are supposed to identify why the wound is not healing, and then how to promote wound healing. Now, it was in 2005 when the principle of wound management came, time principle, the cycle, and that was for the wound bed preparation. So always start with the patient, identify the wound etiology, whether it's infective, ischemic, both infective and ischemic, or it's a decubitus, or it's a neuropathy. Then perform time assessment, how it is to be performed, I will be discussing shortly. And then treat and evaluate how to intervene, and when to intervene, when not to intervene. And then the final result, whether the wound has healed or not. If it has healed, how to prevent it. Like Dr. Suri has spoken about it, Dr. Bal has spoken about it. And if it does not heal, then what to do? So you have to start from the beginning. What are the factors which you are missing over there? So the first step in wound bed preparation is wound cleansing. The purpose is to remove all the debris from the wounds, the devitalized tissue by debridement, the microorganisms of the bacterial load, and maintenance of the exudate. Now, normally we use normal saline solution, but what they say now, the water which is good enough for drinking is good enough for cleaning of the wound. Although most of us do not use water, routine water for cleansing, but yes, in the literature, it is very well mentioned it can be used. Now, with the pressure, it should be 8 to 10 pounds per square inch pressure, which you can use with using a jet or pulse jet, which it is called, and many orthopedicians also use it. So with that, you can maintain a pressure and clear the wound bed. So coming to the first part, that is assessment of the tissue. We have to first make out what type of tissue we are dealing with. Is it necrotic tissue? And the characteristics of necrotic tissue means it's a dead tissue. There is cell death, and because of lack of oxygen as well as ischemia. Two types are present. One is scar formation, that as you can make out in the picture over here, it presents as a dry, thick, leathery tissue that is often tan, brown, or black in color. And slough, this we see in most of the patients which come to us in day-to-day practice. So this is devitalized, a combination of devitalized proteins plus collagen and fibrin. It may be yellow, tan, or green or brown in color, depending on what type of infection we are going to have over there, and may be moist, loose, or stingy in appearance. Second is whether the tissue is granulating or not granulating, or it is healthy or unhealthy. So unhealthy tissue usually is black, dusky red, or dusky red in color, and it does not bleed. Dr. Tushar Rege discussed this point in the morning in his talk. Healthy granulation tissue is when it is red in color. This means it indicates a good wound healing. Then epithelializing tissue. So epithelializing tissue, if you can make out from the margins and from the base, it looks quite pink and it is shiny in appearance. Now, if there is a gangrene, we have to identify whether it's a dry gangrene or a wet gangrene. So in case there is no infection, it is called a dry gangrene, but in case there is superimposed infection, that means it is a wet gangrene. Interventions. Debridement plays a very important role. Dr. Bal stressed on that. Use a knife. Then Ramakant sir gave a very nice talk on that. So removal of devitalized tissue until surrounding healthy tissue is exposed, that should be the principle of debridement. Contraindications, non-infected wounds, lower extremely arterial diseases, which have been already discussed. Ramakant showed a case also in the morning. Then stable, intact scar on the heel. Never ever excise it. Indications, infected wound, necrotic and sloughy wound. Now, what are the advantages? It allows accurate assessment of wound. Once you have removed the devitalized skin, the superficial part is removed, we come to know what exactly the size of the wound, the pus which has to be drained, removal of dead tissue, and it provides deep tissue from wound to be taken for culture sensitivity. Now, always remember, when we talk about taking a culture, never ever take a swab culture. It is a deep tissue culture which should be sent for culture sensitivity, preferably in peptone water. Then it facilitates wound healing by converting a chronic wound into acute wound. Now, what is the warning sign over here? Even if you are going for debridement or a very, very little or small, amputation, make sure at least one of the two vessels, that is dorsalis pedis or posterior tibial artery, is palpable. And in case they are not palpable, think twice before going for any sort of surgical management. Types of debridement: autolytic, enzymatic, mechanical, surgical, and biological. Now, most of them have been discussed. I will be discussing with you in short the principle about it. So autolytic debridement is, the principle behind is that the body's enzymes, own enzymes and moisture with hydrocolloids and hydrogels are used. Advantages: it promotes moist environment. Limitations: it's a very, very slow way of debridement as compared to surgical debridement. And the common agents which we use is intrasite gel. Now, I may be taking many, commercial agents name which are available in market, but it's a very strong disclaimer, nothing to do with that. Now, this picture I have taken from my very dear friend, Dr. Vacharajani's book, How to Deal with a scar formation like this. Now, see, it is very clearly, you can make out in the diagram, make multiple incisions, insert intrasite gel, that's all. Wait for the debridement, auto debridement to occur. It will take some time, but yes, the whole scar formation area should not be removed. It is going to take a lot of time, and you're going to remove whole of the fat and necrotic material. Along with the necrotic material, whole the fat you are going to remove over here. Enzymatic debridement, well, it works on the slough. That is a combination of collagen, fibrin, and elastin. It digests the devitalized extracellular material which is present in the wound. Advantages: it's a faster way of debridement. Limitations: enzymes do not affect dry scar. Now, that is the reason I said use hydrogels or intrasite gel at the time of a scar, because no ointment, topical ointment, is going to be effective on that. A scar should be cross-hatched before using enzymes, as I showed you in the picture. And when you are applying the ointment over it, make sure the thickness is at least 0.1 millimeter. The commonest reagents or solutions which we use in our practice, that is Debridase and Zolopac. Mechanical debridement, hydrotherapy, which has been taught since our medical college days, since the last 30 years or so. Two types, that is immersion in the water, this thing tank, and the temperature should be maintained at room temperature, ideally they say, but it is 35 to 39 degrees. And pulse wash, which I was telling you for use for cleansing of the wound bed, that's a pulse wash system which can be used. Pressure, as already said, it's 8 to 10 pounds per square inch. And ultrasonic debridement, it is usually used for small wounds. This setup I have seen at Dr. Suri's place. He has got a wonderful equipment with him, but this equipment is very expensive, cost around 25 lakhs. The limitation, the biggest limitation, you cannot use it on the bigger ones. Now, another equipment which is available, but mainly in the corporate setup and very few private hospitals, that is VersaJet. So VersaJet is that you cut the blade cuts using water as a medium, and the speed of water is 1000 miles an hour, just like a speed of a jet. So advantages, it removes only the necrotic part. The healthy part of the wound is never disturbed. So this is a patient who had presented to us with the roadside accident. After that, the stitching was done, but later on, after 10 days or so, he developed the necrosis over here. With VersaJet, we removed everything over here. And after that, this is a complete healing of the wound. Wet to dry dressing, nothing new about it. This we have been doing since our residency days. And the idea is very simple. When the exudate is there, cover it with dry gauze, keep it like that. And the aim is the water content, the moisture content, which is present over there, that starts coming out. And you may have to change the dressing twice or thrice in a day. Disadvantage, it's a painful sort of a thing. The reason being the gauze piece which we are using, it gets stuck with the tissue. Surgical debridement, already Ramakant sir has discussed this thing in detail, so I'm going to skip it. Biological debridement. Now you see maggots. Sometimes we see maggots in a wound, but we remove them. But at the same time, we use sterile maggots for debridement purposes. The difference is that it is sterile maggots, not the other ones. So other ones, when we see a chronic wound where patient, it's a completely neglected wound, you see maggots over there, idea is to remove them, and the best way to remove them is put turpentine oil, leave it for an hour, and after that, do the dressing. So in 2 or 3 dressings, they will come out. But otherwise, if you want to use maggots, always make sure you are not using them in a tunneling. That is a very strong contraindication for the use of maggots in the wound management. So the goal is to remove all the non-viable tissue and convert a chronic wound into the acute. So the points to remember: when to debride, how much to debride, when not to debride. Coming to the second, that is infection. Now we know the difference between contamination and colonization. Contamination means the bacteria are present, but they are not replicating. Colonization means that the bacteria are present and they are replicating. So for these two, we don't need any treatment, just keep a vigilance over that. But in case the local infection is there, it means it may be because of biofilm. Already this topic has been touched by Dr. Tushar. I will just add a few slides from that. Then local infection, or it's a spreading infection, or it is a systemic infection. These are the three areas where treatment is required. Now, what international working group has to say about the grading of infection? No signs of local infection, it is grade 1. Local signs of infection with subcutaneous tissue involvement is grade 2. Erythema more than 2 centimeters, grade 3. And in case a patient is having systemic infection along with that, it is grade 4. That is called a severe infection. Now, how to do the assessment? The classical signs in acute wound, simple signs of inflammation like warmth, fever, edema, pain, and purulence. And secondary signs in chronic wounds that delayed healing, absent or abnormal or discovered granulation tissue, as already I have shown to you, foul odor and increased serous discharge. Now, coming to the next, how to identify infection. Yeah, the ulcer base looks yellowish gray, purulent exudate is there, sloughing of ulcer may be there, or the bone tissue may be there, sinuses with undermined or exposed bones may be there, and there may be present tunneling wounds below which the lot of slough may be there, and the most important is odor. Once a patient walks in your OPD, if the odor is there, make sure that the patient is having infection. And sometimes if you have a look at the dressing itself, the color will tell you a lot many things. If it is thick brown like odor, it means it is a Staph aureus. If it is greenish color, that means Pseudomonas. And then if it's a fecal smell, it means there is an anaerobic infection. Now, this part has already been covered. Infection, how to choose an antibiotic. So mild, moderate, and severe. Mild, the choice is augmentin. Moderate, vancomycin, and severe, it is a combination of piperacillin and tazobactam. But I will still say that when a patient comes in septicemia, take a blood culture sample, take a culture sample from the wound, start antibiotic of your choice, what you are used to in your routine practice. And after that, once the report comes, look at the MIC values, and then you start the proper antibiotics. Intervention. So after controlling etiology and comorbidities, biofilms are probably the most single cause. Biofilms, you know, what is the significance? Already Dr. Tushar has covered most of it, but I will just share with you in brief. So what is the significance of biofilm? That is the most important for the surgeons to understand, that it decreases the drug penetration, it prevents formation of granulation tissue, it maintains the inflammatory phase, and impairs migration and proliferation of keratocytes, and reduces oxygen supply to the bone. And this is how clinically, if you see how it looks. So when to suspect the biofilm is present? Delayed healing, failure to respond to antibiotic, repeated episodes of inflammation, high levels of exudate, and gelatinous substance on the wound that returns soon after removal. Now, even if you remove biofilm, just remember, if you are not using a proper topical agent, then the biofilm will reform within 6 hours. So removing biofilms, most important is wound cleansing, repeated debridement may be required, and as I said, a topical antiseptic may be required. So this is a small video just to share with you how it can be removed. More useful for, undergraduates and postgraduate students. So this is a patient who had presented with a wound. So it's a biofilm which is present. Now in whichever practice we use PHMB solution. So spray, keep it for 2 minutes. And after that, using a gauze, it's a very simple thing. Just gradually you remove it. So underneath, what you see is granulation tissue, and bleeding is from there. So that is one way, using a gauze. Another way to use is that once the biofilm is present, at that time, you use simple curate. This is washing of the wound using normal saline. And that is how it can be curated. So you can remove the biofilm. After that, apply any topical ointment. So what agents to use, what not to use? Please do not use povidone iodine. Betadine is contraindicated in any type of wound management, especially in the chronic wounds. Now, why so? It does not cross biofilms. It is a cytotoxic drug, and it is very clearly mentioned even in Goodman-Gilman that the prolonged use of iodine can lead to iodine toxicity. And when we are using, wounds over large areas, iodine we are using, maybe in a concentrated form from 7.5 to 10%, the absorption is much higher. Savolon, it does not cross the biofilm. H2O2, it inhibits healing, and it's a cytotoxic. Now, 30 years back, people used to teach us, our teachers taught us, use hydrogen peroxide almost in all the wounds. Now, it is contraindicated. So what to use? Well, silver we can use. It has already been discussed in the morning. And just one line, silver, what it does, it converts the wound from alkaline to the acidic pH. So once the pH is acidic, that is 5.5, the wound, this silver preparation helps in the healing of the wound. PHMB, it acts on the bacteria, on the DNA itself, stops the replication, and it crosses biofilm. Octanidine, that also crosses biofilm, and that is a Zotobac which we use effectively in both gram-positive and gram-negative. And pepinuria, it's a combination which is available in the form, it is the market as a debridase, and pepin effectively digests scar protein, and urea acts on hydrogen bonds, which prevents in protein breakage. Goals to identify biofilm, use an antibiotic, and take care of comorbid conditions. Now, coming to the moisture, that is the third part. Now, we don't have these sensors in most of our hospitals, at least I don't have one, but there is a sensor how to measure how much wound is wet, how much moisture is present. Well, if it is 5 drops, it's called a wet wound, but if it's a 1 drop, that is called a dry wound. So if it's a dry wound, just hydrate it with hydrogel, intrasite gel, as I said already. Wet wound, remove excess moisture. We can use dressings like foam dressings. Dr. Pawan has already spoken about that. Calcium alginate can be used, fiber dressing can be used, and the most important is VAC, that is negative pressure wound therapy. VAC can also be used. So the goal is to maintain the optimal the moisture. Then coming to the last, that is edge. Always we have to assess whether the edge is advancing or non-advancing. If edge is advancing, you will always see epithelialization at the margins. And in case it is, and the ideal wound, it will look like something like this. Now, this is an ideal wound, which should look like this as an ideal wound. It's a thin epithelial margin with pale pink to translucent surroundings. Non-advancing wounds, you can make out it may be either epibole, that is rolling out of the curve, rolled out the margins. Then it may be keratosis and callus formation. I think most of the speakers have talked about this, and unattached or undermined. So whenever you find any case like this or this, always take a biopsy from the margins and send it for histopathology. Rule out any malignancy if you are dealing with. Intervention, non-advancing, surgical debridement. It will freshen the margins. It's a standard practice for all of us as surgeons. And other interventions, you can go for VAC, PRP can be done, or we can use a new product which is come in the market, that is amnion and corium, that is Emcoplast. In our medical college days, when I was doing my house job way back in 87, 88, at that time we used to get placenta from the obstetrics ward, and then we used to apply over the patients in burns especially. But now Emcoplast is available in market. Now, what are the factors which can affect? Extrinsic factors, repeated trauma, ischemia, and poor glycemic control. And intrinsic factors is deficiency of growth factors and reduced fibroblast activity. Now, another thing which we commonly see in practice, although it is not a part of time management, but we should be aware of this, we always talk about epithelialization wound or with healthy granulation tissue or non-healthy granulation tissue. What happens when you get a patient with hypergranulation tissue? How to deal with that? The causes, it may be because of wound infection, excessive inflammation, presence of a foreign body, or a physical irritation. Treatment options, in our practice, we use hypertonic non-saline dressings. Otherwise, silver nitrate dressing can also be used, although I have never used it. And sharp debridement or curating can be done. And surgical lasers we do use, that is diode laser is there with us. So we also use that. And as I said, always send a tissue for biopsy from the margins. So the goals to achieve advancing wound edges for healing of the wound. So dressings, as per guide principle, I will just share with you a few slides. Otherwise, it has already been discussed in detail by the previous speakers. So management of exudate, if it is low, you can go for hydrogel or as a contact layer, and after that a simple gauze can be placed outside. Moderate, we can use alginate inside and hydrochloride or a gauze piece outside. And heavy, just don't bother about anything, go for VAC. Now, what are the markers? Balsar has already shared in his lecture just a brief this thing about what are the good healing markers for as per time management. HB should be more than 10. Albumin should be more than 3.8. Creatinine less than 1.2, and HbA1c level, which is the most important thing, should be maintained between 6 to 6.5. And this is something which everybody has been talking about, ABI, TBI, and make sure that the values are within normal limits. And we had a talk about, hyperbaric oxygen, role of hyperbaric oxygen. Well, we know if you measure TCPO2 and if it is less than 40 millimeter, that is a case which should be subjected for hyperbaric oxygen. Now, coming to few patient descriptions. This is a 65-year-old patient who presented with just a blister he had at second and third toe. And when he came to us, like Ramakant sir showed in the morning, it's a similar case which we had in our practice. And we just had a tunneling wound in this area. My cursor is there. From here to here, there was a tunneling wound, right from anterior to plantar to dorsal aspect. So as he taught me and as he showed in his lecture, we just opened it. Complete debridement was done. After that, there was healthy granulation tissue, and that's the final wound. So patient was happy. And as Dr. Suri mentioned, I prevent amputation. So all of us should try to prevent amputations. And the treatment approach was debridement, vac in between we had used, and then normal dressing with Zotobac and Emcoplast. And of course, offloading is also very important in these patients. Then 56 years old female patient, you can make out a tunneling wound over here. Now this was after the amputation. Amputation was done outside. After that, patient developed a wound. So you can make out the moist, macerated edges which are present over here. Now this is because of, the discharge. After that, what we did, we started with Zotobac and or hydrogel in the beginning. And after that, we just kept on filling it with Emcoplast. So Emcoplast looks very expensive, but it is not. Patient has to come once in 5 days. He saves a lot of money on traveling. So this is the final outcome of the picture. Another wound. Now this is an interesting case because the patient was advised amputation straight away. When he went to the OPD of one or two colleagues, they just said, oh, we just go for amputation, we cannot save it. But luckily, patient had both the vessels, the peripheral vessels, that is posterior tibial and dorsal spade is palpable. We took a chance. We knew it, we can save this limb. It took a lot of time. We went for aggressive debridement. And after that, that is the result which you can see on the screen.
Dr. Kamal, you'll have to restrict the time.
Yeah, sir, I think I'm almost over. Necrotizing fasciitis has already been discussed. And take-home message is try to prevent amputation whenever possible. Follow time principle for wound bed preparation. Follow whenever you think, don't follow any ointment which your colleagues are following. Just take 3-4 ointments, see which is the best for you, and always work as a team. You have to involve a physician, you are a surgeon, sometimes you have to involve a plastic surgeon or orthopedic surgeon. So work as a team. And this is what I personally feel, that when we have less knowledge, the confidence is very high. But as we keep on learning, our confidence keeps on decreasing. So more you know, less confident you are likely to. Thank you very much. And this is what I always believe in. The most dangerous phrase is, we have always done it this way. Thank you very much.
Thank you, Dr. Kamal Gupta. That was a very lucid presentation. I currently do not see any questions in the question answer box. But from my side, if there is time, I'd like to ask you one question.
Yeah, sure, sir. Please go ahead.
Knowing your passion for lasers and proctology, could you just speak a little on your experience of lasers in wound management?
Yes, sir. We use a lot of lasers that actually in wound management. That is triple LT laser. The difference is that in proctology, I use 1470 nanometer wavelength, and triple LT is low level laser therapy. Now that is 905 wavelength. And so far so good. We have got very good results with triple LT laser, but because it was not a part of time management, time principle, that is the reason I did not touch this topic.
Okay, thank you very much, Dr. Gupta.
Thank you, sir. Thank you very much.
I would like to introduce the next speaker, Dr. Krishna Prasad K. He comes from the pharmacological background, and he's a general manager at Medical Services Department in India. He's handling the scientific affairs, medical governance, compliance, business development, pharmacovigilance, clinical and transitional research, and has 65 plus publications, oral papers in international and national conferences. Over to you, Dr. KP Prasad.
Yeah, a very good afternoon, ladies and gentlemen, and dear colleagues. I'd like to share the screen to start the proceedings. Can I do that?
You may share the screen. You can share your screen, sir.
Yeah, I hope the screen is on. I think it's on, right? I mean, the screen and the audio is on, right?
Yes, sir. Yes, sir. You may continue.
Okay, fine. Yeah. First of all, thanks for this kind invite, and I was probably quite enamored by the preceding session and lecture. Also, looking at the pragmatic and realistic approach that we usually going to be looking towards, and that is probably looking towards diabetic foot ulcer and chronic wounds. And I think my topic is also somewhat related to the similar kind. And when we speak about pain and central sensitization, the first thing which comes to our mind is obviously chronic pain. And the implications and complications of undertreated or untreated pain in such a setting is probably otherwise fathomable for that to be further discussed or maybe further elaborated in this session once again. So I'm going to be speaking about the central sensitization and pain, what we want to call it as pain and central sensitization. And I try to understand the fact that how is this really relevant in our current context when we know the fact that very times it is this central sensitization which is probably responsible for the transition of simple innocuous acute pain into chronic settings, which probably has a different tangent in terms of having a limitation on the commonly encountered strategies of pain relievers to be used on a chronic basis. So while we're going to be speaking about central sensitization in few details in the forthcoming slides, this is my disclosure, and as rightly highlighted, I think I have an bent towards translational research, which is probably looking towards evolving personalized, standardized, and maybe otherwise even customized approach for each of our case, because we all understand the fact that yes, if we are looking towards a standard of care to be incorporated and imbibed for each and every case, I think it is going to be quite rudimentary to understand. It may not be successful in any of these cases. So what makes central sensitization such an important concept? I think that is what is going to be highlighted in this outline of the presentation, which speaks about the significance, if not for the role of sensitization in transitioning this state into chronicity. And before we could have a word from the guidelines itself, that how probably we are looking towards a step ladder approach for probably looking towards mitigating the risk associated with chronic pain and central sensitization. But I think the purist would say the fact that yes, pain is something which is protective, it is pleasurable, but in case it is persistent, then we do understand the fact that yes, we would require intervention to make it less progressive and probably otherwise more manageable. And the purist will also say the fact that yes, it is the pain which is as defined by the International Association of Society of Pain, to say the fact that yes, in case the pain is noxious and it is associated with unpleasant sensory and emotional experience, the moment it becomes damaging, and that is the time that we probably would like to intervene. But our submission is the fact that why do we want to wait for such a long time? Why can't we preempt it? And probably we should be proactive in understanding the underlying pathophysiological defects and probably understand that the physiology is directed towards delineating the mechanisms of central sensitization, which will probably avoid the complications of undertreated or untreated pain in such settings. So what are those painful settings which probably lead to central sensitization and lead to chronicity? Gone are the days when we used to say the fact that yes, it is a chronic arthritis pain, which is probably going to be leading to central sensitization, and probably we would require obvious differential strategies. But the fact of the matter is the fact that if the boat has already sunk, what is the harm or what is the additional benefit which is going to be incorporated by unearthing this mechanism of central sensitization and preventing that? So if we do look at the other scoping indications, and which is in the form of 14, 15, and probably 10% of post-traumatic, post-surgical pain, we do understand that almost 40 to 45% of these pain settings are likely to be landing up with severe, if not severe, but probably otherwise landing up with central sensitization, which is a common cause for recurrence and probably an important reason for readmission for the patient to be looking towards newer avenues for therapy, which are again limited by the dose and the duration of therapy. So if you look at the significance of untreated and uncontrolled central sensitization as a common denominator for uncontrolled pain, it is sufficing to say the fact that yes, it has a dramatic impact on your individual productivity, if not societal standing, for you to contribute towards your daily affairs. And if we look at the probable reasons for central sensitization, yes, if it is not because of post-traumatic settings, very many times it is understandable that post-operative or maybe those post-surgical pain is one of the important reasons for important elaboration and initiation of this pain settings, which is understood to be arising because of central sensitization. So it goes without saying to understand the fact that yes, almost every other case of surgery, which is probably landing up with a post-surgical setting, is going to be a case of post-surgical pain, which is of severe intensity, which would warrant the appropriate line of therapy, which has been adopted and suggested by WHO. But when we look at the probable pragmatic reality and probably the approach in the real world settings, we do find the fact that almost 50% of these cases who are supposed to be managed still try to develop chronic pain. And it is this chronic pain which is an important area of further research with new interventions to be elaborated in the next few slides. But when we speak about these new approaches, the point is, why can't we prevent it? If we want to treat it, again, we said the fact that yes, it is going to be limited by the dose and the duration, and if not anything else, the choice of therapy, which is again going to be associated with significance of dependence or maybe there's abuse potential. So it is in this line, we probably would try to understand the fact that yes, if you are looking towards the rightful approach of preempting post-surgical pain, which should not be landing up at central sensitization, I think preventive approach is probably the most important strategy to look at this progression to be prevented. I think the slides are stuck.
Is Dr. Krishna Prasad voice and signal not there?
I think the slides have got stuck. I'll just try to log in once again. Yeah, I think it's back. Yeah, so we do look towards chronic pain setting in almost half of these cases, which are probably undertreated or maybe inappropriately treated at the outset. And probably even if they are treated, the chances of patient landing up with coming up with poor patient compliance and non-adherence for the completion of the treatment course often is an important reason for the patient to be coming up with recurrent flare-ups, if not for readmissions in the hospital setting once again. So how do we preempt this scenario of undertreated or maybe inappropriately treated pain, which probably leads to chronicity, which is probably manifested by the symptom states of hyperalgesia, maybe otherwise even allodynia. So when we look at the pain physiology, which was wonderfully highlighted at the outset by Descriptus in 1644, it probably suffices to say the fact that the painful stimulus, which was arising because of high intensity stimulus, which is probably in this case fire, is not just the intensity of the stimulus, but probably it is also related to some physiological changes which are happening at the level of the spinal cord, wherein the gate theory probably becomes overwhelmed by the intense flux of the neurochemical or neurochemistry of neurotransmitters, which will probably lead to a central sensitization, landing up with a strategy to prevent this phenomenon, if not for treat. Because mind you, if we do have a protective mechanism of removing our leg from the painful stimulus, then probably it is sufficing to be adopting such a prophylactic strategy. But mind you, in case of post-surgical settings, the pain itself is so severe that the neurochemical flux is probably triggering an important mechanism of central sensitization, which may not be available with the simplified treatment strategies, which we would try to adopt even at the time of the discharge of the cases. So that comes to the point about understanding the fact that, yes, what is central sensitization? In simple terms, it's nothing but an amplification of a noxious stimulus, which would happen at the dorsal horn of the spinal cord. And it probably arises because of intense neurochemical flux, which probably leads to transduction, conduction, and transmission of the painful impulse, and then gets transmitted through the spinothalamic tract to the somatosensory cortex for the pain to be perceived before it gets probably damped by the protective descending pain pathways for us to be endowed with the protective reflex of moving away from the painful stimulus. But in case the stimulus is very intense, as in the case of nociceptive pain, otherwise even nociceptive with a neuropathic component, that is what we call it as mixed in real world settings, it probably triggers a progressive yet relevant changes in the neuronal circuitry of the central nervous system, that is in the spinal cord and also in the central nervous system, for us to come across with this important system of central sensitization, which is characterized by important dysfunction of the ascending and the descending pain pathways. So gone are the days when we used to say the fact that, yes, the peripheral nidus or the peripheral stimulus leading to the generation of the peripheral neurotransmitters, that is prostaglandins and substance P, could be mitigating the risk of central sensitization. We do understand the importance of the ascending and the descending pathways for them to contribute towards important flare-up of the central sensitization, which is happening at the dorsal horn of the spinal cord. So what are the changes which happen at the spinal level? We all know the fact that, yes, depending upon the intensity of the stimulus, which is of mixed, if not of just simple nociceptive, there is a transition from the neurotransmitter circuitry from substance P to glutamate. And it is this change in the guard of the gate which probably intensifies the recruitment also of additional pain fibers, which we call it as the big fibers, that is A beta, as well as the C fibers, which will probably contribute to the simple innocuous rose petal touching the face itself, turning itself into a painful stimulus for us to be complaining about allodynia, if not about hyperalgesia, which is nothing but an hyperreaction to a simple stimulus on the cheek. So this, complications of hyperalgesia or allodynia are probably otherwise in some way or the other, sometimes controlled by the descending pain pathways, which are probably again getting damped by the relative deficiency of norepinephrine in comparison to serotonin, which probably gives rise to an important equation that, yes, as the norepinephrine level goes down, it is the level of glutamate which goes up, and it is this glutamate transmitters are probably antagonists, that is NMDA antagonists, which were also playing a pivotal role in post-operative analgesia to be further beefed up. So whether we call it as ketamines or whether we call it as dextropropoxiphanes, they have their own limitations. And the silver lining is the fact that what if we do have a single agent which will take care of the peripheral neurotransmitter flux, probably an agent which will take care of the glutamate hyperstimulation, and probably otherwise an agent which will also take care of the descending pain pathways through the norepinephrine reuptake, so that we could have one single outlet for controlling central sensitization, not from the point of control, but probably more importantly, preventing, because right from day one of control of central sensitization, we should be in a position to prevent hyperalgesia, allodynia, and spontaneous pain. So I won't go into the details, but to suffice to say the fact that yes, peripheral nociception is very many times related to nociception, but in case this nociceptive pain is also accompanied by nerve damage, that is neuropathic. In case of mixed, we do understand that in very many cases, it will lead to central sensitization, which has very many phases, but little treatment strategies, because we understand the fact that yes, NSAIDs probably take care of the peripheral sensitization, but not to take care of the central sensitization, which is happening at the level of the spinal, or maybe otherwise even at the brain. So we do understand the fact that yes, alpha-2 delta ligands have been looked upon. It is the COX-3 mechanism of acetaminophen, which is considered to be central, but probably it is only a few opioids which are probably fitting the bill to treat and control central sensitization, both at the spinal and at the central level. So does the guidelines, that is WHO Compare Rescue, probably they are considered a standard of care for having a step-ladder approach to be adopted for the intensity of pain to be controlled. But mind you, my friends and colleagues, in real world settings, we would agree the fact that yes, they are probably sparsely, descriptive about the control and probably otherwise the preventive strategy of central sensitization, which is so dominant in post-traumatic, post-surgical, otherwise neuropathic pain settings. So probably it is time to understand the fact that yes, these very many phases of central sensitization that we call it and that we are knowing about probably require a refined approach with a single agent which will act at all the levels so that there is better control in terms of preventive strategy, so that the manifestations of chronicity or maybe otherwise hyperalgesia or allodynia are much prevented for the patient to comply with the dose and the duration of therapy. And in this line, the researchers would probably say that yes, why not combine 2 or more drugs with complementary actions so that we could be in a better position to control central sensitization. But mind you, even centrally acting analgesics or so-called acetaminophen are still controlling only part of the storyline. They are either related to the COX-3 inhibition or probably otherwise having a more stronger inhibition of the serotonin pathway, and probably they are still a weaker mechanistic reasoning for them to be playing an important central role in the control of central sensitization, even at the competition. And the most important incremental side of this topic is to understand the fact that if you want to control central sensitization, is it on day 4 or day 7 when the patient is going to come back, or is it on day 1 itself when the patient is likely to be having repeated circular changes in the spinal cord, which is related to epigenetic changes, which has to be controlled on day 1 itself. So that's why our oral strategy or injectable strategy would require a steady state concentration levels to be achieved, as in the language of a pharmacologist or clinical pharmacologist. And that is where we would understand the fact that a novel route of delivery, which is kind of a nasal delivery system, would be an obvious alternative as an answer to be suggested in such cases, that why wait for 4 days of the steady state concentrations to be stabilized and achieved, and why not adopt internationally, globally, renowned approach, and that is the intranasal delivery system. So some of these nasal delivery systems are already available, and the tapentadol nasal spray is probably reaching in the pulse dosages, or maybe what we call it as a micro dosages, the central sites where the pain is supposed to be perceived within minutes, and that is within the 6th minute. And probably this is being achieved on day 1 itself without the requirement of achieving a steady state concentration. So probably the advantages of nasal delivery system are much more heightened for this painful settings of central sensitization, some of which you have already enumerated. And it suffices to say the fact that yes, if not for a sustained release formulation, the nasal concha itself offers an area of absorption which is as large as 160 square centimeter for that part of the drug to be passively absorbed into the systemic circulation. It was also absorbed on the nerves for that component of the drug to directly reach the central areas in the central nervous system for the drug to be effective within the 6th minute. So yes, it would obviously also bypass the GI tract, and that's why the GI adverse events also could be circumvented by this novel delivery system of the opioids.
Dr. Krishna Prasad, your time is up, please.
So with that, I would probably come to the summarizing line to say the fact that yes, we as a clinicians do try to treat and offer a customized and individualized approach to the pain which is being exhibited or manifested by the patient in our clinical chambers. But I think it's also time to revisit the pain strategies, not by the book, but probably by our clinical state that the patient comes up with, and probably do away with the classical strategies, but probably adopt successful strategies which will directly deliver the drug to the central areas to offer not only good, robust effectiveness and safety profile, but also offer immediate control of central sensitization within quick time for us to prevent the complications or damaging effects of this clinical pathophysiological defect. So if you have any reservations about this mechanism and the strategy of control, then probably we would be possibly facing the ire of the patient at our clinical chambers, because we would probably be subjected to the adage to say the fact that yes, sometimes following the practice by the book probably would land us up in probably one or probably two of these cases landing up with chronic pain, maybe otherwise with complicated states, which will probably otherwise be much scarring our own practice profiles. So with that, I would like to thank you all for the attention, and I would be happy to take the questions if there are any. Thank you.
Thank you, Dr. Krishna Prasad. I see that there are no questions in the chat box. We'd like to go to the next speaker, that is Dr. Amrish Baliar Singh. I'd like to thank Dr. Krishna Prasad for an extremely relevant and nice presentation. And I'd like to invite Dr. Yeah, Dr. Baliar Singh, you can carry on.
Yes. এটা দেখলো কোটা এটা মোর হইতো না ତାଙ୍କର ସେମାନେ କାଇଁ ସେର ଗଲାବେଳକୁ ଆସୁନି କାହିଁକି ସେମାନଙ୍କର ରିସର୍ଚ ଆସୁଛି ମୋଟା ଏଇଟା କୋଉଠି ହଉଥିଲା
go to files
କୋଉଠି
Dr. Baliar Singh, unmute yourself.
Yes, sir. Actually, I'm trying to.
I think it's this time.
Didn't you send your presentation to Swapnil? If you have said
Yes.
Swapnil, you can share.
No, actually, no. What happens is, it is the organizer's screen is same. It doesn't show my screen. One second. Anyway, it is with Swapnil. He can play it also there. No issues.
I think Swapnil, you can play it.
No.
Install
No, set up a phone on your laptop. No?
Swapnil, do you have Dr. Baliar Singh's presentation loaded?
Amrish, take help of your daughter.
Yeah. Sir, just a second.
Beta, come forward and help your dad. He won't be able to do it.
Yes. That is there, but now you have to go to your presentation. Okay, they are seeing your screen now. Yes.
You all can see me now?
Yes, very much. Congratulations.
Thank you very much. And I thank you for inviting me to share this lecture, which is very dear to me. And by now you have spoken about all the things about diabetic food. And I am the only last person left. At least we will try to salvage whatever is possible. As you know that foot is a terminal part of the leg of a vertebrate animal. And foot supports body weight, provide balance, do shock observation and many things. But most important is it balances the body and helps in walking and locomotion. So how it functions? It has a complex anatomy. As you can know, with specialized tissues, it has 26 bones with 33 joints and more than 100 muscles and tendons. They are the parts of the foot. And you know, dorsum of the foot is thin, pliable and mobile. And sole of the skin is glabrous, non-pliable and thick and durable. It provides stability. And it has multiple components, but most important for this is the maintaining the arches of the foot, which is important for walking or maintaining balance. And also there are many structures, but muscles which are important for this presentation are the muscles. They are in the first layer are abductor hallucis, flexor digitorum brevis, and abductor digiti minimi, which are in the first layer. They can be used for as flap for the resurfacing part of the wound of the sole. And also on the dorsal musculature is extensor digitorum brevis, which is used for covering ankle or lateral side of the ankle. Now coming to arterial supply, we have to follow this angiosome concept. What angiosome concept says is that particular area is supplied by a particular artery. So if there is something happens that entire area gets affected, you can see that dorsum of the foot is affected by the dorsalis pedis artery angiosomes, and heel, posterior heel is supplied by the calcaneal branch and is supplied by the peroneal arteries angiosomes. Now, foot is supplied by numerous blood vessels through all the 3 blood vessels of the leg. But in addition to this, there is also a plexus around the knee joint, which also join the blood vessels to provide circulation to the foot in case there is some problem to any of the blood vessels. And same thing also happens around the ankle. All the blood vessels in this area are intermingled to provide supply through one or the other arteries. So this concept is also good for doing reconstruction. Diabetic, is a major health problem. At least 25% of the diabetic, they develop ulceration, and a major amputation is occurring every 20 seconds. Though amputations are not inevitable, limb salvage can be achieved. Now coming to diabetes mellitus, so what happens is it leads to peripheral neuropathy that will lead to small muscle wasting and also foot deformities. At the same time also, the lack of sensation also will increase plantar pressures, and that will take to the foot at risk. And again also with peripheral arterial disease also, because of lack of supply or to maintain the functions, that also will take the foot at risk of ulceration or injury. And also autonomic neuropathy, because that will lead to decreased sweating and arterial altered blood flow. What happens is there is arteriovenous malformation occurring below near the skin, so the skin will look dry and distended. Will have distended foot veins, and also that will lead to callus formation, and which lead to plantar pressures and again ulceration. Because one of the 3, actually either peripheral neuropathy and peripheral artery disease, they are the cause most of the problem because of trauma, maybe because of the callus, or maybe because of the paronychia or shoe bite, or maybe simple injury can lead, or over a long time can cause tissue necrosis and lead to bigger ulcers. when you try for diabetic foot reconstruction, basically you are trying to salvage whatever can be salvaged, or put whatever the damage is going to occur, put the damage to the minimum. So first thing is medical, whatever the condition, because these patients will have, in addition to diabetes, they will have maybe chronic renal disease, heart disease, or infection, or other medical conditions which need to be treated and also adequately taken care of. Naturally, next is the evaluation of the foot also, and the general condition of the patient, and peripheral vascular status, that is what is the vascularity of the foot, and also the bone pathology, and also wound depth, location, and duration, all need to be taken care of, and also to find out whether there is osteomyelitis or not. And most important is to find out whether patient is motivated for reconstruction or not. And also you have to think considering wound debridement and also other related surgical procedure what may be needed to salvage the foot. Vascular pathology is an important aspect. If the patient has ischemic pain or a non-healing ulcer, naturally vascular surgery consultation should be taken if the patient is symptomatic. And also there is neuropathic ulcer will require debridement also of non-viable infected tissues, and also local care of the wound, and also offloading. If there is no improvement, then aggressive wound care, foot salvage procedure have to be considered. And when there is wound healing is stalled because of all standard care, such as offloading, infection control, edema control, etc., then you can try for hyperbaric oxygen therapy, cell therapy, then growth factors, and negative pressure wound therapy. These are actually they are adjuvant to improve the condition of the wound, which can be useful to arrest the deterioration of the damaged foot. And one of the most important factors is, it's already been spoken, that removal of the biofilm. It requires either surgical debridement and also some therapy like frontosan. There are many other solutions which can also be used, which can avoid biofilm formation and will allow healing of the wound at the earliest. And also in some cases, you can use a negative pressure wound therapy for improving the wound condition. And also now there are many more synthetic wound dressing or many dressing materials available to take a better care of the wound, so that improvement in the wound condition occurs at the early. So there are many actually spectrum of care available, starting from medical condition like hyperbaric oxygen therapy can be given, negative pressure therapy also can be given. Then you can add growth factor for healing of the wound, gene therapy, cell therapy also has been tried. And also systemically you have to control the diabetes and other medical conditions. And also you have to take care of the wound by offloading or using advanced dressings or infection control. And also if there is ischemic foot, then you have to also augment the vascular supply. And naturally surgical option will require is skin grafting, flap reconstruction, or amputation at the appropriate level, maybe at a later date. Coming to evaluation history, and vascular evaluation is the most important factor. So, and also in addition to examining the pulse and the blood pressure at the ankle and the arm and toe pressures, you also can do Doppler studies. CT and MRI angio can also be done to assess the vascularity. And also we take care of, measure the oxygen saturation of the skin to demonstrate that there is good vascularization. And also sensory evaluation is extremely important, and compartment pressure in certain situations also will be useful, and gait analysis and bone assessment like also with X-ray and CT scan also need to be done. But most important, initial foot evaluation requires vascular and neuropathic orthopedic and infections control is extremely important to be done. And as I told you, multiple departments need to be involved simultaneously to improve the patient's foot condition. So in diabetes patient, also there could be calcified arteries, suggesting that there is peripheral vascular disease and poor circulation in the foot. And also lower limb angiogram can suggest there is actually the problem with the blood supply of the foot getting affected. If it is segmental block, then suitable angioplasty can be done. If it is long segment block, then vascular bypass can be done. Whatever reconstruction is attempted to improve the circulation, however, the treatment duration is going to be long for these patients with diabetic foot. And this is a picture shows the normal vessel, lumen, and also diabetic, calcified vessels. It shows that the changes in these blood vessels, they either block the lumen or they don't allow blood to transfer the nutrients, other factors for the healing of the wound. And also many times patients are also with varicose veins. This is often a neglected, actually nobody thinks that could be existing varicose veins. That also complicates the wound and takes a long time without healing. And also conditions like vasculitis, that also can cause ulcer in patients with diabetes. And because this requires immunosuppression and corticosteroids for treatment, that also will delay the duration of the treatment. Now coming to evaluate the perfusion of the foot, how can you ensure? Two dyes, natural fluorescein and the indocyanine grain has been extensively used. So you can see that the flap has been planned, and after raising, the distal part has been deauthorized to see the fluorescence. Fluorescence shows that is yellowish green fluorescence means it is vascularized. So this is checking the fluorescence under ultraviolet light, saying that flap is vascularized. This is after transfer, and this is the healed flap. So that part, at least vascularity can be ensured with this test. And also with indocyanine green, it is much safer than fluorescein. And the entire area shows good perfusion. That means vascularity is good and adequate treatment like debridement or any other procedure can be done for these patients. And coming to sensory evaluation, it is extremely important because at least the person should be able to perceive 10 gram weight, touch sensation. So to be to protect his foot, but majority of the patient or 90% of the patients, they can't feel this 10 gram weight also by which is measured by semis-western filament. That means many of the patients are with problem and they also can lead to ulceration later on, which need to be protected. And gait analysis definitely helps to know what are the pressure areas for offloading and also designing the footwear and also future care to prevent ulceration in the foot. And coming to physical examination, one will require vascular, neurologic, and dermatological evaluation, and also musculoskeletal, that is what are the muscles or soft tissue present, what are the bone condition also need to be evaluated, and radiograph, especially weight bearing radiograph will help diagnosing the condition of the arch of the foot, and CT MRI also will be needed if either to depict to identify infection or also the condition of the bone or osteomyelitis, and also what procedure to select. You have to consider the patient's expectations, actually what patients requires, and also you have to consider the degree of deformity, location of the deformity, and if you can reduce the deformity by some extent surgically. And also before giving any treatment, patient will require preoperative medical clearance, and also blood evaluation need to be done, and also whether to use tunica or not to use tunica, it depends on the vascular status. Sometimes the blood vessel, the vascularity of the limb is not good. In that case, it may not be a good idea to use tunica. And also fluoroscopy, as I had spoken before, that says to identify the vascularized tissues intraoperative period. And also in the protective period, wound need to be protected, and which by protecting offloading and physical therapy and also customized braces. This is a simple algorithm about limb salvage in diabetes. So if you say that after debridement, the vascular strategy is reliable and it is simple wound, may will end up with skin grafting or a local flap. Then you can start with the rehabilitation program. But if the vascular status is not good, then if no amputation is planned, then conservative care can be given, and it takes a very long time to heal also for some patient, not all. So then patient can go for rehabilitation. And if it is vascularity is good, but it is a complex wound, then we can think of successful soft tissue reconstruction, even bone reconstruction or nerve decompression. And if there is failure, it can end up in amputation. And there are definitely indications for amputation like systemic sepsis, major tissue loss, significant comorbid conditions, poor patient compliance, and the vascular, diabetic foot, which cannot be do any reconstruction because of severe damage. They will definitely end up in amputation. And one have to make a decision whether you are going for extended amputation at the appropriate level, so that it will result in early healing and rehabilitation with the prosthesis, or you are conservatively amputating, preserving part of the foot and then reconstructing the foot. But if you are planning to reconstruct, then the duration treatment is going to be more. That also need to be considered. Now, there are patients also in diabetes with renal failure and other comorbid conditions. But in those cases, if there is adequate blood supply, then reconstruction also can be planned. But however, diabetes with peripheral vascular disease may not be a good situation to treat. And majority of the patient, they will start having peripheral vascular disease with calcified vessels, and also blood vessels may not be available also for reconstruction for doing a free flap or any other procedure. And as I had told you before, if there is a segmental loss, then you can go for bypass procedure, or if there is a few small segmental blocks, then one can go for angioplasty. But whatever is done, if you are trying to improve circulation and salvage the foot, treatment period is going to be long. This also need to be explained to the patient. And this was balloon angioplasty done, the procedure. And this is angioplasty, that is stenting. And also these are the various bypass procedures which can be done to improve vascularity of the leg and the foot. Now coming to the how to operate and when to operate and how to operate also. See, this looks like a small, good looking wound, but a small flap was done to improve the close the wound. However, wound margins necrosed and there was dehiscence of the wound leading to breakdown. But if you notice that the dorsalis pedis artery was blocked, and this flap is based on the blood supply of the dorsalis pedis. So naturally, vascular assessment in diabetic foot problem patients are very much essential. And naturally, you have to, when you are planning for soft tissue reconstruction, you have to consider the underlying cause, and also underlying bone architecture also need to be considered, and also about the weight, how the weight transmission can happen. That also is important, and it may lead to require bone resection, osteotomy, or other procedure may be necessary. And also, one should attempt to provide a protective sensation, but which sometimes the chances are very big. Many classifications has been devised, starting from grade 1 to the ulcerative lesion to grade 5 with most extensive gangrene. And also people have tried to provide a visual chart to show the type of the wound, so that it is for recording and also treating. However, we find that if the wounds are defined in a very simple manner, it is much better. So simple wounds are like simple ulceration, but there is underlying structures are not exposed. And in the complex wound, underlying structures are exposed but not destroyed. And in the complicated wound, the exposed and destroyed structures are with deep infection. But wound excision would result in a functional foot. And sometimes unreconstructable foot, because the destruction is so much that excision would not leave a functional foot. So accordingly, you have to decide what type of therapy one can do. Coming to some of the ankle and foot, if there are simple wound, naturally it will be with skin grafting can be done. And if there is small area of exposure, it can be treated with abductor hallucis or abductor rigidity mini muscle flap, or even extensor digitorum brevis muscle flap. Sural neurocutaneous or lateral supramalleolar flap also can be attempted. You can see that extensor digitorum muscle on the dorsum of the foot can cover the ankle and also the lateral and medial side of the ankle to provide cover. And also lateral supramalleolar flap from the lateral surface of the leg can be used for the ankle and also for the posterior heel, and also for the proximal dorsum of the wound can be also used. And however, larger defect over the dorsum will require free flap. This patient has been treated with anterolateral thigh flap. Now coming to plantar forefoot, if there are small ulcers or the toes are not doing good, one can use a toe fillet flap.
Dr. Balyan Singh, your time is up. You have to hurry up.
Yeah, fine. And then coming to midfoot, either you can try for double rotation flap from the local skin, or you can plan for a GUI advancement, and also you can do a small gracilis flap for the small foot defect. And for the plantar hindfoot, you can do either medial plantar flap or a abductor hallucis muscle flap, or you can do a lateral calcaneal flap. And you can see that this medial plantar flap has been used for the posterior heel, and also it can be used for the proximal sole of the foot also can be used. It's a medial sural flap covered for the medial malleolus area. And also one can use a flap with a perforator to the skin, design a flap to cover the lateral area of the leg, or middle side of the leg also can be used. And ALT free flap, of course, posterior heel and proximal sole defect also can be done. Exposed endoachilles, there are sometimes small defects can be treated with lateral arm flap. And there are chimeric flap also, with flaps with multiple skin, bone, muscle, which can be used for treating different multiple defects. This patient had defect over the dorsum and also plantar aspect. It is a latissimus dorsi muscle and skin flap, which was used to cover the dorsum and the plantar aspect of the foot, and also super microsurgery. Sometimes the small perforator also can be used, which can be borrowed from the adjacent territory. But however, the territorial blood vessels should be available for transferring a flap. This is actually dorsum of the foot was reconstructed with the first metatarsal artery perforator with a LT flap. And of course, sometimes foot salvage is essential after thorough debridement. We have done a latissimus dorsi muscle flap covered with skin graft. And this is another patient who was treated with skin graft because of multiple ulceration. We had to do a muscle flap for this patient. However, bony projection and pressure point will result in callosity. You have to use silicone insole or devices to avoid bony prominence, pressure over the bony prominences. And of course, sometimes if the morbid patient's condition is not good, you can have to debride and later do a skin grafting after VAC therapy. And this is the renal failure patient with comorbid conditions. So we have done amputation, and again debridement was done. Then after negative pressure wound therapy, skin grafting was done. And many times in morbid conditions patients, you can do for integradermal regeneration template. If the vascularity of the area is good, one can use that and use skin grafting. And also now coming to the conclusion, systemic illness should be adequately controlled and treated, and reconstruction of the diabetic foot is possible. Staged approach with aggressive excision of the devastated tissue is extremely important, and also you have to reconstruct with the autologous tissue, and multidisciplinary approach will help preserving the foot, and ancillary modalities like negative pressure wound therapy, advanced dressing material, hyperbaric oxygen therapy, growth factor, gene therapy can be used to advantage in a certain situation with food preservation. Thank you very much.
Thank you, Dr. Balyas.
Thank you, Dr.
Thank
Amari.
you.
I think we'll take the questions in the chat box. I thank
Milind,
the chairperson.
We didn't move to the
Milind,
next
you're not
session. We
audible.
are quite late.
We are moving to the next session.
You're not audible, Milind.
We are moving to the next session. I would like to thank Dr. Sunil Singhal and Dr. Ashwini Wagh, who are our chairperson, and for excellent lectures by Dr. Kamal Gupta and Krishna Prasad Gurukunda. And also Dr. Amresh, who just spoke. We move on to the session 7 of this symposium, which is on pressure source, which is also an important topic. And we have for chairing this session, Dr. Samir Rege, our own Samir Rege from KEM Hospital, St. GS Medical College, who is a professor in surgery, Honorary Secretary in Maharashtra State Chapter, ASI, Executive Committee member of AMASI, and Executive Committee member of Hernia Society of India. We also have a senior surgeon from Chembur, Dr. Debashish Das, who is a special interest in abdominal GI surgeries, consultant laparoscopic and general surgeon in Asian Cancers Institute, and faculty at Ethicon Institute of Surgical Education in Mumbai. I hand over the proceedings to the chairperson, Dr. Samir and Dr. Das.
Good evening, everybody. I request this topic is often a very neglected topic. Most of the time, when we have pressure source, we often leave it to our paramedical staff to manage it, which is absolutely disgraceful for us, because managing this pressure source is one of the most important things for the comfort of the patient. I request Dr. Samir Rege to introduce our first speaker in this symposium.
Yeah, I take an opportunity to introduce Dr. Viraj Tambekar, who has done plastic surgery from my own institute, a prolific plastic surgeon on board of committee members of various international and national societies, not only in private practice, but he's a good academician or reviewer on the reviewer board of Indian Journal of Plastic Surgery, and also a faculty of our DNB, the surgery at Bombay Hospital. Keen interest in organizing multiple national conferences, and he's going to speak on clinico-pathological evaluation for pressure source. So I request Dr. Viraj to share his screen and start the presentation, please. I would request him to be on time so that we are already behind schedule. So let us finish in 15 minutes, please. Thank you.
Good afternoon, everybody. I'm trying to share my screen, and while that happens, may I just thank the organizers of this conference.
Yeah, a bit louder.
Yeah, I thank everybody. I'm just trying to share my screen, so just give me a second. I don't know why it's not sharing.
Your screen is shared. You need to click on the PowerPoint. We can see your screen.
All right.
Yeah.
Okay, there we go.
Yeah, you can start the slide.
Okay, cool. Thank you very much, Chairpersons Dr. Rege and Dr. Das, for your kind introduction. And thank you very much for the office bearers of the Mumbai Surgical Society for inviting me to take this talk. And since we're running late, I will start right away. I have absolutely no conflict of interest. And I must thank Dr. Harsh Shah, who's our final year resident, for helping me make this presentation. All diagrams and pictures that you see here have been taken from standard textbooks. The synonyms for pressure sores are bed sores, pressure ulcers, or decubitus ulcers, or it's just called a sore sometimes. But it has been defined by the National Pressure Ulcer Advisory Panel in 2007, which is an American-based advisory board, as a pressure ulcer is a localized injury to the subcutaneous and or underlying tissue, usually over a bony prominence as a result of pressure in combination with shear and or friction. And I will run through this, and I'll tell you what shear and friction can also do to, why my slides are not moving.
Yeah, so click on the presentation, it will move.
Okay. All right. Okay. So before we go ahead, let's just look at what causes this problem. And since I've been asked to speak on the clinical evaluation and the clinical pathology, this is where we'll start. So there are three primary things that cause the whole problem. The problem is essentially due to pressure, a shear force, and friction. Most commonly, because these occur due to pressure, people think it's only pressure that is the causative factor, but shear and friction are very often not looked upon. Apart from this, there are associated comorbid factors that are also a part of the story of why these things occur. Part of that is immobility, either due to injuries, spinal injuries, or various other situations wherein a patient is not able to move around. Malnutrition, of course, old age, which there's dry skin in old age, etc., which contributes to this. There is incontinence, excessive moisture, a poor mental status where a person is not able to turn around from side to side or doesn't manage their hygiene very well. And then, of course, chronic medical conditions that we're talking about. So this also needs to be evaluated when you see a patient from a clinical perspective. Now, what do you mean by pressure, and what are you looking for when you say, is there pressure on a particular area of the body? Typically, what has been noticed is that if you look at the spectrum of pressures coming from the bigger arteries to the smaller arteries, to the capillary systems, and the arterial portion of the capillary systems and the venous portions of the capillary system, we will realize that essentially any pressure that is more than 32 millimeters of mercury can actually cause a compression and a complete occlusion of the circulation in a particular area. So if this happens as a high pressure for a short period or a low pressure for a continuous period of time, it will create ischemia and thereby a pressure ulcer. This pressure also is proportional to the body weight of the patient. So obviously the heavier a patient, the more the problem. And it's inversely proportional to the area of contact, which is again very common sense sorts of a statement to understand. This is a pictorial diagram that depicts what is actually happening to the bodies and where pressure is being exerted maximally. So this is a supine patient, and you'll realize that the maximal pressure at 60 mmHg occurs in the presacral area. And this is where you find most pressure.
Viraj, you need to speak a bit loudly. You're not heard.
Okay, am I any better now? Is it any better
now?
This
much, minimum this much. Don't go below this.
Okay, fine. I'm just speaking a little louder then. This of course is when the patient is prone. So you can see that the patellar area is where there is maximal tension. This is when a patient is sitting down with their legs hanging, and you can see it exerts up to about 60 mm of mercury in the ischial tuberosity area. And when they are sitting with their legs supported, as in a wheelchair sometimes, you can see that it goes up to almost 100 mm of mercury, especially when the patient is tilted to one side. As you can see here, though there is a patient sitting on a wheelchair, there's a hammock-like situation created here, maximal pressure on one side. This pressure can go up to about 100 mm of mercury. Also, when the patient sits forward, doesn't have very strong muscles, they're sitting actually on a bony promontory here, which is sliding forward, creating a shear force, as is seen very clearly in this diagram. You don't realize it, but very, very often, even the sheet that we cover the patient with creates shear forces in these areas, leading to pressure sores. There are, of course, heel areas, the presacral areas, and the ischial tuberosity areas where these things happen. Now, when a patient is moved from side to side in a bed, there is also friction. So combination of these three are basically what is creating a problem, whereby the blood vessels are either getting compressed by direct pressure from above, they are getting pulled to one side, and therefore the lumen becomes thinner as it gets pulled to one side by a shear force, and a combination of the two where both happen. What is also important to understand is if a patient is sitting on a hard surface or lying down on a hard surface, this is the amount of pressure being exerted. But if this patient is on a compliant surface, something that will kind of float the body up, that pressure does get reduced. Now, this is something is important from an evaluation perspective. At some times we say, okay, the patient's on a waterbed or an air mattress, but if there is bottoming out happening and this surface is not appropriately filled to create this kind of compliance, without realizing we are giving rise to a lot of excessive pressure, and therefore it gets worse rather than gets better over a period in time for the patients. This is also seen in what we call as low air loss mattress, which are air mattresses typically which are fluted where air flows. However, even when patients are on these, we need to make sure of the points that I mentioned before, so that there is no bottoming out that takes place. These are even more advanced beds. They're called fluidized mattresses, where there are spheres inside, so that the pressure of the air is also not that much. It is the spheres that take over the portion of the pressure, but still apply a good amount of compliance. Now, having spoken of these three direct causes of why pressure sores occur, let's look at all these situations, which are the associated comorbid factors. These can also be called as risk factors to patients developing pressure sores, and this needs to be evaluated when we clinically see a patient so that it doesn't progress from where we are called in to see these patients. Impaired sensory perception, impaired physical mobility, and altered level of consciousness. All of these typically lead to an increased pressure for a prolonged period. Fecal and urinary incontinence leads to local moisture being high, and thereby the tissue gets damaged. Malnutrition, dehydration, excessive body. So these are all various things that we need to look at when we evaluate a patient, because all of these contribute to the formation of the ulcers. Now, the basic pathophysiology is very, very simple. As I've explained in the previous slides, it's essentially a lack of blood supply and poor hygienic conditions, creating a situation where ischemia causes tearing of vessels, lack of supply to the skin, and then the breakdown of skin, ischemic necrosis, and thereby an ulcer forming. The commonest sites of pressure ulcers are typically the presacral area, the tailbone area. It's because of the position of the patient in a bed, like a semi-Fowler's position or a slouching position in a bed or a chair. There is a higher risk of this developing in patients who are fed with tubes or who are incontinent. Heels are the second most common, usually in patients who are immobile or who have no sensation in their legs. And of course, patients who have got ischemic vascular disease. Other sites are the trochanter, especially for those patients who are lying on their sides. And here you will see that there are ulcers on the lateral side of the foot. There is a malleolar lesion, etc., than the heel itself. And of course, the ischium for those people who are sitting down more without proper support in a chair, a wheelchair, that is. Now, there are other areas from where patients can get these pressure sores. And sometimes we feel that, we are helping the patients by giving them certain kinds of boots or supportive casts, etc. But these also, if not done properly and the minor things not looked at, can create pressure sores where an excessive amount of pressure takes place. A simple thing like an anti-embolism stocking, we wonder what goes on, but if it rolls or it compresses or it kind of crumples as it's being rolled up on the patient's feet, legs, etc., can create excessive pressure at the area of the fold, creating pressure sores. So all of these things are also very, very important when we examine a patient clinically and evaluate him when we get referred a patient with a pressure sore. What are the warning signs of pressure sores? The warning signs are usually changes in the skin color or texture. There could be swelling in the area. Sometimes there is a frank wound and there is discharge from the wound. Sometimes you have an area of skin that can either feel cooler or warmer depending upon the kind of pathology that's taking place. If there is cellulitis in the local area over and above the pressure ulcer per se, you will feel that it is warmer. But if there is ischemia, and that's the major cause of the pressure ulcer, it might probably feel cooler. There are, of course, areas of tenderness, depending on whether there is sensation or not, or even severe pain. Now let's come to grading, because before we evaluate a patient and decide what to do and manage this patient, we need to grade the disease. And based on the grading, we can then take a call on what we need to do for our management, conservative, surgical, etc., etc. The two big panel bodies which have essentially come out with various guidelines are the European Pressure Ulcer Advisory and the National Pressure Ulcer Advisory, which is an American system. But there are others. There's a Yarkoni-Kirk and a Shear grading as well. But for a practical understanding, and of course, there are various risk assessment scales as well. The Norton scale, the Waterloo scale, the Braden scale, which is the most common scale that one looks at. And this basically gives you a score of 1, 2, 3, or 4, depending upon where you stand in terms of sensory perception, moisture, activity, mobility, nutrition, and friction and shear forces. And basically, if your score is 16 or less, as it's mentioned here, you are 16 or less, you're considered to be at a risk of developing pressure ulcers. And the lower the score, the more the risk of you developing pressure ulcers. But to keep it very simple, I think the National Pressure Ulcer Advisory Panel has come up with a very simple staging, which is a 4-stage staging depending on the tissues involved. There is a 5th stage, not by this particular panel, but something that we kind of incorporate because we really don't know what happens sometimes if the wound is not totally open, and I'll come to that in a bit. So these are the 4 typical stages of the National Pressure Ulcer Advisory Panel. One where only the epidermis is lost and the dermis is still intact. Dermis is lost, subacute tissue is lost, and muscles are lost on a bony prominence. Let's look at the first stage. Basically, you will find that there is intact skin, but there's non-blanchable erythema over a localized area of bony prominence. There may be some discoloration of skin, warmth, edema, and pain may also be present. It typically involves only the epidermal layer of skin. And this is typically what you would say is a person who's at risk, so to say, to develop a more severe ulcer. This is an example of the same. There's a little blistering that's taken place, but the epidermis is the only thing that's lifted off and not the dermis. So therefore, this is staged as grade 1. This is also grade 1, where there is just some areas of discoloration and signs of pressure. Stage 2 typically is a little more loss of the skin where the dermis is also involved. So there's a partial thickness loss of the dermis. It presents as a shallow open ulcer with a red-pink wound bed without slough usually. Now this means there is damage to epidermis and dermis both. And you could also have a blister and abrasion in this situation. These are some clinical pictures of the same. Another clinical picture of a grade 2 friction lesions. Stage 3 is a little more severe where the subcutaneous tissue is also involved, but bone, tendon, and muscle has not been exposed yet. So this is where you will see some fat in the wounds. Now here you don't see the fat in the wound per se because of the eschar on top, but if you remove this lying basically on a bony prominence and there's only being fat beneath, this is where fat will be exposed if you debride it. Another situation, this is due to one of those CPAP machine kind of things that a patient in an ICU for a long period. Full thickness is when everything is involved. You go down all the way to the bone. Now, these are some very severe ulcers, just clinical pictures for purposes of evaluation and documentation. Now, this is the 5th of the unstageable, in a sense, pressure ulcer that I was talking about. Now, this is a situation where you have this big, black, deep ulcer. There is a bony prominence beneath, but you don't really know what is involved because everything is intact and you can't see it. So in these situations, sometimes you need to resort to something like this, perhaps, where you need to resort to some amount of investigations to figure out what's happening. Just to quickly recap, when you look at a patient clinically who's been referred to you for a pressure ulcer, apart from what I just mentioned in terms of risk factors and the causes of it, you need to basically look and understand a comprehensive history as to why this has happened. Even small things like nursing care, etc., play a big role in understanding what's going on there. You need to assess the skin very, very carefully for any of these changes mentioned here. You need to examine the ulcer very carefully and figure out what's going on, and then assess, of course, these other situations, take a wound swab, and sometimes do further investigations to check whether or not the bone involved in this whole system is also affected. Because if the bone is affected and you're going to be chopping off a part of that bone, then whether it's just the bone alone or the joint which is adjacent to it or beneath it needs to be also evaluated properly. So this is all a part of the clinical evaluation, over and above the generalized morbid status, nutritional status, other comorbidities that the patient has. Here's just a quick depiction of bone scans done for a patient who's got severe sacral involvement and the osteomyelitis of the sacrum, very severe osteomyelitis of the sacrum. And this is something you can't see sometimes in a stage 5 because you just see a black color of skin on top. Now, these ulcers sometimes also have secondary complications like cellulitis or necrotizing fasciitis spreading along the layers beneath the skin because of the sepsis that they're creating. There can be bone and joint infections, like I mentioned. There could be fulminant sepsis based on what the clinical condition of the patient is. And of course, in very, very rare cases of maximal neglect, there could be some kind of a marginal ulcer-like picture where there could be malignancies in these eschars. Now, these are the references from where I've got the information that I've just narrated to you. But I think what's most important to understand in a clinico-pathological evaluation of these situations and a clinical evaluation of the patient, we need to make sure that we can prevent these situations because, like Dr. Das said, it's often neglected and is something which is horrendous and very, very morbid for a patient and unnecessarily expensive. So prevention would be the best cure, and the best way to do it is to inspect your skin each morning. When I say your skin, I mean the patient's skin each morning by the nursing staff, and a well-trained nursing staff can prevent a lot of problems for a patient. Thank you, ladies and gentlemen, for a patient listening.
Thank you, Dr. Viraj. It was a wonderful dissertation of the whole clinico-pathological situation. Our next speaker is Dr. Ranade. Dr. Shailesh Ranade is a plastic surgeon attached to Hinduja Hospital. And after having received the first rank in MCH from the Bombay University. He has been trained in Essex in plastic surgery and burns. Over to Dr. Sailesh Ranade, who will be speaking to us on conservative management of pressure sores.
Thank you, Dr. Das, for a nice introduction, and I thank the organizers at the outset for giving me this opportunity. So I take over from where Viraj stopped, basically. As we are aware, a pressure ulcer is a localized injury to the skin or underlying tissues, usually over a bony prominence as a result of unrelieved pressure. And as he said in his last slide, prevention is better than cure. So conservative management of pressure ulcers will be divided into first prevention of pressure sores. And if we cannot prevent it, then wherever in an established pressure ulceration, we will try and see how we can treat it conservatively. So in the prevention of pressure ulceration, what is requirement is assessment of risk factors. As again covered by Dr. Viraj, this is the excellent scale called Braden scale, which is commonly used. And it's very, very useful in determining which patients are more likely to get a pressure sore or a pressure ulceration. And it covers basically 6 points as it was explained: sensory perception, moisture, activity, mobility, nutrition, and friction and shear. And this is the chart, which is a very, very easy counting score, which we can assess for any patient which is likely to have a pressure sore, a patient which is bedridden. And the scoring system is from 4 to 1. And there are basically 6 factors. Only the 6th, or friction and shear factor, has got only 3 points. So the maximum score can be 23, where the lowest possible score can be 6. While the mild risk is for the patients who have got a score of 15 to 18. As the score goes down, the risk for developing pressure ulcerations is much higher, and patients with score of 9 or less are at very, very high risk of developing pressure ulcerations. So this is a risk scale, which again showing a color coding, and you can see between 6 and 12 are these patients which really require to be taken care of well by a nursing staff and the doctors, because we'll have to keep on looking at whether they are likely to develop pressure ulcerations. So here we have to intervene to do prevention. Mobilizing the patient out of bed can be the biggest and most effective intervention, but it is not always possible. So we have got 4 different ways of intervening to prevent pressure ulceration. One is repositioning of the patient, pressure reducing devices, diet assessment and correction, and a good skin care. There is no evidence to determine an optimum positioning schedule. On the right hand side, you can see a small diagram which shows a turning schedule for any patient. It is basically a 2-hourly schedule. As for bedridden patients, repositioning every 2 hourly is recommended. You can see on your right hand side, the right side, back and left side is, this is the way the patients are rotated every 2 hourly, and this chart is normally put in patient's room, and ideally nursing staff should tick mark whenever they're changing the position, so that we are very sure that the positions are changed in time. So when the doctor comes for the rounds, many times the chart otherwise remains on the wall unless there is a counter chart which is showing whether this chart was exactly followed. The head end of the bed should always be elevated not more than 30 degrees to prevent shear, as it was described by Dr. Viraj, while it is maintained to the lowest degree of elevation to prevent complications like aspiration. So we cannot make the bed flat completely, but as less as possible we elevate, it is better for the patient. So this is what we talk about low Fowler position. Normal Fowler position is between 45 to 60 degrees, while semi-Fowler position is between 30 to 45 degrees, while we are talking about 30 degrees or lesser. This is called low Fowler position, which does not cause much of the shearing force because patient does not slide down, and it's always better that in this position there are less chances of patient developing pressure ulcerations. There's a nice rule of 30, which is a good guideline for a bedridden patient to prevent ulcerations. As we have seen, the first point, the head of the bed should not be elevated more than 30 degrees. Similarly, the body is placed in a 30-degree laterally inclined position when we give a lateral position, and the hips are tilted as well as the shoulders at 30 degrees from the supine position. And we use pillows or wedges to keep this patient position without pressure or the hips and buttocks. So if we give this kind of position, as you can see in this picture, the hips and shoulders are rotated at 30 degrees, so they don't cause direct pressure on the trochanters as well as on the scapulae, which can be the bony prominences, which can cause pressure ulcerations. And these kind of wedges are very, very helpful in maintaining the position, because many a times what happens is the nurse or a doctor gives the position, and when he or she goes away, immediately the patient is back to supine position. So these kind of wages are very, very important in maintaining the position. Note the pillow in between the two legs, which prevent any friction between the two knees and don't cause any chances of ulceration. Active patients can reposition themselves by using a trapeze bar. This is a simple overlying bar. All nursing homes and private hospitals and public hospitals as well should have this bar. We generally lack this bar. We rarely see these kind of bars in our hospitals. These are very, very simple bars. They are overhead bars with a ring on the top where patient can hold. This ring height can be adjusted so that patient can hold herself or himself and easily change the position without having any assistance if the patients are conscious and having adequate energy to do so. For seated positions, the patient should be made to change the position every 15 minutes ideally if the patient is chair bound. If the patient is unable to reposition himself or herself, then every hourly at least the patient's position should be changed. As Dr. Viraj nicely showed, if the chair is on one side, then the pressure can be up to 100 millimeters of mercury, which can be extensive. In addition, use a pressure redistribution cushion, which will be a great help in such kind of patients where they cannot move themselves. This is the diagram of a pressure redistribution cushion, which is connected to a motor behind, and it keeps on changing the pressure in between so that the patient does not have pressure points developing even on a chair. Use of rubber donuts are not recommended as they don't really protect the pressure points, and thus they are out of practice now. Care of heels, as Dr. Viraj has explained, is the second most common place to get pressure ulcerations is heel, and which is often neglected. It's not commonly seen, it's on the back side. Normally we rotate the patient and only check the sacral area. This is a very simple heel protection device which can be used in all these bedridden patients who are likely to develop pressure ulcerations. If we cannot do that, we can have simple water-filled gloves which can be kept underneath the heels to protect the ulceration from heels getting ulcerated. I normally prefer, rather than keeping this 2 or 3 gloves filled with water, I prefer a cushion with 8 to 10 gloves put inside, and this cushion can be easily the pillow cover basically, which can protect and keep all these water-filled gloves inside as one piece, and then it is very easy for the patient even to move on that without having a chance of this toe or a heel slipping below. Pressure reducing devices have been observed to have a very good chance of reducing the pressure ulcerations as compared to the normal beds in the hospital. There are 2 types of pressure reducing devices, static and dynamic. The diagram shows on the left hand side the static pressure producing static bed which has fixed points where the pressure is generated all the time, and it is very difficult to stop this pressure from changing. While in the dynamic device, as you can see here, the pressure keeps on changing at multiple points, so there is a less chance that patient will develop pressure ulcerations with a dynamic device. So dynamic devices are always preferred as compared to the static devices. Commonly used static devices are foam mattresses, water mattresses, gel mattresses, air mattress overlays, while the foam wedges, which are also static devices which help in maintaining the position as I was discussing before. While the dynamic devices are many commercial motorized beds which are available, which keep on changing the air pressures in the system alternately so that the patient does not have one pressure point at a time. Despite proper risk assessment and preventing interventions, some pressure ulcers are unavoidable. So in such cases, we require to manage conservatively most of the ulcerations if they are detected earlier, and we can treat also these patients conservatively without need of a surgery. So as Viraj was describing, assessment of an established pressure ulcer involves complete medical evaluation of the patient, including knowledge about the comprehensive history, the risk factors, the comorbidities, treatment received in past, the psychological health, behavioral and cognitive status, social and financial resources, and availability and access to caregivers. This is very important. If you have got a appointed caregiver to the patient, he or she can do a lot of work with the patient in good quality nursing, and they definitely can have a better outcome. Clinical examination should note the number, location, and size of ulcers, presence of exudate, odor, sinus tracts, necrosis or discharge formation, tunneling, undermining, infection, healing, and wound margins. And this all should be noted in the file on day of admission, so that we have, as we progress further, we keep a record of what is exactly happening with these pressure ulcerations. And the surgeon should immediately stage these ulcerations into 4 different categories. As Dr. Viraj has explained, NPUAP is the most commonest staging which is used, and it is very, very simple to follow. Stage 1 to stage 4. Stage 5, we don't require to determine. So conservative management, the main aim is to plan to reverse the ulcer causing factors whenever possible. Whenever there is a chance that we find out a cause or a factor which is causing the ulceration, then we definitely can try and revert. Simple things like pressure stockings or simple like CPAP mask belts, which can be definitely taken over. Or many times there are endotracheal tubes tied over the ear lobules, can cause pressure ulcerations on the ear lobes. So this all can be easily prevented whenever we can take away these factors. Treatment and control of comorbidities include control of diabetes, which is very, very common with patients with multiple pressure ulcerations, and we require to take very good care of these patients. Pressure reducing devices and repositioning has to continue as it was in the preventive part. The skin care includes keeping a good skin hygiene and application of moisturizers on dry skin wherever indicated, while avoiding excess of moisture in the skin folds. In the skin folds, many times can retain moisture and can be predisposing to infection. So we have to be very careful in using moisturizers in the skin folds, in the axillae, in the groins, where there can be already a moisture there, and increased moisture can cause further ulcerations. We have to maintain the hemoglobin to 9 grams and protein sided to 3 grams. This is all variable. Many clinicians feel 10 grams is the right hemoglobin. Proteins of 3.8 of albumin is the good albumin. But this is all variable, and clinicians have their own goals. But normally it should be above 9 grams, and albumin should be above 3 grams to have a good quality healing. The nutrition evaluation and diet planning may be required, especially in malnourished patients, and high protein and caloric diet fed through the oral route is the best way to treat these patients. But every patient may not be able to do it, and in such cases we may require to have enteral feeds, or in some cases which are unconscious, we may even require parenteral nutrition. The aim is to keep the positive nitrogen balance with 30 to 35 calories per kg per day and 1.25 to 1.5 grams of proteins per kg per day. Vitamin C and zinc supplements are empirically given, but the data supporting their effectiveness is still lacking. So we still give vitamin C and zinc supplements, imagining that it will help in wound healing, but there is no data which helps to show that it is going to improve the wound healing in pressure ulcerations. Wound dressings form the integral part of the care of these pressure ulcerations, and doing a good wound dressing is an art. Right from removal of the previous dressing to finishing the dressing with a final tape, the surgeon should try and look at it or supervise it at least, so that, or there should be a trained assistant which may be doing this dressing, so that there are least possible complications of the dressing itself. Many times we find removal of micropore tape itself causes excoriation of the skin, and skin comes out and there's a peeling of the skin which still gets infected. So ulceration remains on one side and secondary complications easily occur. So we require to be very careful while doing these wound dressings. These wound dressings basically protect ulcer from trauma, contamination, and promote wound healing. They prevent maceration of skin by absorbing the exudate. They maintain moisture and prevent desiccation, which can hinder epithelial cell migration. And they control infection and facilitate wound bed preparation for definitive wound cover. So wound dressings are very important, and there are different types of dressings available. I will not go into much details because previous talks I was listening, and most of these points are already covered with various types of dressings. There are transparent film dressings, which can be used for stage 1 or 2 types of ulcerations, hydrogel dressings, alginate dressings. This has been covered just before in a diabetic foot talk. I've heard in detail, so I will not waste time on this. The foam dressings, hydrocolloid dressings, these are various types of dressings. And because there are various types of dressings available, it simply means that one classical dressing for a pressure sore at all stages is not available. So as per the surgeon's choice, as per the requirement, as per the exudate, as per the presence of infection, presence of debridement, we require to keep on changing the different dressing materials as and when needed, as per the surgeon's choice. Local antimicrobial agents like silver sulfadizine, framycetin, neosporin polymyxin B, chloromycetin are used by different clinicians as per their expertise and as per their experience. Systemic antibiotics are required in cases of invasive sepsis. But it's very important to remember that antibiotics should be considered as an adjuvant to debridement and not substitute for debridement. So if there's an infection there and there's a focus of sepsis there, we cannot just keep on giving IV antibiotics expecting that the infection will come under control automatically unless we take the source infection out. Negative pressure wound therapy is very, very useful in cavitating and discharging deep infected ulcers with exposed bones. It promotes granulation formation. With controlled uniform pressure, it draws the wound edges together, reducing the wound size. It removes infectious material and reduces bacterial load in tissues. It creates closed, moist atmosphere to promote wound healing. The supportive treatment includes self-retaining urinary catheters, rectal tubes, as they may be required to prevent repeated wound contamination in patients with incontinence. Physiotherapy and early mobilization are key to rapid healing of the pressure ulcerations. Psychological counseling and support is very, very important because these patients are bedridden and hospitalized for a very long time, and prevention of other complications is equally important. This is a chart which shows the basic management of this pressure source. So if there's a superficial ulceration, which is epithelializing with absence of slough, only moisturizing dressings will make the wound heal. If there is a sign of systemic or tissue infection, we require IV antibiotics. Deep ulcers with dead tissue and necrotic slough present, then we require debridement of these dressings. If the wound does not improve, then we require to have defined whether if it's a superficial slough, we can debride and do a skin grafting. If there's a heavy slough, then we require NPWT. And if there is a deep ulcer with exposed bone and muscle, we will require a flap cover. If with NPWT, the patient, it's not effective, we may still have to go for a flap cover. If it's effective, we can still manage with only skin grafts. Final aim is to make the wound heal. And after the wound heals, it's very important that we continue to have this therapy to prevent the further and protect the area so that there is no further pressure ulcerations. It's important to tell how I do it. So important points which I'm going to note is, one is meticulous history taking. We don't have to miss out on any points. Clinician has to exactly see what has exactly gone wrong and how many days this ulceration is occurring since. Eliminate the causative factors, control the comorbid conditions, encourage mobilization out of bed. Every day we should have a few words with the patient to try and encourage them, to try and tell them that if they can get out of the bed, all these ulcerations will heal very rapidly. Joint rounds with physiotherapist and dietitian is very important, because with physiotherapists we can have a perfect understanding of what is exactly lacking and why the patient is unable to move, or what can be done so that patient can be mobilized. And a dietitian has to take a daily diet recall and assessment. Many times the charts are prepared with X number of calories and proteins to go, but if there is no daily diet recall, we will not know exactly how many calories were received by the patient. So that is very, very important. Watch for the other sources of sepsis. These patients many times have urinary catheters, central lines, arterial lines. So we should also try and see that these factors are ruled out so the patient does not remain in sepsis for a long time. Vigilant daily clinical examination of the wound by the clinician is very, very important. Right from removal of the dressing, what is the kind of discharge, which is very, very important to be mentioned so that we can quickly correct the problems. Confirm adequate pressure in dynamic air beds. Many times these air beds don't have adequate pressure, and in many such cases we feel the patient is safe on the air bed and a dynamic bed, but the patient is having the bottom of the patient is touching the bed, and then in such cases the ulcerations may worsen, as told by Dr. Viraj. Watch for new pressure points, and strict repositioning regime has to be followed. Check for the color and quantity of the discharge. Watch for sub-discharge collections. If there is a sub-discharge collection, immediate surgical debridement is necessary. Watch for the change in the color of the discharge. Periodic tissue cultures are important to follow what kind of organisms they are in. Topical antimicrobial treatment is preferred as compared to IV antibiotics whenever possible, because patient has already taken a lot of antibiotics in such kind of situations. So try and avoid IV antibiotics if it's possible. Applications of dressings are to be done as per the requirement depending on amount of discharge and stage of healing. And daily bedside debridements, when indicated, have to be done under strict aseptic precautions. Protect surrounding skin from maceration, prevent wound contamination with urine and feces, and watch and note the progress by taking serial photographs. It's very, very important that we have clinical record of the clinical picture, so we are aware what is exactly happening with these wounds, whether improving or worsening. And the surgical management, of course, will be covered by my colleague in the next slide. There are newer modalities like growth factors, hyperbaric oxygen, skin substitute, and same cells, which are still under review and still not have been definitely useful for making the ulcer seal. In conclusion, vigilant monitoring and meticulous medical management can prevent, heal, and cure pressure ulcerations early, reducing the morbidity, need for surgery, hospital stay, and treatment costs significantly. I thank the organizers again for giving me this opportunity.
Thank you, Dr. Ranade, for an excellent lecture. Now you didn't tell about conservative management, also told us how to prevent these things by managing the pressure source. Two good lectures, etiology followed by conservative management. Here I invite my third speaker, who is a associate professor working in Department of Plastic Surgery at KM Hospital, who has done MCH plastic surgery from LTM Medical College. Not only he's in the public sector, but works for a private sector at Nirmiti Clinic and attached to various other institutes at Sushrut and Godrej Hospital. So over to you, Dr. Chandrasekhar Chalavade, for surgical management of pressure source.
Good evening, everyone. I am Dr. Chandrasekhar Chalwade. I would like to thank organizers of Woundcon 2021 for giving me this opportunity. I am going to talk on surgical management of pressure source with a focus on flap surgeries. Why should we do flap surgeries in such patients who have a lot of comorbidities? It has been proved conclusively, first by Lamon and Alexander and later by many other authors, that flap coverage for grade 3 and 4 pressure source is superior to conservative management. Not only they do reduce the healing time, but the long-term costs and recurrences are also reduced. However, conservative management is still mainstay for grade 1 and 2 pressure source. So what is the goal of flap surgery for pressure sore? The main goal is the primary healing of the pressure sore, which translates into improvement of patient hygiene and appearance, lowering of the treatment costs. It reduces the protein loss through the wound. It prevents secondary complications like osteomyelitis, sepsis, amyloidosis, renal failure, etc. Extensive preoperative optimization may be necessary before commencing the surgery. In terms of positioning, patient needs to be accustomed to new position. Spasticity needs to be relieved before surgery. General condition improvement measures in terms of nutritional status, skin care, comorbidity optimization, and wound care needs to be continued. Debridement of devitalized tissue is must. Sometimes it may be done as a single stage. Wound care method will depend on degree of infection, amount of slough present, extent of exudation, and money available. One method which deserves mention here is VAC therapy. It takes care of exudate and fills up the defect very nicely. Urinary and fecal contamination of sore should be prevented. It is usually done using catheterization, low residue diet, and perennial skin care. Some surgeons consider colostomy as an indication for patients who have pressure sore within 6 cm of the anal opening, while others prefer to decide on case-to-case basis. This is probably the most important slide of this presentation. These are the principles of reconstruction for pressure sore. The ulcer excision needs to be complete. Surrounding skin, involved bursa, and soft tissue needs to be excised. Involved bone needs to be excised and its surfaces needs to be smoothed out. Padding of bone stem and filling of the dead space needs to be done with a flap. Flap should be large enough. They should not violate the surrounding flap territories. The closure should be tension free. The suture line should be away from pressure areas if it is possible. The donor site can be grafted if tension free closure is not possible. Careful hemostasis and prolonged suction drainage is often necessary. First part of the surgery is excision of the ulcer. It is termed as a pseudotumor excision by some. A methylene blue soaked gauze is packed into the cavity and the ulcer is excised in toto with surrounding margin of healthy tissue. Any involved bursa or bone is removed. As far as bone management is concerned, any involved osteomyelitic bone is excised and any sharp edges are smoothed with a contouring burr. However, one needs to be careful with extent of ostectomy, as it is well known that ipsilateral ischectomy causes pressure source on the other side, while bilateral ischectomy will shift the pressure to the perineum and will cause perineal sore or urethral fistulas. Spasticity is usually relieved with physical therapy and serial casts. However, sometimes a Z-plasty of the shortened tendon is necessary Filling of the defect with flaps usually follow the hierarchy as secondary intention healing, then skin grafts, local or regional flaps, which form the mainstay of the treatment. Tissue expansion and free flaps are just to complete the list. They are done very rarely. As I have written here, avoid primary closure because they are very liable for breakdown. As far as factors important in decision making, the most important factor is patient's degree of mobility and the potential for mobility. If there is any chance of mobility returning, we should not use muscle flaps. Other factors include level of spinal cord injury, location of ulcer, if any previous surgery has been done, and whether patient is motivated enough or not. The patient motivation and education is very important factor as far as recurrence is concerned. Composition of flap can be fasciocutaneous, musculocutaneous, or muscle flaps with skin grafts. Most favor fasciocutaneous flaps as these do not violate the underlying muscle flaps to be raised later on. Muscle flaps are useful to eliminate dead space. These are some of the common designs I have shown in diagram: rotation flaps, advancement flaps, O to Z, O to S, or transposition flaps. Out of these, large VY advancement or rotation flaps are desirable as these can be elevated again if needed. Providing sensation has its own merits, and technically it is possible to elevate tensor fascia lata flap with a lateral cutaneous nerve of thigh and gluteal thigh flap with a posterior cutaneous nerve of thigh. If surrounding skin is sensed, we can expand the skin and transfer it to the defect so that the defect or pressure bearing areas will now possess sensate skin. In intercostal islanded flap can also be done. However, these are not often possible owing to patient's sensory level deficit. The choice of flaps by location is usually decided by the available options. For most local, regional, rotation or transposition or advancement flaps are the first option. For sacral and ischial, gluteus maximus based rotation flaps are commonly done. For ischial source, a posterior thigh provides many other options like bicep femoris based or posterior thigh flaps. For trochanteric sore, TFL flap is the most common flap used. Many designs are possible. For calcaneal, occipital and olecranon sores, surrounding or local flaps are mostly done. As far as recurrent pressure sores or multiple pressure sores are concerned, the decision making is as such. We will first see whether the fasciocutaneous flaps are possible, whether their previously done flaps are reusable or not. If they are reusable, we will use them. If they are not reusable, we will try to use underlying muscle flaps. If all these options are exhausted, then sometimes we may have to do extreme salvage procedures such as disarticulating the limb and using the thigh skin as a flap or total thigh flap. Post-operative care is extremely important. We must ensure positioning so that there is no direct pressure over the flap for 4 to 6 weeks. Hemoglobin must be monitored and it needs to be replaced if there is a bleeding. Fecal and urinary diversion needs to be maintained. Skin care, wound care, suction drainage needs to be maintained for prolonged period, and suture removal should be done late. Complications specific to flap surgeries include hemorrhage, seroma, infection, wound dehiscence in early phase, while flap breakdown or recurrence in late phase. Recurrence is not uncommon and it depends on a lot of other factors too. We will have a look at some of the cases. One of the patient with sacral pressure sore, which has been covered with a bilateral gluteus based VY design musculocutaneous flaps. Another patient with a sacral pressure sore. This is more so on one side. It was covered with a fasciocutaneous flap. The secondary defect was closed using transposition flap from the surrounding skin. A patient with right ischial pressure sore treated with a gluteal musculocutaneous rotation flap. We can see the probe showing us the extent of undermining. The X-ray shows the destructed ischial tuberosity. The excised ulcer with a part of bone can also be seen. Another patient with ischial pressure sore. X-ray shows the destructed ischial tuberosity. The first photograph we can see design of a VY based on musculocutaneous bicep femoris flap, and last photograph shows good healing at later date. A perforator based flap for ischial pressure sore. For trochanteric pressure sore, most commonly done flap is a tensor fascial lata flap. Most commonly used design is a VY advancement design. Here we can see in X-ray we can see the destructed trochanter, and excised ulcer with part of bone is also seen in the nearby image. A scalp rotation flap done for a post-electric burn defect. Even though it is not a pressure sore, the scalp rotation flap is similar in all the cases. Another scalp rotation flap. Some of the patients with pressure sores are not because of the position but because of devices or ill-fitting casts. This was one of such patients. He had developed lateral malleolus pressure sore, which was covered with lateral calcaneal flap. Another patient with cast-related pressure sore on medial epicondyle. It was covered using lateral arm flap. Inferiorly based pedicle lateral arm flap was done. Olecranon pressure sore treated with a pedicle flap from the trunk. All the stages of the flaps are shown here. This patient has multiple pressure sores, sacral as well as ischial. Bilateral TFL flap and gluteal rotation flap has been done. Thank you very much. If there are any questions, I will try to answer. In background, we can see the surgical steps.
Thank you, Dr. Chandrasekhar, for a good lecture on surgical management. I don't see any questions in the chat box.
No, there are none.
I think all these 3 lectures were quite self-explanatory.
We'd like to thank Dr. Ruke for conducting an excellent day session on Woundcon, and especially taking up a topic as mundane as pressure sores, which can often be a bugbear of many a surgeon. I thank the organizers, our President, Dr. Niranjan Agarwal, and Secretary Dr. Rajesh Yadav. Back to Dr. Milind Ruke. Thank you.
Thank you, Dr. Ruke, Dr. Agarwal, and Dr. Yadav. Thanks for a good session on wound care itself. Thank you.
Thank you for being with us today.
I thank
all the speakers as well as the chairperson.
I thank the chairperson, Dr. Samir Rege and Dr. Debashish Das, who have conducted this session very nicely and in time. I also thank the speakers, Dr. Viraj Thambevekar, Dr. Shailesh Ranade, and Dr. Chandrasekhar, to enlighten us on bed sore and its management in a very basic and nice way. I now like to take you to the session 8, which is the panel discussion, which is a case-based scenario, and we have our president of Mumbai Surgical Society, Dr. Niranjan Agarwal, who is a consultant colorectal surgeon, Bombay Hospital, Bokad Hospital, President Mumbai Surgical Society, President of the Association of Colon and Rectal Surgeons of India, Executive Board Member, International Society of University of Colon and Rectal Surgeon, Trustee Colorectal Foundation, Trustees Past President, Association of Medical Consultant, Chairman AMC, Major achievements are fellowship of the ACRISI, awarded International Traveling Fellowship in ACRISI 2009, member board examiner of FACRISI Fellowship, delivered many lectures at national and international conferences, many scientific papers and chapters and textbooks, organized many national and international conferences, basically a very dynamic and busy man. Our second person who is involved in this is Woundcon 2021, is our secretary, Dr. Rajesh Yadav, who is currently senior consultant HPB and GI surgery Bombay Hospital, honorary professor of surgery JJ Hospital Grand Medical College, secretary Mumbai Surgical Society, and EC member of IHPBA. 10 international papers, 100 national papers, written chapters for books, and he is MUHS undergraduate and postgraduate teacher. To participate in this discussion is, I would like Dr. Niranjan and Dr.
Rajesh
Yadav to introduce the speakers or the panelists in this session.
So, thank you, Dr. Milind Ruke. Friends, though we were running in time, I'm happy to see that we are just only half an hour late compared to the whole day schedule, which we have completed more or less in the time. And thank you all the speakers and chairpersons for ensuring that that happens in a program of this magnitude. A small hitch here and there, especially to net connections, etc. Half an hour delay is nothing much to be worried about. With this, I would like to call upon the panelist for today's panel discussion. That's Dr. Shrikant Bhoir, who is a general surgeon practicing in Borivali, and he is also an honorary consultant at Woundcon Hospital, North Mumbai, and Apex Multi-Specialities Hospital. He does a lot of diabetic foot work. The second panelist, next slide, please. Dr. Manmohan Kawat, our very own vice president from Mumbai Surgical Society, and he was the convener of this program and conducting the program today morning. He is a surgeon, robotic surgeon, endolaparoscopic surgical gastrointestinal surgeon, and head and department DNB teacher of general surgery at Nanavati Max Hospital. He is also attached to RN Cooper Hospital and owns his own nursing home called the Kamath Hospital. He is also an he was also an ex-professor at the CMP Homeopathy College. He is a visiting professor and examiner of law at the University of Mumbai, and you can read all the major achievements which he has had to his credit all along his glorified surgical career. The next slide, please. Rajesh, you want to introduce? Rajesh?
Muted. Okay. Our next panelist is Dr. Milind Ruke. Dr. Milind Ruke is a general surgeon and diabetic foot and limb salvage specialist trained in foot reconstruction at Texas, certified wound specialist of American Board. He is ex-associate professor, general surgery, diabetic foot and hyperbaric division at JJ Hospital, adjunct external faculty, New York College of Podiatric Medicine. He has several publications to his credit, and he has been practicing surgeon for 28 years, being a DNB teacher at Baba Hospital. Next slide, please. Dr. A.P. Suri, our next panelist, is MBB and CPP in podiatric at Harvard University, USA. It's fellow Temple School of Podiatry, USA, the diabetic foot specialist, president of Indian Podiatry Association, American Board certified HBOT physician, and podiatry department, Fortis, New Delhi. And our last panelist is Dr. Dhyanesh Madhukar Belekar. Dr. Belekar is professor and head of department of general surgery, is a coordinator for medical education unit and curricular implantation support program. He's members of several society. He's a chairman to institutional ethics committee at DY Patil. He has a Provost Award of Excellence in Teaching in Higher Education, and he has several international and national publications. He is MUHS recognized teachers for undergraduate and postgraduate. So these are our all fellow panelists for today, and Dr. Niranjan Agarwal and myself will be the moderators for the sessions. I'll start sharing the slides.
At this juncture, I would also like to put on record our thanks for our MMC observer, Dr. Ajay Bandarwar, who's been appointed as the observer for the credit awards from the Maharashtra Medical Council. And thank you, sir, for being with us. Rajesh, you can share the screen and initiate the discussion.
Are you getting the screen?
Just started.
Okay. So this is our Niranjan, are you seeing the screen?
Yeah, now we are seeing it.
Okay. So we start with the first case. It's a 67-year-old male patient with a known case of diabetes mellitus since 10 years. Now, the site of wound infection is on the calf muscle and right foot since 8 months. Now, the wound size was around 14 by 5 centimeter. The depth of wound of the calf was 7 centimeter. The wound size of the heel was about 5 centimeter by 2.5 centimeter. I'll show you the picture, and we'll begin with Dr. Manmohan Kamath. What would be the next step? This is the patient which has presented to us after 8 months time, and this is the wound position. So how will you go about this patient?
See, there are two wounds as I see post-traumatic. There is one near the heel as well and one on the calf. So whether they are two connected to each other or not, that is, I think, one essential thing what has to be ruled out if there is no tunneling in between. One. Second thing is, as we have been seeing so many, examples about the wound healing and other things, what is more important is, again, whether there is any biofilm formation, why this wound is not healing, the diabetes which is not controlled. So systemic correction of the diabetes, if at all it is uncontrolled, with the help of insulin if required, and taking any local infective cause of the bacterial infection, if at all it is there, about sending the wound swab or a culture would be very essential before we decide any further plan regarding the taking any action on this wound. However, being some slough which is seen on this wound, after all these basic things, after the debridement, which is the slough which is seen there, the good option would be in such cases, if there is no pockets which are there, to put in a VAC therapy would be, NWT would be a good option in such wounds. Thank you.
Anybody has a different opinion?
Manmohan, any other opinion? Would you like to have some investigation? The wound is for last 8 months. So
yeah, obviously investigation is a mandatory thing regarding the patient's nutritional status, finding out why this wound is not healing, in the form of whether the sugars are controlled, whether the anemia is present, whether there are any factors such as what is the low cause of the albumin which is there. So all healing factors which are responsible for all those investigations are essential in such cases. There is a muscles which are seen here. Okay, so you have a TLC which is 14,300, so fairly indicates that there is some amount of infection. Klebsiella pneumonia is a very difficult organism to treat. HbA1c 8.5, definitely this is not controlled sugars as such, and pulsations were palpable is definitely a good sign that the blood flow in this wound would be a good thing that indicates these investigations. Okay. So further going ahead, sorry.
Okay, can I put up anybody other than basic what?
Can I say something?
Yes. What else investigation would you want in such?
Investigation as such, I will like to do the MRI of this thing, leg, sorry, because there is a wound, it's secondary to trauma. It is not typical diabetic foot ulcer wound, and you must see the extension of the wound, because there is it is a depth. If you see the depth, it is going down up to the tendo-achilles. So if there is whether there is an infection of the tendo-achilles along the track, why the wound is not healing for that. You have to see whether the tendo-achilles is involved. If the tendo-achilles is involved, you have to open the
join the two wounds and then excise the tendo Achilles if it is involved. Then only the wound will heal.
Okay, Ganesh or Dr. Suri has to contribute.
The idea is good, sir. VAC is the first option. We should always go in for a VAC. And also in this wound, there looks to be both the wounds are connected from inside. It looks like that. So if we are applying VAC, we should put the foam just inside the skin margin between the two wounds and look at the tender Achilles. As sir has said that we should debride the end of the tender Achilles should be negative. Other thing is we have to offload it. We should always apply a posterior slab on this wound because if the patient is in the prone position or even in the supine position or on the lateral side, it would be touching on the margins. If you see the margins of the wound, it is hypergranulated because it's a long period of time, 8 months or so. So it's a hypergranulation on the margins if you look at. So that it's developing like a pressure ulcer. So we should put in a posterior slab just covering the upper wound also.
I'd like to add one thing.
Yeah, Danish.
All traumatic patients.
Danish, I can't hear you.
Can you hear me?
Yeah.
Okay. Yes. Since the patient is post-traumatic, would like to see the X-ray of lower limb along with the ankle joint for post-traumatic injury. So first and foremost, we need to rule out underlying fracture or any other injury.
Dr. Belekar, your voice is
not audible.
Can you hear me?
So you'll have to keep the tone as high to be heard.
Okay, can you hear me now?
Still louder.
Okay, what I was saying is we need to see at the X-ray of the lower limb and the ankle.
I'm sorry to interrupt, but your conversation is not being heard. You need to change some setting in your laptop. Just see whether your volume is maximum.
Earphone? Are you using an earphone, sir?
No,
he's not using an earphone. You can see that. Your volume is maximum. The speaker volume.
I'll just.
Hello.
Yes.
Okay.
Your speaker volume is maximum.
Yes.
Okay, just maybe.
Can you hear me now?
Okay, can I come in till Danish can adjust his volume?
Yeah.
Am I audible?
You can go ahead. Yeah, you're audible. You go ahead.
Yeah. So there are two things which are very clear, that there is a total count which is 14.3 and the HbA1c is raised. So first, the general things like starting a proper antibiotic and controlling the sugars is a must. But if your infection is there, your sugar will not come down. Now, if you see after 1 month also, this is the status of the wound. And if you see the upper part of the wound, there is already something like a fasciotomy which is either been done or there is a natural injury causing the fascia to split and the muscle to pop up. So I am sure there is something connecting there, and I think we should not do a half-hearted debridement as Dr. Ramakant or Dr. Bal said. We can open that incision completely up to the heel, open it, do a fasciotomy, give a good wash, see for sure what is happening, whether there is any infection underneath. Of course, what Dr. Boyar said, we have to do an MRI and then follow it up with this kind of fasciotomy. This would be my approach.
Okay. So, this is what was done. It was basically chronic non-inflammatory ulcer, and we had done a thorough debridement of both the wounds. And of course, VAC therapy was applied and daily dressings was done. This was at 6 weeks' time. One question to the panelists is, would you be interested when the pulses have been palpable, whether you want to do an arterial Doppler or something of that sort? Or
No.
you will go by a clinical judgment?
No, if the pulsations, peripheral pulsations are digitally palpable, I would not like to go for any Doppler study or imaging studies. One. Second thing is, I am not really in a favor, not to looking at this slide, but before that only about doing a MRI to begin with directly. a 8-month-old traumatic wound, a X-ray is good enough, I suppose. And secondly, if there are no foreign bodies or any bony injuries which are evident on X-ray, it's not really required to go in such patients. I really don't see any point about doing a MRI in such patients.
I would differ on this point, because if 8 months the wound is not healing, doing an MRI is not a big deal, because 8 months a trauma wound is not healing is not a simple thing for the patient. So if he has done so much of treatment, a MRI would definitely give us a good information about what is happening below, if there is a infection which is we are missing.
So Milind,
Because the
you want to
WBC
say
count
that
is high.
it can be osteomyelitis, because the fracture won't be, after 8 months, the fracture would have healed, I guess. So you are looking in the point of osteomyelitis involving the calcaneum. That's why you're asking an MRI?
MRI for soft tissue infection, whether there is a involvement of the tendoachilles tendon.
I think even sometimes there are collections which are deeper inside the muscle tissues which are not visible outside, and MRI will definitely help. Now, provided which setup you are practicing. Manmohan is doing this case in Cooper, probably he will get away with an X-ray, but Nanavati Manmohan, I'm sure you will get an MRI done.
Yeah, I mean, financial conditions always dictate. There is no doubt about that. But irrespective of that, I think stage-wise approach of the clinical examination, as you said, if there are some deeper pockets, I feel fluctuations, pus coming out from the deeper cavities, in such scenarios, certainly I will do. But otherwise, I don't know. I mean, I am not really convinced about the MR in such scenario where the wounds appear to be superficial. Of course, they are non-healing definitely, but the type of treatment what they have received in the past also carries a weightage and importance to take that into consideration with a detailed history of the patient, why and this thing was not healing, and why after 8 months also HbA1c is remained at 8.1 irrespective of the treatment what he has received, and the counts being 14,300. So possibly the patient has not received the appropriate treatment. That's what conclusion I can come to, before when the patient has come to me after 8 months of non-healing wound. So I would like to take a detailed history as one of the panelists or lectures we have been told, and then rule out the things one by one. And after that, yes, when it is totally mandatory or required, I feel then only I will think about the MR. But otherwise, as a primary investigation, I will not really go for it. And
so
clinical,
I would like to put it this way: the primary things such as controlling sugar, controlling infections, and maybe extensive debridement, everything has been done. And then after this is the wound which is there. Which of the learned panelists would now progress with either a graft or a flap, or they would still continue with some kind of local dressing in the form of wax, etc., to let the wound heal, or there will be some more plastic surgery intervention? What is the opinion of the house?
See, if you see, there are two wounds. I am not much concerned about the upper wound. If you see the lower wound, which is actually maybe creating a problem, there could be calcaneal osteomyelitis, there could be a trauma to the tendoachilles which has got infected and ruptured spontaneously. We have to rule out that before we do any kind of procedure on the patient, surgical procedure. And that is why MRI would be my choice, on the basis of which I would proceed for further.
Okay, point well taken. At this point, what would be the further line? You are seeing the wound getting granulated. Want to follow conservative, or you want to intervene at this point with some grafting or something?
after the 6 weeks, the picture what you have shown, Rajesh, is not really a very classy wound for any type of closure to offer. After 6 weeks also, if this is the position of this thing, it is not something which can be used for a flap or a primary closure or a grafting. The wound has not definitely granulated very well for taking up any of the definitive procedures in such scenario. And as Dr. Uke rightly said, that lower down the wound appears to be there is some type of exposed portion of the either of the bone, or something which is seen down there which is really warrants attention.
CBC will not only give
One of the delegate wants to know whether we'll do a bone scan to rule out osteomyelitis.
When you are not doing MRI, why is bone scan there?
Safe is to do an MRI.
Yeah.
The wound also needs some more dressings. It's not ready for any graft or any closure at this moment, as Dr. Manmohan has rightly said. Over in the upper wound, if you see the lower margin of the upper wound and the lower wound, here we see the posterior part of the calcaneal still exposed. So I think it needs some hydrogel with calcium alginate sheet or any foam sheet to be applied on the upper wound as well as on the other wound with curettage. With curate, we remove the biofilm. The shiny margins at the periphery looks like a biofilm. So removal of the biofilm with I think hydrogel gels with calcium alginate should be the gold standard for next 7 to 10 days of time. By the time the more granulation tissue develops, and then we can plan for a closure of this. And if there's no osteomyelitis, mainly at the posterior part of the calcaneal bone.
WBC count will not be only in indicative of the infection. There you must have the CRP or ESR also.
So this
WBC only,
patient
maybe most of the time WBC may be normal in diabetic foot ulcers. In normal range.
taken, this is the position at 8 weeks. Patient had been applied on wax, and this is the point at 8 weeks. So now, what is the plan?
Now on the lower wound again, sir, there's a lot of biofilm over here. Good point is that granulation tissue has developed, but it is biofilm impregnated. So should be curettage. Again, if we allow it for dressing, more dressing, and then plan for a, and you can see epithelialization is occurring. On the periphery, there's a margin of epithelialization with dead tissue. So peripheral debridement of this whitish tissue should be done, and removal of the biofilm should be the goal at this moment. Again, offloading is very important. We need to apply offloading pad here because if the patient is lying down in the bed also, it's the posterior part of the heel. It is going to touch on the bed like a pressure ulcer. So that pad with a good cotton bandage is mandatory in this one.
Move to the next
patient's movements. We see both these areas, basically whatever you are planning to do for the closure, obviously there is a down, there is a biofilm as rightly said by Dr. Puri. So that is definitely requires management. But both these areas are, if the patient keeps on walking, it's very difficult for any type of closure or technique to apply for treatment of these wounds, because both these areas will be mobility are going to be trouble. So patient has to be immobilized. Offloading has to be done for any type of definitive treatment. The upper wound appears to have granulated pretty well, and even if you put in anything like a graft there, that should take. Down there, the wound does not appear to be good. So that wound definitely would require debridement, the biofilm removal by any physical thing or by chemical agents, whatever one may use it, and then look at it to that at a later on.
Good. Point well taken. I just wanted to ask Dr. Milind, at what point, and looking at these two ulcers, assuming that the calcaneum also granulates well, so what type of cover you want to give, or you want to keep continuing dressing and wait for the wound to contract? Milind, did you get my question?
No, I did not get.
Okay, I said at what point you decide whether to continue dressing or to do a grafting like a cover?
See, as you said, the pulses were all good, and if we treat the biofilm that has been seen by doing a proper debridement and
we have done
and using a proper anti-biofilm strategy,
yes, all that is taken care.
If
So
the
at what
osteomyelitis
point
is not there,
you would decide to graft a patient, or you just continue dressing?
No, I would try to do
there
a
any
flap
criteria
if the
for that?
blood flow is good. If there is no biofilm osteomyelitis, I would try to do a flap after using a Haldol Doppler to cover the heel wound. If looking at the patient's age and he wants to walk later on, I think he's a diabetic, and if the blood flow is good, I will use a Haldol Doppler.
You'll do a flap.
Yeah.
I got it. Okay. Anything else you want to add? Because I think we have taken a lot of time on this case.
Move to the next slide, no?
Yeah. So this is the next slide. Now, the lower wound as well as the upper wound, there's been grafting has been done. And actually the photo is not really good on the lower wound side. And the grafting one was done after thorough debridement of the lower wound and the wound had granulated. So I just wanted to ask is at today's era with so many local applicants available, so is there any guidelines which say that a 8 centimeter ulcer or a 10 centimeter ulcer will definitely require grafting, and a 6 centimeter ulcer will be taken care by the local applicants, or it's not like that?
It is always the plantar wounds versus the non-plantar wounds. Like if you have non-plantar wounds which are not pressure bearing, you can, depending upon the patient's economic condition, go for the normal wound dressing. If they're large enough, you can give them an option of skin grafting. As far as the plantar wounds are concerned, the plantar skin is different than the other skin. It is thicker, it has got collagen fibers arranged in longitudinal manner with fat cells interposed to it. It's a special skin. It has got its own sweat glands, and this morphology has to be maintained for the ulcer not to recur, and that is why we use a rotation flap in that part, or a musculocutaneous or musculofacial flap, so that the patient doesn't get a recurrence. If you put a normal skin graft, he is bound to get a recurrence because of excess pressure in a diabetic patient.
Yeah, thank you, panelist. Niranjan, can you take the third case, please?
Okay. So here is a 60-year-old male who is a chronic smoker and a known diabetic since 10 years. And he had some injury to the right great toe. And within few days time, the whole leg is what it is. You can see over there, the whole leg has become red and it is like pre-gangrenous. The main complete gangrene was observed into only the great toe. The other areas were kind of pre-gangrenous. So this was worked up. Rajesh, can you move to the next slide? So you can see he's definitely got some infection there and an uncontrolled blood sugar. Obviously, for purpose of discussion to shorten it, we will assume that all the surgeons will control the infection, they will control the sugars. We will go into the surgical aspect, how to go about it in such kind of cases. Whether only a local amputation of the great toe and debridement of the proximal part would help, or you would kind of advise this patient for a complete below knee amputation at the first go. What is the opinion of the house?
See the first for okay.
One by one. Dhyanesh has been waiting to talk for a long time, so let Dhyanesh do the talking. Yes, Dhyanesh.
Yeah, the first and foremost important thing is to assess the vascular status of the limb. So by doing arterial Doppler, once the Doppler confirms the level of arterial ischemia, then one can actually plan the further strategy. There is a clear gangrene of the great toe, which can actually come off, and the remaining part can undergo debridement rigorously. But after assessing the exact level of the vascular supply and where exactly it is ending, without directly jumping into the below knee amputation.
Most of this arterial supply Doppler would show that there is generalized narrowing and of the blood vessel, major vessel, some atherosclerotic change. Would you ask for a DSA in these patients?
Yes, if facility is available with us, then we can subject the patient for a DSA, which would be a very good choice of investigation for the patient.
Janice, unfortunately, we can't hear you. Anybody else can?
Yeah, as the patient is a diabetic chronic smoker and his chances of having the atherosclerotic disease is very high. So patient must be subjected for MR angiography or CT angiography or a Doppler to know the vascular status, and depending upon that, then you can pose the patient for revascularization either by angioplasty or bypass, depending upon the where is the block as such.
By the time we work up on this patient, I think if hyperbaric is available, that would be a better option to save the dying tissue. Whatever amputation has to be there, either it has to be a midfoot amputation or it has to be a below knee amputation. But if you look at the pre-gangrenous stage, it is above the ankle joint. So we can at least save the dying tissue by hyperbaric for few days. By the time we work up with the angiography or Doppler, and strong IV antibiotics have to be given, covering gram positive and negatives both. It's showing Klebsiella. So that would be my option. And then if line of demarcation develops, that would be the point where you have to go for amputation.
What I am seeing is not only the great toe, but most of the foot is showing discoloration with some kind of demarcation developing. There is a shiny skin of the leg which shows that there is some kind of autonomic neuropathy also. So I would first try to palpate the pulses and clinically and see what is happening. I would also do a Doppler, and I would also do a TCPO2 at the demarcated line. Okay, what is the TCPO2 value? And depending upon that, meanwhile I get him worked up for the creatinine levels and go for angiography. I would give him, depending upon TCPO2, a trial of HbO2. If there is an obstruction which can be relieved by doing some procedure, I will do that if the TCPO2 is low, and then go for some procedure.
So would none of you debride him at the first stage, because his WBC counts are also very high? Obviously we can see that the grade 2 is completely gone. Whatever we are talking about, Doppler or angiography and hyperbaric oxygen, would that not follow after the amputation of the grade 2, or will you wait for the amputation of the grade 2 also?
No, see, Niranjan, I think that this patient requires, first of all, see, problem what happens is that one toe, or whether, it is gangrenous, you start removing, then the second toe, so multiple sittings of the patient may require to be taken up for this amputation. That is what generally keeps happening. You have, you amputate one toe, then second toe, third toe, then multiple surgeries, no patient agrees because it financially drains him and giving him false hopes. So I think it is must to know regarding the vascular status, as this patient has lot of high risk criteria which are about the vascular things which are there. So if we know that the vascular status is not good at all small vessels are affected, medium sized vessels are affected, then it is very unlikely that we will progress or get anything by just amputating the great toe or doing any debridement in such cases. If there are flow or vascularity which is seen, which is suggestive or which can be corrected, then in such cases certainly just the amputating that and major debridement, as we had seen in some of the slides of I think Dr. Ramakant had shown, if I'm not wrong, about the patient, a similar type of limb which he had shown about amputating a toe and then giving extensive debridement and trying to do the limb salvage procedures.
Absolutely,
So
that
that
is what
can
I
be
was
attempted.
exactly, that is what I was trying to get out. The take home message is to try and salvage the limb. You would probably first debride do an extensive debridement first, so that the infection comes down, because that is what is life saving also in this patient. His WB count is also high, and then try and salvage the limb. First is to salvage life, because with such kind of a bad infection, there is a risk to his life also. You can take the next slide, Rajesh.
Yeah.
No, that this we have discussed. You can go to the next.
The fourth case. Hello.
Yeah, Rajesh, present it.
Okay. So you want to conclude on that earlier case?
No, the take-home message was clear: to do
Niranjan.
an extensive debridement in the first sitting to salvage life first, and then work up to salvage the limb, if it is possible. I think in few sentences, if I am not wrong, I have kind of summarized the whole picture what everybody was trying to talk.
And Niranjan, you're right. If the life-threatening condition is there.
Yes.
If it is a wet gangrene, definitely we can add the
There is a
antibiotic,
wet
convert the
gangrene.
wet gangrene to a dry gangrene. But if it is a dry gangrene, you can always wait giving the antibiotics and then see the vascular status, then only you can decide about
Dr.
the.
Goyal, that was a wet gangrene.
It was a wet gangrene only.
It was a wet gangrene. It can be seen very clearly out there.
It's
Next,
a wet gangrene.
yeah.
Okay,
Next.
this is the next case. A 60-year-old man developed a neuropathic plantar ulcer on the right great toe after walking for a whole day. Now, how do you go about managing this patient? Doctor?
So basic X-ray would be the first choice to look at the interphalangeal joint and the distal phalanx. We can plan for an offloading, debridement, and tenotomy would be a better option in this case if the X-ray is okay. If X-ray showed osteomyelitis at the tip of the phalanx, okay, then we need to debride it and cut the tip of the phalanx also at the middle of the distal phalanx, because that will relieve the infection part.
Okay, so
and an offloading slab again has to be given.
For other panelists, if they have any other options like
offloading is important for a treatment, but yes, in such particular case of 60-year-old man with a neuropathic ulcer there with osteomyelitis, which is classically seen, I would like to rule out any tuberculous lesions if at all they are there. Any classical infective biopsy which shows there, suppose there is a tuberculosis which is detected, then maybe anti-tuberculous treatment would help in such wounds to heal to much faster. So you have to rule out, know about a specific infection if at all it is there. Anything offloading is by rule, I think, such type of patients for sure.
I see this patient as a neuropathic patient having the claw toes also.
Yes,
so yes. There is, and this ulcer is on the tip of the toe. Definitely, if there is osteomyelitis of the tip of the toe, you can remove the tip of the phalanx. But at the same time, you can also do the flexor tenotomies to make the straighten the toes.
Yes.
So here I would want to know from the panelist whether you can see a small area of osteomyelitis out there, whether you would just scoop out the sequestrum from there, or you would do an amputation of that particular phalanx, or try to do an conservative surgery in the form of debridement and scooping off of the sequestrum.
No, so phalanx can be saved easily. There's no role of doing amputation of the phalanx.
Absolutely.
You can simply remove the distal phalanx and this wound will heal. This is mainly a pressure sore. It's a neuropathic ulcer and it is
along with the flexor tenotomy, it will definitely help.
Yeah, with tenotomy, and in the offloading bar, in the offloading sandal, you can give a metatarsal bar covering from the first metatarsal head to the fifth metatarsal head. So that makes a wedge and the toe will not touch on the ground. He can walk in house or go to his bathroom and this wound will heal in a quick time.
So the evidence...
Rajesh, Dr. Suri wanted to share one case. If you can allow him after this case.
Okay.
I will also like to share one case. It's an interesting case. You will definitely like to know.
Let us, this particular case, being a neuropathic ulcer, we have heard about managing sugars, we managed the osteomyelitic part. I just wanted to know what are we doing for the neuropathic part. But basically, he has a peripheral neuropathy, I guess, being a diabetic for 40 years. So is there any specific treatment for neuropathy as such, or
treatment?
Yeah.
See, looking at this case, see, there is a lot of evidence. There are papers by and study done by Dr. Benjamin Lipinski, who was has done great work in diabetic foot. There is a paper by Luisa from Spain, which says that if you do judicious use of antibiotics with local resection in this kind of X-ray where there is a proper erosion of the cortex, local resection of that particular part of the bone with judicious use of antibiotics, then the wound starts healing. And as Dr. Boyer rightly said, the patient had claw toes. We can do a flexor tenotomy and we can give offloading sandal as Dr. Suri said. So all this together and sugar control will make the patient all right. And as far as neuropathy is concerned, we do not have we have medicines, oral medicines like gabapentin and pregabalin and methylcobalamin that we give. Some people are trying different kind of physical therapies, but the recovery of neuropathy is never fully. You can achieve 60 to 70% improvement in the neuropathy. But sugar control is the mainstay.
Thank you. So this was what was planned for, and this is what the case we had done the local debridement, and that's how the picture looks. So it's a completely wound healed after around 8 to 10 weeks time. So if Dr. Suri wanted to share a case, he can share his platform.
Okay.
You have to stop sharing yourself first.
Okay.
Can I share my slide?
Yeah. Check out your volume actually. Just not audible. Dr. Srikanth, meanwhile, you can just get your PowerPoint ready so that we can share your slides also.
It's ready.
I'll go to the case by using this. I have used this case with the acellular matrix. This was a patient who came to our center with a big abscess cavity over here, and the draining abscess was going on the posterior surface. There's about 2 to 3 inches deep tunnel over there. So I go inside, debrided the even the lower part of the tendon, and got the cultures done. He was on IV antibiotic. We gave them an offloading slab. He was in-house for about 3 to 4 days. TLC was in the range of 16,000. I covered him with initially with linezolid and tazobactam in-house, and later on we shifted to oral regime with linezolid and clindamycin. This was the calcaneal bone which has totally been exposed over here. Luckily, it doesn't have any signs of osteomyelitis. He was afebrile for about 2 to 3 weeks of time. twice VAC was applied, and subsequently we were able to have a good granulation tissue, if you can see over here. But the bones were exposed. My choice was to go in for a partial calcanectomy, the posterior part and the inferior part of the calcanectomy. So we took him inside, and then I said, okay, let me try with a dermacell application. So we debrided this lower part, which was all exposed. I curated it, and with the saw, I debrided the lower part of the calcaneal bone. And then we applied this dermacell over this, covering the whole part of the calcaneal bone. And then with the same sitting, we applied the VAC also. And we opened the VAC after 10 to 12 days. Unluckily, I couldn't get you a photograph over here because that was left in my clinic. So today morning, I prepared this case. But I was surprised to have a very good granulation tissue. The VAC is still on the patient. We have changed with the dermacell, and dermacell is still applied over there. And it is the staplers are also over there. We have not removed it. I would be preferring to apply minimum for 3 weeks, that is 7 days more, and then go in for a grafting. Even we can avoid flap on this if a granulation tissue or a dermal matrix develops on this wound. Because if you look over here, this was the all lower part, and this was when I started debriding here, but we were able to save the whole calcaneal bone in this case. So
Sir, there was no osteomyelitis?
No, we got the MRI. Initially, we got the X-ray done, and then we got the MRI done. MRI also a little part on just on the posterior caniculum. We could have some part in the MRI, but there was no abscess cavity, no fluid restriction, and there was no signs of osteomyelitis.
So in this case, when there is no osteomyelitis on the MRI, like this is what I feel is, instead of doing, you thought about partial culture, instead of that, if you can just do a drilling of the calcaneum at 3-4 places and then put a VAC, you will find a good granulation tissue coming out and covering the entire calcaneum. I have done a lot of cases like that.
You are right in this case, but I have done 3 or 4 cases similar like this by using extracellular matrix from other company and with dermacell. So I had the option of using this, and the patient could have afforded it. It was covered under his insurance, and we did this derma cell. But I'm happy to say the results. I can post you on your emails the result as I open up the VAC and show you.
When there is no osteomyelitis, it's invariably I had a couple of such patients where the exposed bones which are there and there is no classical osteomyelitis. The NW negative pressure therapy works pretty well to granulate the entire wound, and bone just gets covered without anything, and later on whatever required treatment, I mean further thing can be planned, but yes, it does cover exposed bones as well, and the granulation tissue develops over that.
Yes.
The problem is recurrence. If you put a split skin graft or any kind of thing,
yes,
patient gets recurrence unless you give him a good cover, which is fasciocutaneous or myocutaneous cover. So that is why if they have a good blood supply, we should, in these cases, which is a proper pressure point, if we can give him a flap, if he has good blood supply, it would be, for a long run, it will be a good thing for him.
Yes,
I agree.
That was my option also, because this is a totally a bare area, so there's no fat pad tissue left over. So even if we develop a dermal matrix, we can go in for a flap on this.
The ideal thing I would have been posted in this case to do a flap after the granulation tissue comes up.
Yes,
have been an ideal thing.
Dr.
Srikanth, would you share your slides, please?
Yeah.
Dr. Suri is done with.
So I have a similar case like this. Look at this case, sir.
Yeah.
Similar case on the this again on the lower part. This patient was driving on a motorcycle, and it is a burn injury. He got the burn injury from the silencer of the motorcycle. Totally neuropathic. He didn't came to know. His wife noticed, and then they were with some doctor, and they did the debridement. And when they came to me, we did the debridement. This is 2 weeks post debridement, and then derma cell was applied. Look at the dead tissues over here. At every sitting, we were doing the debridement, offloading with a posterior slab. The POP cast slab was given. This patient was mobile. He was walking in the house, and this was how the granulation tissue has developed over here.
Sir, you are very lucky. I should say you've got good affording patients to afford derma cell.
Yeah.
Well, if you look at this wound, and going over here, it was a miracle for this patient. I also told him it's good that you have been able to save that.
Sir,
I guess apart from derma cell,
start antifungal in this patient? Antifungal?
No, sir. No, I didn't try.
I would probably, yes, that's a bad wound, but I guess with regular dressing, apart from derma cell, it would have been granulated, because it would have taken time. But I shouldn't be that the derma cell is the only thing which would get him.
Yeah, no, I'm not saying that. That's the option. Even dressings, we have applied VAC. This granulation tissue is by the VAC only. Derma cell we applied over here. If you look at the end of the calcaneal bone over here, so it's little part of it is granulating over here. You see.
Okay. So, Dr. Srikanth, will you please share your slides, please?
Yeah.
Dr. Suri, you need to stop sharing.
Yeah, oh, yes. Thank you.
Manmohan, Sunday evening you are with a hospital cap on.
Can you see my slides? Can you see my slides?
No, not yet.
No, sir.
After the webinar, I will answer your question, Dr. Niranjan.
I'm feeling jealous. You're doing an emergency. Yes, Srikanth.
Logging in again.
I think we are at the fag end of the day. So far, we can see people praising us in the chat for a very good conference. If we stretch it too long, they will say अच्छा था लेकिन थोड़ा लंबा था, वो लास्ट में टॉक्सिक हो गया.
Niranjan, you want me to share the slides and finish? There are
No, I think
No.
let Boyers be the last slide.
Okay.
Enough of has been discussed today.
Okay. Good
Already
enough.
people have started leaving.
And we have throughout, I think we were seeing a lot of people, sharing their case presentations, and these things have been done. So
Can you see my slides, please?
Yeah,
Yes,
Dr.
yes.
Go ahead.
फुल स्क्रीन करू लागलाच नाही त्याच्यावरती. डॉक्टर भोयार, फुल स्क्रीन प्लीज.
Full screen. Yeah, can you see now?
Yeah.
Yes.
This is the 72 years old male, known case of diabetes, undergone BK amputation of the right leg, decided by the peripheral angioplasty. So the patient has presented with the ulcer on the left heel, and not ready for any peripheral intervention. On the examination, he has a severe neuropathy, dorsalis phase, posterior tibial not palpable, monophasic flow on the handheld Doppler, color Doppler, having severe peripheral vascular disease with the triple artery disease of below knee, all calcified arteries. ABI 0.6 suggesting the critical ischemia. Patient not willing for any peripheral vascular intervention or peripheral vascular investigations also. He wanted me to do save his foot without doing any peripheral vascular, because he said already after the angioplasty, if he has a right lead below knee amputation, then why to go for that? So I tried my best. When he came for the on the table, already there was extension of the wound, and after the two debridements, the tendons and muscles were exposed, but there were no signs of any redness or granulation tissue. This is after the debridement to vac dressings and irrigation vac dressings. So I was thinking that he may be definitely requiring for the below knee amputation. Then I come across with the collagen dressing. That is a application of the surgical. It is a bioabsorbable regenerative sterile type 1 collagen from the bovine source. Along with, I have started the weekly injections of autologous PRP and PRPFF. This collagen is applied, surgical collagen. After 25 days of application of surgical, I got a picture like this, where there is a, you can see the skin is started healing from the ankle side, but there is a still the slough on the periphery of this thing. So that time the KCI come with the VAC verapoclins therapy. This is especially for the COVID patient when they do not come into the hospital, and then you have to apply the VAC dressing for the debridement. So I use that verapoclins therapy, and after the verapoclins therapy, it has thrown out the slough bubbles, and then after again I debrided the this wound, and after debridement you can see the little bit of granulation tissue. On the granulation tissue, then I applied the Integra and VAC dressing. Separation of the silicone after 18 days, and then I got a picture like this, when there is a, against this slough is there, and it was a pseudomonas infection, which I have started with the local application, local dressings using the irrigation with the 2% acetic acid solution. Integra, you all know, it's a dermal regeneration matrix. It's a cell-free matrix, interact with the wound, releasing the growth factor. It is again made from the bovine Achilles tendon. It's a type 1 and type 3 collagen, and have
Why
the
did you
like
use the acetic acid one?
acetic acid for the pseudomonas infection.
There was a pseudomonas that.
Pseudomonas infection. So after once that was there, then I used again the Dermacell, because Dermacell has introduced the Dermacell first time in India, and they have given me free of cost. So no need to no cost to the patient. I use the Dermacell, and after Dermacell, and it continued with the dressings. So derma cell, you all know, is a human cellular dermal matrix from the human donors. It's a decellularized, and at least 85% of this is DNA is removed. It serves as a scaffold and reinforce the soft tissue and matrix over there. So this is after 1 month of the derma cell application, and after 70 days of derma cell application, you can see the skin is there is a red granulation tissue and the wound is healing well. And this is the final picture after complete healing after 5.5 months of the first debridement and 100 days after the derma cell applications. So now it is 3 months. This patient is walking with a prosthesis leg on the one side and special diabetic footwear like air cast with special insoles on the other side. Thank you so much. I have used all the bioabsorbable materials here so that I thought this will save his limb or foot without having undergo for the revascularization. That was the only option available with me. And I think it is the future for the diabetic foot ulcer management by absorbables.
So, Dr. Boyar, you have told us all about the case and till the completion how you have treated it. So, as a panelist, I would like to ask you one question.
Yeah.
Whether skin graft was done or derma cell throughout till the last healing?
Yeah, derma cell throughout the last, no skin grafting is done. You can see the normal heel skin and not a skin from the thigh or any other. So it is not a split skin graft. The skin has grown completely.
So, how many months follow up, sir, after the?
It is 5.5 months after the first debridement, 100 days after the derma cell application.
Very good.
How much derma cell you require and how much does it cost?
Actually, 5x5-inch Integra cost the 76,000 and 5x5 centimeter derma cell cost the same thing. But fortunately, as they were introducing into the Indian market, I got it free and used for this patient. So patient had no cost. So it comes to near about 78,000 for 5x5 centimeter of a derma cell.
Like I've seen Dr. Boyar and Dr. Suri use derma cell for such wounds. Like if this case specifically, if it is a critical ischemia, does derma cell, with your experience, increases the blood flow and develops granulation? What is the scientific evidence?
Yeah, I have used in.
Share it with the audience, please.
I have used in the another 5 cases, and in each cases, 3 cases were critical ischemia cases, and in that scenario, the skin healed completely. So I think the type 1 and type 3 collagen has a definite role, and bioabsorbable, along with that, I have given the PRP injection growth factors also has a definite role into covering in the diabetic foot ulcer management.
In spite of critical ischemia of the foot?
Yeah, the ABU was 0.3, and you can see that on the other side there is already amputation 2 years back for the critical ischemia. So you can see after 2 years of first amputation, on the other side how much will be the condition. It was 0.6 was its ABI. I am also surprised. Means you don't get the results like this in each and every cases. But
Rajesh, you can wind up, I think.
I think we are done with the times, and thank you all the panelists for today. Thank you, Dr. Niranjan Agarwal, and all my fellow panelists. We had a wonderful program today, and I would like to thank all our sponsors at the same time. Coloplast, 365, Torrent, and from the HOD, some Manoj Gupta, and I would like to thank Sun Vision
and JB Chemicals.
JB Chemicals. So thank you for all for participating in our program, and over to Niranjan Agarwal to have the concluding remarks and to.
So thank you, friend. I must appreciate. See, faculties were involved in discussion, so they could still kind of be involved. But the delegates sitting here right from 8 o'clock in the morning till 5 o'clock in the evening is something which is very applaudable and credible. And thank you all delegates who have been here till this. Your certificates of attendance will be shared on your email address shortly. It will be an e-certificate. And those from Maharashtra who needs that MMC credit point, we have got 2 credit hours for this, will be uploaded on the site of Maharashtra Medical Council. We would love to have your feedback. You probably will receive a feedback form for the MMC also. So please be honest in feeling that we want to learn more on what you think is right or wrong. Not only what we have been talking, and what is your experience in your setups. So please share us with your experiences, and please help us to improve the quality of the programs as well as the content of the program. What is needed by you, because it is your need which we are trying to fulfill in this pandemic. So please tell us what you want more. We have got a series of 6 such full day webinars to come up. The second one will be in the first week of August, which will be a program on breast and thyroid. The next will be a minimal access surgery or a complete day on a hernia. Then we have got one HPV workshop, which probably, hopefully, or we pray all that we do it in a physical manner at Bombay Hospital. And of course, my favorite proctology workshop at the end when we do MSS Con, and we hand over my baton to Manmohan that time. Apart from this, we will have one nurses training program for the nurses of the surgery nursing home shortly. And we are planning a very interesting program for the doctors on a doctor's day, which is 1st of July, so the Sunday next week, that is 4th of July. We'll have a program which is called Healing the Healers. So it will be a program based on the issues which are faced by the doctors, their what you call introspection, why we are facing that, and what are the possible solutions. We are trying to get the authorities on these subjects for us. And so be with us. Those who are not members of Mumbai Surgical Society, kind request all to become a member of Mumbai Surgical Society. It's numbers do count at times. There's nothing like there's no value to number. If somebody says, it is like residencies days में मैंने 10 हर्निया कर लिया, मैंने 10 लैब कॉल कर लिया, और कोई बोलता है मैंने 2 ही किया, तो number does play a game in confidence. So be a member. We can say we are a society of so many hundreds or so many thousands. It does strengthen our voice whenever we require it. So please become member of Mumbai Surgical Society if you are not one. And today, a huge thank to the faculties. The comments which were seen in the chat box were really very heartening to read. All the lectures, practically all the lectures were excellent and appreciated by all. So all faculties, thank you. It is because of you that we are getting all those nice comments, because of your deliberation. With these few words, thank you, and thanks to both my conveners who have done an excellent job today and made me proud. Thank you, everyone.
Thank you.
Thank you so much. Thank you. Thanks, Niranjan. Thanks.
Sorry, I must thank Swapnil and Swapnil from Vama Events. I would fail in my
Thank
duty
you very
because
much.
without his presence and without support from the Vama event, we would not have been able to do what we have done today. Thank you, Vama.
Yeah, thank you, Mama. Thank you.
Thank you, everybody.
Thank you very much.
I will end the meeting, sir.
Yes, thank you.